Check. Here it should come. Audio output here it should come. From here, if I am telling.
function in the heart study has shown that it to be one of the major predictors of cardiovascular disease beyond BMI is abdominal obesity. So again, intra-abdominal obesity is closely linked with abdominal obesity. So to assess the intra-abdominal obesity, the simplest measure is a waist circumference, which is a strong and correlated with the direct measurement of intra-abdominal obesity by CT scan or MRI.
నిమిషం మారుతుందా పారస్ ఫోటో నేను ఫోటో ಪಾರಸ್ ಮೇಲೆ ಡಿಜಿಟಲ್ ಆಗಿದೆ ಮಾಸು ಯಾವ ಮಾಸು ನನ್ ಚೆನ್ನದೆ ಯಾವ ಮಾಸಪ್ಪ ನನ್ನ ಮೇಲೆ ಓಡತಂಗ ಮೇಲಿಂದ ಅಂಜಿದೆ
Cardiometabolic risk, predominantly abdominal obesity, adipose tissues. So adiponectin has to increase, and there should be decreased lipogenesis. Then muscles, you have to increase the glucose uptake. The liver, decrease lipogenesis. GID, increase the satiety signals. Hypothalamus, decrease the food intake. These all are going to target and improve, reduce the abdominal obesity, thereby improving the risk, the chance of developing, reducing the risk of developing cardiovascular. The linked metabolic abnormalities, you all know, impact glucose handling, that is insulin resistance, atherogenic dyslipidemia, the small HDL and increased triglyceride, endothelial dysfunction, prothrombotic states, hemodynamic changes, pro-inflammatory states, like
फोन करता पिंकी रो इंटरव्यू कैंपस इंटरव्यू आसलेन तार गोटे कोट आ गोटे ड्रेस दरकार तू गुटे किन देबारे हम किन देबी तो मु आज जाउ एक्सप्लेनेट तक नेगी भी तक एक्सप्लेनेट रे मिलो ता कोट लेडीज को कोट मिलिबो ड्राइंग बागे के हां तो केनी हला मुंडा बनानी जाउ पिक्चर हम चाबिटा मु दे देबी अनि तागर
गुडी जाने जीवो पिक्चर
ग्रुप पिंकी
पिंकी जीवो
எடுத்து வச்சுக்கோ பேக்ல
Voice not audible. Voice not audible.
So, sir, just a minute. We are working on it. We'll get back to you.
Okay, thank you. Thank you.
கேட்கணும் நானு பேட்டரி இல்ல பேட்டரி எல்லாத்தையும் வீடியோ கேம் பண்ணி ஆமா கிளாஸ் இல்ல இல்ல எனக்கு நான் லீவ் போடுறது கான்ஃபரன்ஸ்க்காக லீவ் போட்டிருந்தேன். ஓகே நின்னுனே பார்த்தேன். பரவாயில்ல பரவாயில்ல. அங்க இருந்தா அழகா டிவில கனெக்ட் பண்ணி பார்த்தேன்.
observation. I found out that with the treatment of diabetic patients, we obviously are fasting in the postprandial period. Quite often, we find the postprandial to be less than the fasting. I would say often, mainly in certain clinical situations. So we always satisfy ourselves saying that the patient probably has eaten less or the meat-related insulin solution. One of the causes that I have found out, I have not published, but I have consistently observed is
always results in a slow, thyroid is responsible for rapid disposal, so the reverse happens. That's my theory. But whenever you encounter a patient whose fasting is more and TP is less, other factors even taken into consideration, if the patient has not been evaluated, this is my personal observation, not reported, because in the literature I did search. Maybe if some of you could search and then supplement.
My observation, type 2 diabetes mellitus, almost more than 10% type 2 diabetes mellitus, they are associated with hypothyroidism. And hyperthyroidism also there, 2 to 3 patients, 2 to 3% of the patients, always free T4, TSH. Along with that, please do rightly point out Dr. Sanmugam sir, TPO, anti-TPO antibody. Because Hashimoto's thyroid is initially hyperthyroidism, then it will become euthyroid, later on hypothyroid state, usually. So anti-thyroid, Hashimoto's thyroid, you need not treat with anti-thyroid drug. If the TPO is elevated, hyperthyroid features, don't treat. Just observe. Previously, they are telling steroids, after 14 days, it will come down normally. After that, definitely it will end up in hypothyroidism. This is my observation. Thank you.
Thank you, sir. Thank you.
I've seen a lot of patients who are on oral diabetic drugs. When they suddenly started responding very well, the patient is going for a CKD. And then the CKD, the insulin disposal comes down. I've seen the same in people who have been on oral drugs. They are undiagnosed with hypothyroidism. They come frequently with hypoglycemia. I don't know how many of you have seen that. Once we correct the patients with the thyroid substitution, then the hypoglycemia settles up. I thought thyroxine is one of the counter-related hormones. So one should remember, if you have a hypoglycemia, not only check the CKD, you also have to check the thyroid functions. Thank you. You've been a wonderful lecture, Sandarshan.
So that's a wonderful.
The insulin clearance is delayed in hypothyroid. That's why you get hypoglycemia.
Yeah, similar kind of thing like what we see in patients with the DKD, like the reduced insulin clearance is one thing that is happening with the patients with that's a very good clinical observation, sir. Thank you, sir.
Yes, sir. Thank you, sir. Similarly, the insulin dose also after the hypothyroid is corrected, they may require a higher dose. Before undetected hypothyroidism, they require a lower dose. Yes. So we go on to the next topic. Next topic is resistant hypertension. Resistant hypertension is blood pressure above goal despite the use of 3 drugs, which include a calcium channel blocker, a RAS inhibitor, and a diuretic. This must be used at maximum dose or maximum tolerated dose. Any resistant hypertension, we have to rule out 1, adherence part, 2, white coat hypertension. To talk more on this, we have Professor Dr. K. Kannan, who is the head of Department of Cardiology, Stanley Medical College. He is an interventional cardiologist. So over to you, sir.
Good morning to all. It's indeed a pleasure to start the morning sessions, and that too on a topic of great interest, resistant hypertension. I wish to thank the chairman, my colleagues, my friends who have come up in the morning to get the scientific material and enrich their knowledge with experience. Slide. Resistant hypertension. Now the definitions are, though the recommendations, the definitions looked at a patient who is now on 3 drugs of antihypertension, as the chairman said. Now the Braunwald looks at one more addition to the definition. So it's defined as a blood pressure that remains above guideline directed target levels despite the use of 3 or more antihypertensive drugs optimal or maximum tolerated doses and appropriate dosing frequency. So you need to look at the doses and the frequency too. And one of the agents has to be a diuretic which is appropriate to renal function. That is the addition which the latest Brownwall, the 12th edition, has added in the definition of resistant hypertension. The prevalence normally we say is about 10 to 30%, was normally is about 10%. And what is more important is this is a group which has got higher risk factors for cardiovascular and renal events. So whenever we see resistant hypertension, American College looks at resistant hypertension, there's a separate group where it includes patients who achieve target levels on 4 or greater than 4 antihypertensive medication, a condition that has been referred in literature as a controlled resistant hypertension. So the term resistant hypertension will refer to patients who are on controlled as well as not controlled, but only depends on the number of antihypertensive agents being used. So this is one addition the American has given us. So these are patients with, those patients we see with hypertension, about 12 to 15 are resistant hypertension, of which we have the control group is about 1/3 of it. So whenever you treat a patient with resistant hypertension, look at these 4 things before we really brand a patient as a true resistant hypertension. You look at an inaccurate BP measurement, you look at undertreatment, you look at white coat effect and the medication non-adherence. Because we see in our population that many of the doctors even do not, the recording of BP is not done as per the guidelines. So whenever you should know that going to the basics of BP recording is make the patient, you ask the patient first to empty the bladder, because even a full bladder itself can increase BP by up to 10 millimeters of mercury. And then you ask him to sit without legs being crossed, because a single leg cross can increase BP by 6 to 8 millimeters. And then you have a support of the back and the arm, because that also changes by about 10 millimeters. And then you should sit in a quiet room and wait for 5 minutes before the BP is recorded with choosing an appropriate cuff, which has a length of at least 80% and a width of up to 40% of the arm circumference. So placing the cuff directly on the skin instead of the clothing is one of the very important things which you measure, because that can increase even up to 40 millimeters. So, and then you take a minimum, you take 2 readings 1 minute apart. So they have the 4 categories of patients based on the office recording and the home recording. And so these are the 4 categories of patients we see. One, we see on the upper half of the patients whose BPs are more than 140/90 in the office recording. The lower half of the patients who are on the BP less than 140/90. And the left are patients who have a daytime BP recording of less than 135/85 and a nighttime recording of less than 120/70. We see the 4 categories of patients. The true resistant hypertension patients are in the left upper corner, where the office recording and the home recording both are high. And these are the patients who are the target of a talk. So this ACC looks at multiple categories in this, masked, unmasked, everything. So we're not looking too much into this. Let us make it very simple. To the left of the slide is a patient whose BP is controlled, and the right whose BP is uncontrolled. So a patient having, so if you see the number of drugs that are being used, if you are able to control a BP with 3 drugs, it becomes controlled hypertension. Whereas a patient is requiring 4 or more than 4 drugs to control the hypertension, it becomes a controlled resistant hypertension. If you take the patients who are uncontrolled, if you use 2 drugs, they're uncontrolled. If you use 3 and they get under uncontrolled, it becomes resistant hypertension. And those who have got more than 4 drugs and still not controlled, they become the category of refractory hypertension, which has got a different pathophysiology. So what are the 3 basic mechanisms of resistant hypertension? One is hyperaldosteronism. The primary thing is occurs in 20% of the patients, and you have got a sympathetic hyperactivity, which may be because of the RS activated. And both of this contribute to vascular inflammation and endothelial dysfunction. So why is resistant hypertension special? Because one, as I told you, you need to define the patients who are higher risk of morbid cardiovascular events and death. And these patients are more likely to have medication side effects because of multiple drugs that we use. And they're likely to have a secondary cause of hypertension compared to the other patients. And they benefit with a specific diagnostic and therapeutic approach. And then this, which contributes to the morbidity and mortality in these patients. So if you see the studies of resistant hypertension, in a retrospective study of more than 2 lakh patients, the resistant hypertension were 47% more likely to have the combined endpoints of death, myocardial infarction, and heart failure and stroke over a median of 3.8 years. In another study, more than 4 lakh patients, all the endpoints were more in patients who are resistant hypertension in the form of heart failure, heart attacks, cardiovascular mortality, and even ambulatory BP studies have also shown in this regard. So what do you do whenever you see a patient resistant hypertension? The first is to exclude apparent treatment resistant hypertension, which can be due to a white coat effect, a medicine non-adherence, or a therapeutic inertia on behalf of the doctor. So evaluation of secondary hypertension and most commonly primary hyperaldosteronism should also be conducted. And if you see the prevalence of apparent treatment resistant hypertension, most studies have shown is about 15%. So you do ambulatory BP is a very important part of the treatment whenever we approach hypertension. But if you see that 37.5% of patients diagnosed with resistant hypertension had ambulatory BP recordings changes, which shows a white coat effect. So home BP monitoring is another useful tool to look at these patients. The adherence of this to therapy is very variable range of 3 to 80%, 86%. So you use it in different ways. You look at the pill count, or you do a therapeutic drug monitoring, or you do a directly observed therapy or dose, or you do multiple measures to check if the patient is adherent to the therapy. The two things that you important to look for is a drug profile of the patients, because patients usually take multiple drugs and one of them may be interfering with the blood pressure. And whenever you find a drug which interferes with the blood pressure, that should be discontinued before you brand the patient as a drug resistant or as a resistant hypertension. So clinical inertia or therapeutic inertia is behalf of the doctors, because they're hesitant to go to the what is the optimal dose to the maximum tolerated dose. And so whenever you look at the prescription of the patients, you must also always see if the patient is on the right drug, is it on the right dose of the drug, is he on the right dosing interval of the drug, and is he taking the maximum tolerated dose or the optimal dose, and a combination is correct before we say that we really brand these patients as resistant. Obesity and obstructive sleep apnea are usually common accompaniments. And if you see the resistant hypertension group, in contrast, in usual patient, if you reduce 1 kg, you lose about 1 to 2 millimeters. But in this group of patients, the effect is more pronounced. And obstructive sleep apnea is also another disease which is usually associated with resistant hypertension. And CPAPs have shown a reduction in the blood pressure in the studies that have been done. So the 3 Ds of pharmacotherapy in these patients are: you look at drug doses, duration of drug action, and the use of a diuretic. You also look for the other things that the patient is taking, as I told, cocaine, amphetamine, other drugs which interfere with the hypertension. And you should always look for renal vascular hypertension as one of the secondary factors to induce hypertension. Pheochromocytoma, though, is quite rare, though it's usually discussed in all academic circles, and you should always remember even pheochromocytoma, 50% usually have sustained hypertension, and only 44% have episodic hypertension. So whenever you have a patient, this is how you should do a clinical management algorithm. First of all, evaluate a patient. You exclude pseudo resistance, that is most important, by taking out of hospital measurements, adherence, and also if you see that you counseling of the patient. Then you optimize the 3-dose regimen, the appropriate doses, frequency. And then you look at the secondary causes, comorbidities, concurrent medication. And once you rule that and it's still not controlled, then you are dealing with the resistant hypertension. Then you look at you emphasize lifestyle changes, because they're extremely salt sensitive. So the salt reduction plays a very important role in that in these patients. Then you optimize the treatment regime and add a 4th drug, preferably as an aldosterone antagonist like a spironolactone. And then if they are not responsive to anything, then you may have to consider intervention technology. So an approach to resistant hypertension is you give 3 drugs, then you consider resistant hypertension, look at the ambulatory BP, you roll out a white coat hypertension, and then you have a 2 resistant hypertension. You investigate for secondary causes, and then you add a 4th drug, just spironolactone. Look at ambulatory BP again, and if it's still a 2 resistant hypertension, you add a 5th drug, which is usually a beta blocker or a central antagonist, alpha agonist. And then if it's still uncontrolled, you brand the patient as a refractory hypertension and go in that angle. So what is the mechanism of resistant hypertension is, though it's multifactorial, a large body of evidence or literature implicates excess fluid as one of the retention as an important cause. The pathogenic basis is suggested by studies that they have found that if you give diuretic, intensive use of diuretic therapy has been the treatment modality for most of these patients. And Taylor has reported resistant hypertension is measured by thoracic fluid content as thoracic impedance indicator. So that has shown that the relative fluid excess in these patients may be a very important factor in contributing to the resistant hypertension. So in patients with resistant hypertension, those who have fluid retention in spite of a standard diuretic, you intensify diuretic by combining spironolactone with the chlorothalidone. And why do these patients have more fluid retention is because of the effects of increased salt sensitivity, the black rays, the small CKD, which is found in these patients, older age and obesity, and high rates of hyperaldosteronism and a high dietary intake. So these patients, all these contribute to resistant hypertension. Refractory heart hypertension is a distinct entity. In this, the sympathetic system plays a major role. So these group of patients who have resting heart rates are more, both in ambulatory and home recordings. And these patients, they have found that they have found an increased urinary excretion of metanephrine, increased vascular resistance index in pulse wave and velocity, and reduced heart rate variability have all shown that the increased sympathetic drive is a major one which holds resistant refractory hypertension. And this may be either cause or the effect. So whenever you treat these patients, we always look at non-pharmacological measures. As I told you, physical exercise, weight loss, absence of alcohol, reduction in alcohol consumption, the DASH diet, reduction in sodium intake, increase in dietary potassium are all important as far as stress management. Salt restriction, and compared to the normal persons who lose only about 6 to 8 millimeters with salt restriction in these group of patients, the studies have shown reduction to 50 millimole from 300 millimole has reduced up to 23 millimeters of mercury, which shows that extremely salt sensitive. And these group of patients, the restriction of salt should be emphasized on every visit. And the importance of weight loss in compared to the mean systolic BP, usually the 1 kg, you drop by about 1 millimeter. With these group of patients, they have found that the drop is much more. So modest weight loss with or without sodium restriction can prevent hypertension approximately 20% of these patients. So this may allow us to step down or withdraw the drugs. So this must be emphasized in each visit. So principles are heterogeneous. So the patients of resistant hypertension are heterogeneous from a pathophysiological perspective. With one group have just got an aldosterone excess, one group and there's increased fluid retention. And the concept of treatment should be based on what group we are dealing with. So a large group of patients have a low renin type. So the response to sodium restriction and escalation of natriuresis, that is the aim which you follow. But a small portion of patients have a neurogenic component, which we call as refractive hypertension. And these may benefit with a beta blocker as one of the cornerstone of treatment. So the important distinction between resistant and refractory is that when compared to resistant hypertension, refractory hypertension is more neurogenic in nature, where resistant hypertension is more volume dependent. And this observation will have major therapeutic implications because you need to, what you need to do for the resistant hypertension is to step up the diuretic. For those patients who are refractory, you need to consider a beta blocker, which is more useful in this group of patients. So whenever you treat patients pharmacologically, A, C, and D are the corner is what we start with. But in what we shown in the pathway 2 trial was that when spironolactone was compared to bisoprolol, beta blocker, doxazosin, an alpha blocker, and placebo, the maximum BP reduction was found only with spironolactone compared to beta blocker and doxazosin. And this control was achieved in up to 58% of patients taking spironolactone, 44% of patients containing bisoprolol, and 42% taking doxorubicin, which shows that the first line of drug after the third should be an aldosterone antagonist in this group of patients. The newer concepts in treatment includes the newer roles for SGLT2 inhibitors or fluoxetins, which are increasingly recognized not only as a glucose lowering as cardiovascular protection, but the BP effect lowering effect of fluoxetins, namely empagliflozin, has been especially pronounced with specific population of patients, only two groups, diabetics with lack of nocturnal dipping in BP and black patients with type 2 diabetes. In these two group of patients, these have been used in treatment of resistant hypertension. Device therapies by inhibiting the renal sympathetic inflow have been used in the form of renal denervation techniques. So the initial results were extremely encouraging with 20 to 30 millimeters drop, but subsequent have shown only a slightly modest reduction in blood pressure. Baroreceptor modulations have been done with the carotid receptors in 3 major studies. So the Mobius HD system is the system which is now in vogue, which has given about 20 by 24 by 12 millimeter reduction in the blood pressure, as you can see. So this is what is the more practical regimen which is now followed. You start with A, C, and D, go to the aldosterone antagonist, perform a 24 hours ambulatory BP, and then you document that there's a sympathetic component. The sympathetic component is there. You definitely use a beta blocker, or if not responsive to beta blocker, the refractory group, not responsive to 5 drugs, then you look for some device-based treatment. So this is a gist of my presentation. You see the left side, treatment-resistant hypertension. You're looking at treatment-resistant hypertension. First of all, you ensure compliance. You ensure that the lifestyle measures are taken properly, and then you'll investigate for secondary causes. And this is the therapeutic. You optimize diuretics. The potassium is less than 4.5. You add spironolactone, eplerenone, or amiloride. Whereas if the potassium is more than 4.5, you double the dose of a current thiazide diuretic or a loop diuretic. So whenever you see the first of these patients, this is step 1. Step 2, you go for adrenoreceptor blockers, beta blockers and alpha blockers. Beta blockers, the heart rates are good. And then you try the next group of drugs, but there's not much of evidence in this. Centrally acting drugs and vasodilators. And once these patients are not responsive, then you take them as a part of a trial. So this is the resistant hypertension. You look at 4 factors. One, you have the patient factors, the adherence, persistence, obstructive sleep apnea, sodium intake, and use of medicine that raise the blood pressure. The other hand, you look at the BP measurement techniques, which is very important, has been re-emphasized. You look at biomarkers. For example, you look at natriuretic peptides when you think that the fluid retention is more, or look at endothelin, or you look for actives. In such specific situations, you look for sympathetic activation markers. And then you look at the therapeutic constraints, is the pill burden and the hyperkalemia, which is a challenge in these patients. It's very important, friends. The conclusion I used to say, resistant hypertension has to be treated in a different way. The pathogenesis of the resistant and refractory has been clearly defined. And if you see many of these patients, they need to have a proper diagnostic workup and the therapeutic challenges, which has to be taken, which we see in our practice. And in spite of that, we have a group of about 3% of patients who are refractory to treatment, and these are the patients who are extremely prone for cardiovascular and renal events. So it's very important in our practice to look at high-risk groups in all parts of, in whichever field we take, and these are the groups which we really concentrate and work on. We can definitely contribute to lowering the cardiovascular burden in our country, and that is the aim of what this conference is all about. Thank you all for the patient hearing, and thank you.
Thank you, Dr. Kannan. He gave a very brief the treatment management and also the causes for the resistant hypertension. I think from the audience you will invite anybody's. Yes.
So particularly sleep is an important factor in resistant hypertension. Less than 5 hours is an important risk factor for resistant hypertension.
Yes, sleep disorders.
Particularly to avoid in this.
Yeah.
In resistant hypertension, before naming it, see that whether the patient has got any patient factor related to the hypertension management or the physician factor. That is more important. Sometimes one factor may dominate the other. Sometimes, both factors may dominate. But if you eliminate all these factors, then only you should come to the diagnosis that this is resistant hypertension. I want to ask only one question. See, even 10 years back, we had the same resistant hypertension drug. But the drugs are now much more potent. You feel that this incidence has come down after the new introduction of so many calcium channel blockers or the ARB or the CA or the diuretic chlorothalidone indapamide, etc. And device therapy, is it really possible in our?
It's only experimental. To be very frank with you, the incidence of true resistant hypertension has, if you see from the guidelines that we have seen, they have come down from 17 to 10 or less now. But the problem is, even these the auto drugs that we use in combinations and everything, now the SGLT2 inhibitors have also been added to the armory. So this is an ongoing struggle. The incidence may definitely come down, definitely. But to what extent has come down is difficult to say, because most of the studies have been done in 2000 up to 2017 only.
Excellent presentation. Now, when you suspect primary hypertension, will you routinely check the fasting plasma renin aldosterone ratio?
See, you suspect if you have hypokalemia with hypertension, you suspect. And then you look at the fasting, if the ratio is more than 20, then it requires further evaluation.
Someone said, no, the newer molecule, especially the acylindipine at that time, really gets the blood pressure very low, 16 milligrams. Diabetics, I think we need a lot of papers. What about the renal artery atherosclerosis, narrowing, causing the hypertension? Will you intervene with that?
Yes,
Can we do angio also look at the renal perfusion?
No, we can. That is why I told you in the secondary causes. If you rule out the primary hyperaldosteronism, the next is to look for renal artery stenosis. In the prevalence, that is number 2. So ideally you should do a renal angiogram, a CT or thing to document.
No, in congenital hypertrophy of the muscles, it's helpful intervention. But what about the patient developing a narrowing with atherosclerosis in a single renal artery?
So unilateral renal artery stenosis, generally even ACE inhibitors should be found to be useful. But the only question is, if you do an intervention of renal artery, there are 2 things. One, how long is there a recurrence of this? Because we see even in 1 year, the recurrence rates are about 30 to 40%. That's one. There is one group of patients who will really benefit. We have seen our practice also. We have done renal artery stenting for few patients. We did incidentally renal angiogram after a coronary angiogram, and we done angioplasty for them. They have done reasonably well. But how long this effect is sustained is difficult to say, because the high chance of recurrence of restenosis in the renal arteries.
Well, the major trials showed no benefit at all.
That's why it's because of the recurrence. Recurrence is very high, sir. Very high.
Very nice.
Thank you.
Just one thing, a practical point I wanted to say was, as soon as we diagnose hypertension, we or the patient automatically go on a low salt diet. So this hyperaldo is actually a lot more common than we think and we diagnose. Actually, Con has said it's as much as 1 out of 5. So first, when the patient comes, before they go on a low salt diet, we should measure their potassium. We won't miss some of these patients.
I think serum electrolytes should form one of the basic tests when you see any patient with hypertension.
அதான் சொல்றாரு, அவர் பேரோட சொல்றாரு. பிரியங்கா வந்து டெய்லி வந்து அவங்க போஸ்ட் போடணும்.
Giving me the opportunity of co-chairing also.
Thank you, sir.
சொல்றாங்க, 2 பேர் தான் சொல்றாங்களாம் போயிட்டு. அவங்க எங்களுக்கு போலன்னா கூட பரவாயில்ல, போஸ்டிங் நீங்க கேன்சல் பண்ணுங்க அப்படின்றாங்க.
Dr. S. Chandrasekhar sir and Dr. K.P.
கேபிஸ் ஆர்டர் பண்ணிட்டப்பா அப்படின்னாரு. போன் எடுத்ததுக்கு முதல்லயே. சரி, இப்ப என்ன பண்றது? போலீஸ் வந்து கொஞ்சம் ரொம்ப இது பண்ணுறாங்க. 6 பார்க்குறாங்க சார், அங்க இருக்கிற 6 பேர்
by Dr. Krishna. Is the director of Access Obesity Center, and we all know he is the current executive committee chairman for the 50th year total with the RSC, what we are going to have a action. He is going to come live from New Delhi. Over to Dr. Krishna. He is going to talk on the mitochondrial modulator. Is it a magical bullet? So it's a very novel way of people of very novel way of finding to treat type 2 diabetes because it's a inflammatory disease. The mitochondria is the energy regulated. So basically it's a disorder of energy and metabolism. So we are going to listen to Dr. Krishna on mitochondrial modulator. Over to Dr. Krishna.
Good morning, everyone. Can you hear me? Hello. Hello. Can you hear me? I would request all the people who are connected, please mute your mic because there is a lot of noise.
Just
please
a minute, sir.
mute your
Just a
mic.
minute, sir.
Yeah.
We are not able to hear you. Just a minute, sir. Just a moment. Sorry for the inconvenience.
No, some people connected are, having their mics on, so there is a lot of noise also. Who is Ritesh? Ritesh, please mute yourself. Hello. Yeah, actually, see, there is a lot of people who are connected on this Zoom. They have their mics on. There is a lot of music and noise going on. So, can you tell everybody to please mute their mic? You can tell the organizer who's handling the Zoom platform to close everybody's mic. Yeah.
Yes, sir. Yes, sir. Yes, sir.
Can you hear me now?
Yes.
Okay. Good morning, everyone. It's indeed a pleasure to be connected here virtually for this important meeting, the Cardiometabolic Congress being organized in Chennai. I would have loved to be there physically, but somehow.
I removed.
Am I audible?
SDMA removed.
Hello.
Yes, sir.
Yes.
We could hear you, sir.
Can you hear me? Hello, can you hear me? Okay. So,
This cable. This one.
at the outset, I would like to thank Dr. Chandrasekhar and the team for this cardiometabolic meeting, who have given me this opportunity to talk on a very important emerging concept, that is the metabolic modulators. I am going to share my presentation. Can you see my presentation?
Yes.
Hello?
Yes, sir.
Okay. So my topic for the day is mitochondrial modulators, are they magic bullets? I don't have any disclosures for this. So in this presentation, I will briefly talk about the mitochondrial function and structure, what happens when there is dysfunction, and what is metabolic inflexibility, and how does it connect with type 2 diabetes and metabolic syndromes, and what do we mean by drugs that are called metabolic modulators. Yeah, Dr. Chandrasekhar, can you hear? I am connected. Can you see my presentation? No. I have put up my presentation. I'm sharing my screen. Hello. Oh. And can you hear me also? Can you hear? Hello.
Sir, we can hear you, sir.
No, the person is saying they can hear me now.
You are not connected, sir.
Can see you also. Slide is visible.
Okay, shall I start? Not audible? Something at that side, because here it is showing fine.
Hello.
Yeah, can you hear me?
Can you hear us?
Okay, okay, fine.
Yes. Okay, sir.
So, as we face some technical side, we move on to the next talk by
This one.
Introduce. Good morning, and those that are very thank the organizers of this program and Professor Chandrasekhar for having the opportunity. Today, it doesn't interest in the slides. And great feature. And I've been working with him for the past almost 15 years. That's a some of our medical journal club in Chennai. Welcome, sir.
So thank you so much. Now, before my next slide, thanks Novo for supporting this program.
In your Zoom connect.
I think the integrated therapy has been a boon to diabetes.
In your laptop Zoom connect. In this laptop. Which one? Which flavor?
So the expectation for the clinician was we were taught that all the
this one, right?
a lot of importance probably
Take shortcut.
Yes, we address the secretory defect, but if you do have a molecule which enables the secretion of insulin only when the blood sugar is high, stop insulin production when the blood sugar is more or less near the target, address hyperglycemia, and maybe weight neutral and no hypoglycemia. Yes, I think this was more or less a wishful thinking or anticipation by the clinicians. Surprisingly, we were happy to have all these caveats addressed by the class of molecules, the incretin-based therapy.
And in the overall form, the DPP for me because enjoyed the reputation of being class of molecules, and now we graduate a lot of delegates. That's what we are discussing now. I think it has given enormous opportunity for the clinicians practicing diabetology to translate this mode of therapy to a huge chunk of patients. Because at the end of the day, being an economic ailment, we are always conscious of the cost effectiveness.
Audio.
Concomitantly, we realize that the GLP-1 is the main
Not required.
Is being able to survive for a longer time by the DPP-4 inhibitors. So, concomitantly, the GLP-1
WhatsApp, Zoom, Zoom I'm sending. Send me.
That is supraphysiological. Don't have the ability, does have the ability rather, to have an impact on the GI tract, the CNS, and the cardiovascular system. So when you have such a mode of therapy, obvious benefit
This one,
with respect to effect on obesity,
Short.
hypertension, dyslipidemia, etc. And surprisingly, we do have
Shortcut, sir. Shortcut, sir.
and probably some effect of the renal system as well. So the GLP-1 receptor
If forward me. My number is
entered the therapeutic scenario of type 2 diabetic subjects, of course, catering to a small subset of patients for the simple reason. Till the advent of oral sperma, because
Surface.
And the parents are major deterrents. Whenever as a clinician, determines that it is adequately among these two restricted the battery therapy in the past. The first has been taken care of by what I would call as a technological revolution by Novo. Because can we just imagine a peptide being administered in the oral form, it should be as effective as the parenteral form? Can Sanjay or somebody have the backup slides? Because mine, I think, it's a shortcut. I'm sorry. But yesterday I had the same problem in that computer. Subsequently, they changed the computer and it worked. It's another thought. So do I take? I think they have a. Do you have a backup with Sandhya and Srimati? Yeah. Is it allowed? Because they do have. Then we cut short my slide presentation probably because otherwise should not be bored. So coming back to the issue of the GLP-1 receptor agonist, so they do have an issue, and as advocated by the guidelines, the ADA and other bodies, GLP-1 receptor agonist should probably be considered. The next step that you have to obviously it cannot be enforced upon every percentage, it should be considered as the first injectable space in the type 2 diabetic subjects. Now, when we talk about this, 2 or 3 OHAs on board in a subject who has been having diabetes for close to 8 to 10 years. The fourth agent is unable to capture the basic HbA1c system point of glycemia. At this point of time, we always talk about basal insulin quite often, or at times even a co-formulation or a pre-mixed formulation, which means the prandial component has to be considered in the therapeutic armamentary condition. When we talk about the GLP-1 receptor agonist, both the components are addressed. So, quite justifiably, from the point of view of concept, GLP-1 receptor agonist could be viewed as the first injectable space, but as I told you, the cost of the therapy, as well as the parenteral mode to the oral sema, maybe probably was less comfortable for the clinicians to position it in a way that it has been. So, I think they did some magic. Thank you. So thank you, Noah, once again. I've been contracted by Noah to make this presentation. That is a disclaimer. Otherwise, I do not have any conflict of interest. I do not have any shares in Noah to do this presentation. Now, coming back to the subject, I'll try to run through. Now it's 11:55. Can I go on to 11:50? So we started with exenatide in the slower acting form. So that was derivative of insulin. The homology with native GLP-1 was less, but subsequently liraglutide, and other molecules have got good amount of homology with GLP-1. The message is, if a protein that you are going to use, like the GLP-1 receptor agonist, if the homology is closer to a natural one, of course the chances of immunogenicity is less. It cannot be 100% for the simple reason because the escape being neutralized by the DPP4, so the amino acid substitution in the 8th position is there, and then there is an interesting substitution at position 34. Now, yet another technological marvel of Novo is, be it degludec or detimar or whatever it is, whenever or liraglutide, the prolongation of the action of the molecule is enhanced by the fatty acid side chain. So this has been probably very successful and quite handy for Novo to see to it that the duration of action of the molecule is long. So you have this spacer with the fatty acid side chain so that the renal elimination is long, because mind you, even though the oral semaglutide is there, the absorption is not very optimal. We are trying to do certain things to maximize the absorption of this polypeptide in the oral form, which we will discuss in the next slide. So the minimal amino acid substitutions: 1, to escape degradation by the DP4. Second, to prevent the wrong attachment to the spacer and the fatty acid side chain, which are absolutely required to prolong the action because of inhibiting or decelerating the renal payloads. This is what I talk about as a technological revolution. We never imagined, like I talked about, a possible molecule in the oral form having a physiological effect with respect to insulin secretion, inhibitors. Never could have imagined a polypeptide can be administered in the oral form. So we know that it is destroyed by the gastric juice and all. So you have the participation of this SNAC protein. What this SNAC does is quite amazing. When you co-administer semaglutide with the SNAC creates a local environment of slightly alkaline pH. You know, the acidic pH of the stomach destroys or is not favorable for the absorption, it is being destroyed. So locally, alkaline pH is created so that the access to the destruction effect of the gastric juice is not there. And very concomitantly, there is a facilitation of absorption across the intestinal epithelial barrier, as you see on the right side. So a twin job is done by this SNAC protein, which it's a revolution in technology, and that has enabled this class of molecules, the GLP receptor agonists, which have got benefits beyond just glycemia and consistent beneficial effect with respect to hardcore cardiovascular endpoints, primary MACE, and also sometimes components of primary MACE like CV death and stroke. I think the stroke benefit we have consistently seen across the board with the GLP receptor agonists. But fine. This science is good, it is quite strong, the evidence is there, but it's a parental form. So to accommodate all these attributes, favorable attributes, and pass on the benefit to the clinical scenario, I think the oral form becomes so handy, and that's where semaglutide is there, thanks to this SNAC technique. Only thing is, there are a few precautions. It has been taken in empty stomach in about 120 ml. Why not 150 ml? 150 ml probably makes it a bit dilute, so the absorption may not be good. Already we are dealing in a situation where the absorption is suboptimal, given all the limitations of the oral form of therapy. And second is, it should not be less than 120 ml also, because the side effects could be more. And then we take it, maybe Usha is there, she will elaborate on. There is a certain amount of increased thyroid exposure. What I do is I will position the thyroid in the previous evening. Otherwise, I believe there could be a 25% reduction in the thyroid dose if there is going to be. Because Chandra gave a beautiful lecture on thyroid disease and diabetes about half an hour, 40 minutes back. And then starting dose is 3 milligram, but most of my patients, especially when you switch over from already a clinical form like liraglutide and dulaglutide, you can straight away start on 7 milligram and then go on to 14 milligram if it is required. We discussed very briefly about the performance of this molecule with respect to glycemia, non-glycemic benefits, and also touch upon the cardiovascular benefits and the renal benefits before I conclude in the next 15 minutes. I've been given time to 11:15. So this is the pioneer peptide innovation for early diabetes. So we're not going to go into the data details, just to highlight that this molecule has been tried in a wide spectrum of type 2 diabetic patients, right from monotherapy compared to placebo, on top of metformin compared with an SGLT inhibitor. And quite interestingly, it has been tried with liraglutide, a GLP receptor agonist, on board with 1 or 2 oral agents, metformin, SGLT2, and also on board with insulin and special populations. And Pioneer 6 is the cardiovascular safety trial. The disease slide, the message is oral semaglutide in 7 and especially 14 milligram is effective across the board. It is so effective that it has got a significant HbA1c reduction even with liraglutide liraglutide in the parental form. So this is amazing because we know among the class of GLP receptor agonists, liraglutide 1.8 has always been viewed as the most potent GLP receptor agonist, probably even better than that is dulaglutide in the 1.5 milligram dose that is being recommended from the weight reduction. And HbA1c is called. So you look at the HbA1c. The HbA1c is, as expected, significantly better than your DPP-4 inhibitor, SGLT2 inhibitor. It is also better than liraglutide. And lower down, look at the body weight. The weight reduction is, you have molecules like the SGLT2 inhibitors which also result in weight loss. So the weight reduction is better than, significantly better than mTOR, and it is at the end of the study incident better than liraglutide. And look at the column on insulin. On top of insulin, if you're going to achieve weight reduction, I think that attests to the true weight-losing nature of this molecule. Now, I would like to dwell upon a couple of points with respect to weight reduction. How does this molecule cause weight reduction? For you to have a weight reduction, you should have negative balance. So whether it is promoting a negative balance by promoting energy expenditure, yes, it is speculative, browning the adipose tissue. There are some soft evidences, but probably what is more significant is maybe it crosses the blood-brain barrier, because this we prove with Scc as well as liraglutide. They are smaller molecules. They cross the blood-brain barrier. Even if they do not cross the blood-brain barrier, by the GI effects, by the distension, by the inhibition of motility to an extent that causes a deceleration of GI motility, the vagal afferents convey the message to the. This probably is what's up in most of the molecules. So either they cross the blood-brain barrier, or if they are not able to do by the size of the molecule, like aldehyde is one of the biggest molecules. Like these molecules, maybe indirectly through the vagal afferents, they give the signals to the hypothalamus, having an effect on the satiety center. I think this we have observed. Whenever a patient is on GLP-1 receptor agonist, the appetite is not good. In fact, some of those good eaters, since they would like to have some fried with the non number or a mutton korma, they are not able to exceed 3, 2 or 3. It produces a nausea. So I feel that is probably the major factor. Of course, it does have a predominant effect on the comorbid conditions like hypertension, dyslipidemia, and inflammation, which we'll see shortly. So, a molecule in the order form of GLP-1 receptor agonist, good efficacy in the metabolic neuropathy of HbA1c reduction and also the weight reduction. So the first extra glycemic benefit is a robust weight reduction to the tune of almost 5 kg in some of the studies, comparable, if not even better than molecules like the empagliflozin as well as the liraglutide. You can always say, whenever you have a baseline HbA1c, the reduction HbA1c is there for all molecules. Yes, agreed. But look at it. This is much better, even with respect to baseline HbA1c. Some of the molecules where the data are available, even liraglutide is available, thanks to the background music that adds flavor to the presentation. So here, if you look at the data, the reduction HbA1c with high baseline HbA1c, which is expected of all the molecules, even better with oral semaglutide. So, as usual, with the incretin-based therapy, the risk of hypoglycemia by itself is less, whereas in top of molecules like SUs and insulin certainly it will be there, and we can use various stages of hepatic, etc., with respect to the safety issues. And these are some of the data which should motivate the clinicians to patronize these type of molecules, in spite of the fact that it will probably be a small subset of patients given the cost of the therapy, because 50% of people are out of target. And the recent landmark trial has, this is in India, it's yet to be published, almost 78% of the subjects are out of control, and there is associated with 1% reduction which you learned from the UKPDs, etc., etc. So putting these two together, good chunk of type 2 diabetic patients are out of control. Some of them could be candidates with respect to the profile of this molecule suitable for initiation of the GLP receptor agonist or activation as an add-on, and it should be considered for the benefits that we have already seen with respect to. This is just to re-emphasize the HbA1c reduction, which is quite robust to the tune of about 1.5%. So whenever we talk about the ADA recommendation that GLP-1 receptor agonist should be the first injectable space, at that point of time, all the similar available when this guideline is there. But the simple reason we have robust molecules with respect to HbA1c reduction, of course, not to mention about the extra glycemic benefits as well. So in patients with HbA1c more than 9, certainly it is 2.6%, and on an average about 1.5% reduction. What about the impact of obesity? I think there have been some elegant data with respect to obesity, which we have tried to visit and revisit after the advent of molecules like the SGLT inhibitors, because even though we have appreciated the association of obesity with respect to worsening the cardiovascular risk factor in the diabetic population, and also how difficult to control the diabetic patient overweight or obesity. So some of the endpoints, like your stroke, coronary artery disease, how they are impacted when the patients are obese. And here, 5% weight loss is able to have a significant effect on the metabolism, so that you can de-escalate the background medication therapy. That is number one. It is able to address hypertension and dyslipidemia. It is able to have good effect on heart failure. In fact, there are some meta-analysis. They look at all the data right from your the trial with rosiglitazone, levetiracetam, and ADOPT study, origin trial, and you have the Bariatric. All the trials which are very enhancing have been associated with an increase of heart failure and worsening of risk factors. So, treatment associated. Number one is pre-morbid obesity or overweight. Treatment associated weight gain. In this context, to achieve a 5% weight loss is quite significant. We are not talking about 10% and 15%, which we associate more benefits like fatty liver disease and then your reversal of diabetes, etc., etc., and OSA. There is 5% is adequate in the pharmacology. I see Dr. Oman here. I think much more about heart failure will learn from you in the next presentation of yours. So, what's the proportion of subjects who achieve more than 5% of weight loss? Previously, we are talking about the 5 kilogram of weight loss. Percentage of subjects is almost 3 times more than the placebo. And that is with respect to the performance of the molecule and the magnitude of the endpoint that they have achieved with this molecule in the oral form. Now, this is with respect to the body weight comparison with other molecules in the context of the weighted effect. This is a small study, but the message is quite important. I love when we did because how they did it. This is the air displacement plethysmography. The compartment of the weight loss that is accomplished with oral semaglutide is a fat percentage to -2 compared to the placebo and also of course the body weight. So whenever you lose weight, it has been linked to the adipocyte or the fatty tissue compartment. I think this is unique both for the SGLT2 as well as for the GLP-1 receptor agonist. And elegant studies, even though numbers will be small, should assure the clinicians that the loss of lean body mass is not significant enough. Because when you talk about the weight loss in a crude form, it includes the lean body mass weight loss, which you do not prefer in many of our patients. And of course, comorbid condition like hypertension, we know the anticipatory hypertension, the 4% patient, we had an excellent talk on resistant hypertension, but Dr. Khan recently. So hypertension, its impact. And look at the other side. You all know the association. Once you interfere, the 5% decrease in the hypertension because this molecule is associated with a 5 millimeter reduction. 5 millimeter reduction might look trivial from the point of view of the readings that we do encounter in the day-to-day practice, 170 by 104, etc. But it is associated with endpoints which are significant in this day-to-day practice. It is oral sema reduces blood pressure to the tune of about 5 millimeters, and the impact it has. GLP-1 by itself has got the capacity to modulate the ApoB48. I think what there is number point. ApoB48 is responsible for incorporation of dietary lipids and send it via the lacteal system through the portal circulation to be taken up by the liver as chylomicron remnants after being acted upon by the lipoprotein lipase. Now, at the point of entry at the level of the gut, the ApoB48, its level is determined by the GLP-1. Good amount of GLP-1 discourages more of ApoB48. That's why you have a good amount of reduction in the triglyceride level, and triglycerides in the context of cardiovascular disease, I'm sure Dr. Narasimhan is there, he has got much more data with respect to the triglycerides as well, which is probably was sadly neglected by counterparts in the West, but we have always given a lot of importance to triglycerides with respect to cardiovascular disease, not only pancreatitis. So this probably is one of the key mechanisms, and subsequently it helps the weight reduction might probably improve the lipoprotein lipase activity, so that at the end of the day you have a good effect on body weight, reduction in the blood pressure, reduction in the lipid parameters, and we have understood some of the mechanistic reasons behind how this could be accomplished with the GLP receptor agonist in particular, in oral sema, in general oral sema in particular. Diabetes is a metabolic and vascular disease, as Professor Sanchiti Moses put it, and you can add it as it is a chronic low-grade inflammatory disorder perpetuated by the adipose tissue. So you reduce the adipose tissue, and also independently markers of inflammation like HSCRP are favorably impacted by oral sema, and evidence in this particular study comparison with empagliflozin. And Whenever you have the data, the pioneer 6 we'll see very shortly. Extrapolating it, you can say that the mean absolute CV reduction is 6%, and when it comes to an individual patient, you're postponing the advent of a CVD event to the tune of almost 2 years, which is, in my opinion, quite amazing. And as a class, I think the GLP receptor agonists have got a much more powerful impact, favorable impact on the cardiovascular, atherosclerotic cardiovascular disease than probably the SGLT inhibitors, because the mechanism is in such a way, you see the effect after 1 to 1.5 years, whether it is from liraglutide or dulaglutide, it's not immediate that we are SGLT inhibitors. So heart failure and CKD certainly SGLT inhibitors score over the GLP-1, whereas with respect to atherosclerotic cardiovascular disease, I think the GLP-1 score over because it is a consistent benefit that has accrued out of this class of molecules. So before I conclude about the cardiovascular outcome trial, Pioneer 6, good trial with about 3,000 subjects, and look at the retention rate. It's about the 99, almost 100% retention. That's amazing. Even though the duration was about 1 year and 3 months or less than 1.5 years, the events that was anticipated was exceeded. So it was non-inferior to a placebo, that means it is safe. Whether it is superior, it will be answered by the subsequent huge study because, and as I told you, the endpoints, cardiovascular death, one of the endpoints of the primary is has been found to be favorable for empagliflozin, the SGLT2 segment, and for liraglutide, if I remember right, and also for the oral semaglutide. Of course, the sustained-6 with the injectable sema also address this. Of course, this is non-inferior study, even though it looks like an apparent significant, it was not intended to be so, but it's a good message to the clinicians. You might turn around and ask, yes, you have given the theory behind the absorption of the polypeptide being facilitated by the SNAC protein, but still, is it as effective as a parenteral form, subcutaneous? Yeah, you have the data here, wherein the HbA1c reduction has been compared to the level of semaglutide achieved with parenteral as well as oral semaglutide. You see the response, it is the same. So this is just pulling of the data of sustained 6 and the Pioneer 6, the same molecule, one in the parenteral form, the other in the, probably this was looked at non-inferior study, so the superiority was not there. Maybe the number of events was not, because the duration was 15 months only. Maybe the sole study, which is attempting to look at a greater number of events, might throw a positivity. So this is with respect to the pooled analysis outcomes, the effects are favorable. And then this is a consistent benefit in this class. I think where it probably scores over the SGLT with respect to the stroke benefit. So with respect to stroke, I think you have a consistent benefit to the GLP-1 receptor agonist, and the natural process of decline in the EGFR is certainly interfered favorably by the oral sema in this, I mean, by the oral as well as the parenteral sema in this cumulative data, about 6,000 subjects over a period of 2 years, which is quite important. You may not be a CKD modifier or a disease modifying agent like the SGLT inhibitors, but certainly they do have a favorable contribution with respect to decelerating the patient's disease. So, to sum it up, we do have a molecule in the oral form, a technological revolution, wherein the benefits of the GLP-1 receptor agonists, the clinician has a scope to pass on the benefits to our patients. Do you have the data? The data are there. They have been tried with extensive entire spectrum of type 2 diabetic subjects as monotherapy and on board with the other molecules. Comparable, if not even superior, HbA1c reduction with molecules like sitagliptin, empagliflozin, as well as liraglutide. The weight reduction is amazing to the tune of about 5 kg, and good number of subjects are able to achieve a 5% weight loss, which is the benchmark for some of the favorable endpoints like modification of the cardiovascular risk factors, and then de-escalating the dose of anti-diabetic medication, etc. You have the cardiovascular outcome data, which shows it is not inferior to the placebo. And if you combine the data of the Pioneer as well as Sustained 6, you have a lot of exploratory points. Besides the favorable effect on the cardiovascular risk factors, information is also all put together, and maybe some unidentified mechanisms give this molecule a profile worthy of patronization in a good chunk of patients. Thanks for the opportunity. I'll end here. There are some more slides. Maybe we have some discussion.
Thank you, sir. So, what about this effect in normal weight and underweight patients?
Yes, in fact, that particular segment was introduced, since the topic was oral sema, I didn't talk about it. Injectable semaglutide in 2.4 milligram doses has been tried as an anti-obesity drug, and the results are amazing. Probably might have the sanction to introduce this molecule in the near or the distant future. Yes, not the oral sema, but the injectable sema in 2.4, it has been found to have a wonderful weight reduction with good amount of tolerance, and the study was there, which is called SELECT study, if I remember right. And this is also being tried in patients with as a supplementary therapy to prevent heart failure. For the simple reason that the weight reduction that has been achieved with 2.4 milligram of injectable sema is quite supreme. So it's being promoted. It is the information that infancy, at least in the context of the Indian population, might soon we can have a recommendation. Just like is available.
Normal weight and
As it is not recommended for a weight reduction, but injectable 2.4 milligrams is recommended for a weight reduction, but not yet approved in India. This applies to all the molecules. The weight reduction, when I say 5%, depends upon the baseline weight. So we not be unduly worried by exhibiting this molecule to, of course, not very emaciated patients, but non-obese patients also can be, because it is proportional to the baseline weight. Varnaman always asks this.
Thank you, sir. Great presentation. Music presentation, you have a lot on the talk, but I'm very happy about the point that snack protein supposed to locally alters the gastric pH in the heart. It thereby improves absorption. So wonderful point. That's a new technology. It's innovative technology. But what might is, can we apply the same principle for oral insulin? Because again, insulin is being destroyed there, and if we have such alternative, very good. And the second doubt is that, and this of course, with this oral semaglutide, it brings down the weight apart from the anti-diabetic action. So will it have any effect on gut microbiota? So because the gut microbiota is the one which determines the weight. If you take the microbiota of the thin individual, you put it to the obese individual, the obese become thin. You put the microbiota of the obese individual, vice versa. So if that is the case, since being the hormone which is secreted in the intestine, we are going to alter it. Will it have any effect on the microbiota, which is maybe responsible for the weight reduction apart from the glucose control?
They told you always ask the questions. Anyway, whatever I have learned, I'm trying to answer. Number one is insulin. See, with respect to the oral semaglutide, in spite of this technology, the absorption is very poor. That's why you wait for a week or two for it to have a steady state, if I understood it properly. Whereas with respect to insulin, with respect to basal insulin, it's applicable. Whereas with respect to the prandial component, you want the insulin to have its effect on that particular day at that particular meal. So I'm sure Biocon and other people who have been in the job of introducing oral insulin in the job for decades together have not been able to find an answer. I'm sure SNAC would have been tried. So maybe other possibilities are being tried, but this has always been challenged to convert it into reality. But one thing that has converted reality was inhaled insulin. For which I have done the trial in a hospital. It works. It works. When you inhale insulin, Lispro was tried. But that effect was observed by probably less than about 20 or 30% of the insulin. The remaining 70% gets trapped in the interstitial tissue, and that has been linked to some malignancy signals. That is why it has been abandoned. So the oral insulin still is evasive. Inhaled insulin was there, but maybe because of the signals with respect to the malignancy, it was abandoned. And to the point of view of a basal insulin is such type of a snack protein or a similar absorption enhancer, whether it could be, maybe the future will answer. With respect to the gut microbiota, I'm not too sure about the data, but it is speculated that probably whenever you have a mechanism like your alpha glucosidase inhibitors or metformin, they act in such a way they enable the undigested food or partly digested food reach the intestine. There they have the scope for elaborating a GLP-1 with subsequent effect on the gut microbiota also. Whereas with respect to the molecules like this, I'm not too sure. Maybe it's a good food for thought. if you have access to the literature, there could be some data with respect to our method. Please share with me. Thank you.
Thank you for the nice talk, sir. It's very wonderful. We learned a lot from this. Thank you.
Thank you. Thank you so much.
Thank you, sir. Dr. Makkar will be joining us in the post-lunch session. We move on to the next session. Over to the next session. For this to chair this session, may I now invite. Thank you, sir. Thank you very much, sir. Dr. Namita Narayanan and Dr. A. Gavishankar to chair this session.
Good morning. First of all, I'd like to thank the organizers, particularly Dr. Chandrasekhar, Scientific Committee Chairman, for giving me this opportunity. First talk is by Dr. Abraham. We'll be talking about newer oral anticoagulants, an update. Direct thrombin inhibitors, first approved in 2010 by FDA, later factor 10A inhibitors. Their advantage over vitamin K antagonins will be discussed by Dr. Abraham Oman. Over to Abraham Oman.
Thank you very much for the opportunity. My topic is NOACs and update. These are my disclosures, and this is a disclaimer. So, what I would be doing in the next 15 minutes or so is that I'll be trying to have 10 take-home messages regarding NOACs and anticoagulation, and I'll try to expand because atrial fibrillation or non-valvular atrial fibrillation is the commonest indication for NOACs. It should be now called direct oral anticoagulants. So NOACs or NOACs are used interchangeably. So the first point, take-home message is that atrial fibrillation is not benign. If you get atrial fibrillation, what happens? The problem is not palpitation. The problem is that you get a stroke. So what are the most dreaded medical illness which I personally believe? One is stroke. Second, to caregivers is dementia. And third may be CKD. And fourth may be heart failure, not MI. And the commonest cause of stroke and dementia is atrial fibrillation. And there's a 5-fold increase of stroke in patients with non-valvular and 17-fold increase of stroke in valvular atrial fibrillation. And this almost everyone knows. What about dementia? Like it is said that 1/3 of people may get dementia, that 1/3 of people in this room may get dementia. And one of the commonest causes of that is subclinical embolism from subclinical atrial fibrillation. When the clinical atrial fibrillation, all the models, you may not get a big stroke per se, but you may not become eligible, but your activities will grow. And that's something which all of us dread personally. That comes number 2 in my list. So the risk of us getting dementia is also important. And take-home message 2 is that antiplatelets do not work in atrial fibrillation. If you're going to give it, the most it may harm. So you can see here, compared to warfarin, it does not reduce stroke. It may less of bleeding, but if the point is reduce stroke, so it does not reduce stroke, there is no point in giving it. And aspirin plus clopidogrel leads to more stroke and bleeding. This is something very important. Many people give durangolex and okay, that's fine. Does it reduce stroke? No. Does it increase stroke compared to warfarin? Yes. Does it increase bleeding? Yes. So not only that, it produces no good, it produces more harm. So don't do that at all. And combination of aspirin plus low-dose warfarin. That again many people give, or low-dose acetone. You give aspirin plus 1 milligram or 2 milligrams of acetone and think that okay, patient will not do the proton time properly. That is also harmful. So like aspirin alone is not beneficial. other permutation combinations are actually harmful. And so point number 3, anticoagulation is the key. So we know that compared to placebo, often reduces death and stroke. No brainers there, very old papers. But we all know that vitamin K antagonists have issues with the issue with the food intake, drug intake, regular performance time checking, time in therapeutic range, and if the time in therapeutic range is less than 60, may harm. And also, when we keep the people very much between 1.5 to 2, it does not reduce stroke. And there's also an increase in bleeding. So that is again harmful. Some people keep with a small dose, so keep dimer between 1.5 to 2, that is harmful. So vitamin K have issues. And coming to NOACs is superior than vitamin K agonists. And I've been fortunate to be the principal investigator for multiple phase 3 trials, and all these trials have brought NOACs into the guideline, and so it is, and I was also part of the Indian Consensus Guidance. That's part of all the trials, so I have no particular favorites among the NOACs. So the update of latest guideline is of the heart failure guideline, but it's the same. So patients with chronic heart failure with permanent or persistent or cause air. And with the TAP score, TAP has a simple score, it takes exactly 20 seconds, actually done it to calculate. And it's more than 2 for men and 3 for women should receive chronic anticoagulation class 1A. Next is the most important thing. It is not working. So patient with chronic patient with atrial fibrillation, NOACs is recommended over warfarin. So NOACs over warfarin class 1A, the highest class of recommendation you can get in clinical medicine. So it's NOACs superior to oral anticoagulants or vitamin K agonists. Then look down, and that is again a very new thing. And I'll be elaborating on this point. If the patient's score is without additional risk factors, so say that score is 1 or maybe even 0, the patient has got heart failure cannot be 0, but just heart failure, then you can give NOACs and class 2A recommendation, just below class 1. So if you have heart failure, even if you do not have the associated risk factors, then anticoagulation NOACs is mandated. This is very new 2022. So why this? Because it's from the meta-analysis, NOACs versus vitamin K antagonists, reduce hemorrhagic stroke by 51%, intracranial bleed by 2%. So my 25% is a relative risk reduction. It's not absolute risk reduction, but so my penalty to pay, especially if the rocks bad, with increased GI. Point number 6. Yeah, among the thing is there is a difference. And they cannot absolutely compare the trials, they're not head-to-head trials. But dapivirine 150 milligrams has been shown superior to reducing embolic or ischemic stroke. And apixaban is the safest in GI bleed, CNS bleed or intracellular bleed, all 4 reduced. So there will be subtle changes in the between the drugs, but an overall thing they are one and the same. No guidelines differentiate between these. Now coming to the most important point, problems of underdosing. We have a habit of underdosing and patting ourselves in the back, saying that okay, we have done our job. And so if something happens to the patient, it is failed. Actually, it is not. The commonest underdosing is apixaban, typically 2.5 BD. 2.5 BD is given only in you have 2 out of 3 of these criteria, that is age more than 80, weight less than 60, and creatinine more than 1.5. Even if the creatinine is 5 or the patient is on dialysis, if you have to give, the dose is 5 milligrams BD, unless the weight is age more than 80 or the weight is less than 60. And if you underdose without reason, what you are going to do is to get more strokes, and surprise, surprise, there will be more bleed also. As you can see here, the point is not working. So you see attachment above. The second one is the major bleed. It is at the back side of the line of unity. So not only that, you're not doing a good thing, you may actually harming the patient by giving inappropriate low dose. This is something which you have to remember, because we think that, okay, they will not bleed, they get bleed. And this is been replicated. We have worked out, but the Danish study also has been replicated. Now coming to bleeding. So the question is, what is an important bleed? Is it fatal bleed, intercerebral bleed, debilitating bleed, major bleed, uniformly defined, or GI bleed? Because sometimes the pharmas may come around and say, oh, this is bleed, bleed, bleed. But if you see fatal bleed, intercerebral bleed, and debilitating bleed, all for abuse. So there's not much difference. GI bleed, there's an increase with Evaroxaban as well as 150 milligrams of Bariatric. Major bleed, the definition of trials are different, so it's not exactly comparing one to each other. But fatal bleed, intercerebral bleed, debilitating bleed, all repeats. Now the take-home message number 9 is antidote. So only one drug has the antidote now, as Dabigatran, that Ivacimab or Paxton. And it's extremely easy to do. 2.5, 2.5. It's like the old saying of Hero Honda, fill it, shut it, and forget it. So give 2.5, 2.5. Within 10 minutes, it's reversed, no thrombosis. So that is one advantage of Dabigatran can find. And even now, there is a humanitarian basis. The company provides free reverse rate. But other way also, the patient has got a fall and broken his hip or has to go for a surgery, we can immediately get it done. And by the time patient reaches the theater, the effect is reversed. Andexanet alpha has also been FDA approved for others who are Bariatric Surgery to give us infusion, longer duration of giving, and there is a challenge of thrombosis. Hypertension is no longer followed up by the company. And now, Siraparantag is again the latest novel universal antidote which has come, is not at FDA approved, the study has been published. So now the last take-home message, which I have spent a little more time because I think I have some more time, special situations. So special situation is a patient undergoing angioplasty or a economic syndrome. There have been 4 trials, Pioneer, Entrust, Augustus, and Video. So what these trials have shown, simplify, this is the latest. So what these have shown is that you can skip aspirin at discharge at the most at 1 month. So if it's an ACS, if it's aspirin plus clopidogrel, give both antiplatelets together and stop aspirin at 1 month. If it's ticagrelor, this is the latest. If it's ticagrelor, then skip aspirin after 1 week. So 1 week, if you aspirin, ticagrelor, and NOAC. After 1 week, stop aspirin, continue ticagrelor, and NOAC. At 6 months, switch over from ticagrelor to clopidogrel, and 1 year, give only NOAC. So that is the middle statement in Asia Pacific guideline. And I mentioned about heart failure, but good number of people here are diabetics. So does the rule change for diabetics? And if the CAT score is 1 for male and 2 for females, then if you're a diabetic or hypertensive, then you can give NOACs as per the guidelines. So you need not say, for example, a 40-year-old female comes with diabetic female, comes with atrial fibrillation. So as per the classic guidelines, the score is 2. And one is that female and second and patient has got diabetes. But as per the classic guidelines, we have 3 first females. But if they have diabetes, if you have only diabetes, again, you can give NOACs. So the degree or the bar has been lowered in case of diabetes and heart failure. What about valvular heart disease? As of now, severe mitral stenosis has been excluded. We have to do now VKAs, but there are studies which shows that even valvular heart disease, the NOACs are beneficial and reduce bleed. They're not randomized controlled trials, but there is some data. So, some reason patient cannot take or if you get recurrent bleed, high bleeding risk, then consider that with informed consent may not be a bad idea. The new thing is pill in a pocket, because people get peroxylated fibrillation. If they have lifelong, so pill in a pocket is that I think every single person here has got a smartwatch or a smartphone, and they check their heart rate and all those things. And you can pick up atrial fibrillation. So smartwatch gives us an indication. You take NOAC for a month and stop it, provided it's not a continuous atrial fibrillation. This concept is coming, and it's interesting concept. This again of interest to the physicians, diabetologists, cardiologists, everybody, because we all see patients after stroke. We all take an ECG. ECG is normal size to them. We say, okay, give your antiplatelets. But are they at a higher risk? We know that if you monitor them for a year or so, then about 30% of them will have atrial fibrillation, and we will give the wrong therapy. So how will you look at it? If they have got multiple risk factors, let go. NS size more than 46, ejection fraction less than 35. Halter, if they have frequent APCs, please do an extended halter or extended monitoring. You will pick up atrial fibrillation and you will save the patient's life. And again, biomarkers. So these are simple things which we do, but look more deeply and find out the patient life. Another important thing is what are the surgeries, what are considered as minor, low risk. And minor include dental procedures and intramuscular injection, because vaccinations, everybody comes and asks, okay, COVID, you have to stop, people stop for 3 days, but people switch bridge with normal heparin, it's not needed. So intramuscular injection, example vaccination, come as a minor risk procedure. And for there are two important points. For a minor risk procedure like COVID vaccination, you can wait for 12 hours or 24 hours after the last dose and get it done. But taken in the evening, next evening, you can take the vaccination, not a problem. No need for bridging. No need for giving normal heparin for 3 days, 4 days. All those things are not automatic. If you have renal failure, then the time to be told will vary from 48 to 96 hours. So depending on the period. So CKD delay advice 24 to 48 hours for elective procedures. Then renal liver failure, low childhood score, you can say give NOACs. Higher, more than 10, don't give NOACs. Another interesting point, very new was dementia. I talked about dementia, I think I scared the people here, especially the older generation. But NOACs versus vitamin K antagonists. What they found was that NOACs reduced dementia. Vitamin K antagonists did not reduce dementia. And so that is something interesting. It's a very recent paper about 2-3 months back. Another important thing is in neurologists here, after stroke, we wait for 1, 3, 6 for 1 for TA, 3 for minor stroke, 6 for intermediate NIHSS of 6, and 12 for major stroke without hemorrhagic transformation to start anticoagulation. But these people tried 1, 2, 3, 4 earlier reduction and found no harm. So maybe early reduction may be beneficial. What about cerebral venous thrombosis? As a rule, it is vitamin K antagonist, but this trial published again recently showed that hemorrhage was less, but benefit was equal to that of vitamin K antagonist. Months of pulmonary embolism or venous thromboembolism. After 6 months of full dose, then after that, if you have an extended therapy, you can give lower dose of apixaban. Otherwise, there is no indication. So I conclude by looking at the patient preferences and the doctor's preferences. The left side, I'm sorry for the little smudging. For a physician, the primary point is bleeding. So as far as the physician is concerned, they want to avoid bleeding at any cost. For a patient, it is interaction with food and drug and rapid reversal in emergency situations are the highest priority. Bleeding comes middle priority. And both groups, efficacy is the lowest priority because we are trying to prevent a thing which has not yet happened and people are not bothered. But in both ways, no access because it reduces bleeding, it has equal efficacy, and there is no food or major drug interaction. I conclude by saying this very pre-quoted statement: the humanity's greatest advances are not in its discoveries, but in how those discoveries are applied. The reason is that even in recent Kerala atrial fibrillation history, about 40% of the people who have atrial fibrillation do not get anything. About 20 to 30% get antiplatelets, which actually may be harmful. And anticoagulation is still by minority. That is in the last 35 years. So we should apply our knowledge. Thank you very much.
Thank you, sir, for an excellent presentation on neurovascular anticoagulants. What about usage in prosthetic valve?
Prosthetic valve, it is like mechanical prosthetic valve, only vitamin K antagonist, no NOACs. Bioprosthetic valve, like after bioprosthetic valve with atrial fibrillation, initially give vitamin K antagonist and you can switch over to NOACs classically by 6 months, even if earlier by 1 month also you can switch over. So mechanical prosthetic valve, antiphospholipid antibody, severe mitral stenosis, rheumatic mitral stenosis are the only situations where vitamin K antagonists are superior and NOACs should not be given.
Any questions from the audience on top time?
So it was a wonderful lecture. So I have a question for you. During the COVID pandemic, I think NOACs were used right, left, and center. Maybe rather misused also. Your experience regarding NOAC?
Yeah, see, there are two aspects to it. One, hospitalized patient. And second is after hospitalization in the recovery phase. And third is a non-hospitalized patient. So there is role for anticoagulation because there is increased D-dimer and these people are hospitalized. So NOACs superiority has not been shown. And there are trials, there's one trial called Michelle trial in after discharge with rivaroxaban low dose, which has been found to be beneficial. So there are different guidelines. If you have been hospitalized, a brief period of anticoagulation in the post-hospitalization patient period is recommended. The duration varies from 1 week to 28 days. And which one is a big question? Only study which has been shown superior as of now is Michelle's study by rivaroxaban. And there are studies with apixaban. People have tried aspirin. The biggest, then these studies were smaller. So how I look at is that if a person needs ICU care, patient is on the bed, they require DVT prophylaxis. And DVT prophylaxis can be unfractionated heparin or even NOACs. There has been studies. But the bulk of data is with unfractionated heparin. Once the patient is discharged, I would give, the patient is hospitalized patient, and especially if the D-dimer is remaining elevated, then we can give NOACs for about 28 days. Roughly, some studies with even more, but roughly 1 month. That is how I look at that.
Thank you, sir.
There is hypercoagulated state because of the IL-6, which increases the coagulation profile, and TNF alpha decreases the action of the this platelet activated fat inhibitor. All this causes microvascular thrombosis in the lungs. Even before the development of DVT, to prevent microvascular thrombosis or occlusion in the lungs, can we give it early disease rather than the late disease?
The people have tried that and they found increased bleed. So the problem is COVID, there is a huge amount of knowledge with lot of conflicting things. But hospitalized patient, anyway, as per guidelines, need anticoagulation. So especially ICU patients, there's no question because it's like benefit in both ways. Non-hospitalized patient, there is no real data. Patient is ambulant. High D dimer, studies have not really shown that it reduces events. That's a big problem. So inflammation, again, people have tried even colchicine, people have tried so many things. We know the problems, but the solutions are not really fitted into the problems. That is the thing. So my approach would be very clear. I know that's antithrombotic state. I know that's inflammatory state. I would, if the patient is ambulant, it's, it can be even mild. For example, when I had COVID, I did not have any fever. I did just for, because I had some sore throat, I checked myself and I found I had COVID. And my D dimer was high, my HSCRP was also sky high. But again, if a person has high D dimer, then you can consider, and I said consider, not give to everybody because data is very lack. We have Michelle trial. There's one trial with 2.5 apixaban. It has been ongoing. And when I looked up in 2021, it is ongoing. When I looked up in 2022, it's still ongoing. I still wonder why. Partly it's because of lack of people getting giving consent for it. I'm not very sure.
Thank you, sir. If no more questions, I think we will move on to the next talk. We have another stalwart here to talk on weight balance, balancing weight, whether it is an art or science or both art and science. It is said that practicing medicine is an art. So here, ma'am is with us, Usha Sriram, ma'am. She doesn't need an introduction to this esteemed audience. Over to you, ma'am.
Good morning, everyone. That's a very tough act to follow. That was an amazing lecture. And I think a master class in how lectures should be given. And I've learned so much from this presentation. And thank you, Dr. Chandrasekhar, wherever you are, for the kind invitation. And the talk he has assigned to me is the art, and it's not coming up here, the art and science of weight management. Can I have the first slide, please? Yeah. So as I was preparing for this talk, there's something that I realized. It's completely an art and less of a science about weight management, because I think we know, most of the science. Very quickly, I want to show you, this is the new NFHS 5 data that was compared to NFHS 4, and you can see clearly whether it is children or whether it is men, women, the numbers have gone up substantially, and very depressing that women have more obesity, and this has been true across lifespan, and that is data from the ICMR INDIAB study, which shows you that the prevalence of obesity actually is 11.8 to 31.3, and that's because it depends on what people used as a criteria for calling someone as obese. Did they use 25 as the cutoff, or did they use 30 as the cutoff? And so it depends a little bit on that. So also want to show you, it's not just overweight and obesity. Extreme obesity is also increasing a lot, again, more in women, and this is something we will talk about briefly. So, coming to what is the science and what have we known about, for example, the consequences of obesity? Why do we worry about this whole weight? Is because of this. Even 2,500 years ago, Hippocrates has cautioned that sudden death is more common in those who are naturally fat than lean. He used that word fat and not me. So, and those are words that we do not use anymore. And this is something important to keep in mind. And it has been validated clearly
And you can see a J-shaped curve that as the weight goes up, mortality goes up significantly in men and women. Now, look at the complications of obesity, everything from pulmonary disease to non-alcoholic fatty liver to gallbladder to stroke to coronary artery disease to type 2 diabetes, of course, cancers, pancreatitis, phlebitis, skin issues, acanthosis, so many of them, and osteoarthritis. And why I have this up there is many of these things, and I want to thank our previous speaker for pointing out that what is important to the patient is what we should really consider. If we tell them that 10 years from now you'll get diabetes, or 20 years from now you will get heart disease, or you might die sooner, it just doesn't mean anything to them, doesn't resonate with them. On the other hand, if you're talking about your knees are going to get better and you can walk better, or you're going to have less sleep apnea and sleep better, or your quality of life is going to be better, or your infertility problems are going to be resolved, that is what will resonate, and that is really the art of weight management. And also, if you go back to this slide, there's no mention of mental health at all, when in reality, mental health is a huge part of weight management or weight as an issue. So everything from severe depression to helplessness to isolation, stigma, that is a very important word, insomnia, poor self-worth, all of these things are important to the, and we are a very, what can I say, appearance obsessed society. So that is of major concern, especially to women. So then comes the question like, why did we develop this problem at all? Is it a very simple, we had a very simplistic view of overweight. Energy in, energy out, anybody who put in too much or spent too little, like first law of physics or thermodynamics. Absolutely not like that at all. So just to show you, for the majority of human existence, food supply had been scarce, and stored energy in the form of adipose tissue was important for survival. So our natural instinct was to store food, store fat. But then the Paleolithic men and women had to run and kill the animals and go, gather berries to eat. And unlike us, we can call Swiggy or Zomato and get anything we want. So from an old narrative, which was, energy in, energy out, we've got a new narrative, which is very, very different, which is the obesogenic environment and genetic susceptibility and all of these things, from financial stress to emotional stress, sleep deprivation, sedentary job, commuting, eating disorders, endocrine disruptors, epigenetics, medications, menopause, post-pregnancy weight retention. I'll show you some slides on that, and gut microbiota and hypoglycemia. Again, I just want to tell you that it's not just gut microbiota. Gut microbiota are important. It's just part of the whole picture. And we haven't yet found one magic thing or a missing piece of the puzzle or secret sauce, whatever you want to call it. We haven't found that one thing that if we can fix, everything will go away. So there's, like I mentioned, there's a long list. And here I want to point out 3 things. Smoking cessation. A lot of people will not quit smoking for the fear of gaining weight. So, or they may have even gotten into smoking to lose weight. So, because smoking decreases appetite. So that is something we must address. And because today we are talking about the art and science of weight management. And we need to have the answers for these 5 questions, like why did this person become overweight, or gather insight. Why did this person become overweight? What are the difficulties they are having with losing weight? Do they want to lose weight? What efforts have they put in for losing weight? So we need to have all those answers, which means a lot of time spent talking to them. So we're actually shifting from thinking of BMIs and those hard numbers to actually health outcomes. If this person is overweight, they're going to have some poor health outcomes. And that's all we want to talk about. And then this post-pregnancy weight retention, very, very important. I'll show you something on that. This is it. Do you see this after each pregnancy, there is some gestational weight gain that is retained. Then they go on to the next stage, and then they go on to the next stage. And that is why women, not that women are eating like gluttons. That is one of the reasons. See, women and men are equal. We all know that, but not the same, because we have a very unique life cycle that men don't have. We have pregnancy, breastfeeding, postpartum weight gain, another pregnancy, breastfeeding, another weight gain, and then menopause. So we have all those issues, they're not issues, all those difficulties which ultimately make us gain weight. And then in many societies, women are not allowed to go outside, not allowed to exercise, or don't have the, the resources or the time or reason, they can go out. So they end up having sedentary pursuits like TV watching or just gather around and talking and not actually being physically active. So one of the main things, and this is an art and a science, is to get into what we call the social determinants of health. So social determinants of health have become a very important part of what determines our health. So if you see here, of course, individual characteristics like gender, which I just talked about, genetics, personal behavior, psychological coping skills, nutrition and lifestyle habit, because we have a natural tendency to be dismissive of people who are overweight, saying, he or she ate more, he or she was, was lazy, didn't do much and therefore gained weight. So we think it's a volitional thing and the whole thing is put on the patient. Instead, we need to think that could it be all this: income, social status, education, social support networks, culture, tradition, beliefs, health services. I might talk to the patient about postpartum physical activity, but the family, the grandmother, the mother-in-law, and others may tell you can't go out after having the baby. So there may be cultural beliefs that is stopping a person from doing the kind of thing that they need to. So a lovely paper by Nitin Kapoor from CMC Vellore, who looked at gender disparities in people living with obesity. And you can see many of the things that I have been talking about have been identified as gender disparities that hinder people from losing weight. So coming back to this question, why are people overweight? All kinds of theories have been put forward, from genes to that too much of carbohydrates. It's the sugar industry that did things and not the fat industry, and why we eat too much, and then it's not a character flaw. So everybody is trying to cash in, that's the word. Everybody is trying to cash in on this big problem of overweight. And every one of us wants to look and feel a certain way. And so if there is a magic medication or bullet made by any of the pharma companies that will make everyone come down to the weight they want, they will be the #1 industry, #1 pharma company in the world forever. So, but that's not going to happen, because gaining weight or inability to lose weight is more than just overeating and under exercising. So much more than that, that we are not going to be able to find that one pill to fix things. It needs to be probably a lot of things. And so what makes people want to eat? What is appetite? And so from a scientific, the science point of view, we scientists want to know what's going on. So the fat, which I'm talking about adipose tissue, the gut and the brain, they talk to each other to regulate body weight. But the body itself defends its highest fat mass. And I'm going to show you a very important slide where as people lose weight, their body will do two things. It doesn't know that you're losing weight because you want to get healthy. It thinks you're losing weight because you're stuck somewhere in some mountain and there's no food. And so it will do two things. It will shut down your metabolism, turn the thermostat down. Second thing it will do is increase your appetite hormones like ghrelin. It will do two things. So you'll be all the time hungry, wanting to eat, and all the efforts you put in will not be very successful. So it will be defending, and the body will defend its highest fat mass And once fat mass is gained, it's very difficult to reduce it. So let's keep that in mind. But just to show you, the adipose tissue has leptin, which is the satiety hormone, and the stomach has ghrelin, which is the hunger hormone. And they're all acting on the hypothalamus, where so many cues are coming in from the gut, from the incretin, from GLP, GIP, so many of the hormones, insulin, some neuropeptide Y, so many things are coming that are controlling our appetite and our hunger. But what is to the normal person? This is what is hunger. They see food and they want to eat it. And we eat food not just when we look at it, we feel hungry. When we smell it, we feel hungry. When we touch it, we feel hungry. So all those cues are going to the brain and telling you, eat now. You may not be hungry, but it tells you to eat. So it's also all these things in so much in plenty that is driving the obesity epidemic. So to summarize what I've just said, there are biological factors in utero environment. There is birth weight, gender and age, and concurrent disease. There are genes, susceptibility genes, epigenetic modification, ancestral background, gene-to-gene interaction, food availability, social determinants of health I've talked about, built environment. Built environment is something that we have to keep in mind. Why do people who are living in, for example, in a resource-poor setting, in slums, and have very little to eat, so to speak, why do they become overweight? You just make a little survey of the people sitting and selling flowers or selling vegetables. I did a small survey. All of them are morbidly obese. Why is that? So, and if you go in and find out what they eat every day, what they do every day, you will find out the reason why. So, and they don't have much space to move around and where they live. So built environment is very important. And of course, behavior, psychological pattern. And we already talked about how important sleep is. So you balance all this and you can see there is a body weight set point. And I'm going to tell you a little bit more about set point. And this is a beautiful slide, and this is from the endocrine reviews. I strongly urge you all to read that paper from 2018, written by Dr. Bray, where they talk about how from a healthy body composition, you have an expansion of the subcutaneous fat, and then how that dysfunctional subcutaneous fat further causes, there's further fat expansion, then visceral adipose stores start expanding, then there is ectopic lipids, and as you can see, everything from if pharyngeal fat happens, sleep apnea happens. If it happens in liver and muscle, diabetes happens. If it happens in the heart, you get heart failure and cardiomyopathy. And so, and then cancers, especially in women, the uterine cancers and breast cancer. And then the big bugbear, which is degenerative joint disease, especially of the knee joints, and people are not able to walk. So it becomes one of those vicious cycles. Ellarkum Tamil theriyuma? Everybody knows Tamil? Okay, great. So the Tamil பழமொழி இதுல வந்து கல்யாணத்தை ஆனாதான் பைத்தியம் தெரியும், பைத்தியம் தெரிஞ்சாதான் கல்யாணம். So only if you lose weight, your knees get better. Only if your knees get better, you can lose weight. So how to fix it? I don't know. So very important, I talked about stigma. So coming to this one, we should look at obesity itself, not as some sort of BMI or a disease or things like that, and put all the blame on the patient, but actually look at the stigma against obesity as a disease. There's clinical stigma. Systemic preventive approaches are less, funding is less, coverage for obesity, insurance coverage is less, and there is therapeutic inertia. How much time do we spend asking all those questions I talked about? Same thing, stigma against people with obesity, more mental disorders, binge eating, unhealthy eating, increased body weight. So, and look at what happens to women when they are marginalized or they're treated poorly. And so there is also stress eating. This is something, eating food for the sake of comfort. That's all they can do. So again, a very nice study from CMC Vellore that looked at obesity indicators and health-related quality of life. And I want to tell you, this is again something we should discuss with our patients, quality of life. But in my own practice, this is from that, the reasons why people want to lose weight or the carrot that I can dangle in front of them is this: sleep apnea, infertility, quality of life. For some, it's cosmetic, and then knee pain and effort tolerance. When I say cosmetic, things like acanthosis nigricans, things that they know by losing weight, things will improve. So that's very important. And obesity shrinks the brain. You want to tell somebody about that? They might want to change their behavior associated with reduced brain volume and slows cognitive function as well. So moving now to how do we deal with our patients? You have to have a targeted approach. All cannot be put in one bucket and we cannot talk to them. There must be dedicated programs and they must be evidence-based. Patient-centered language has to be used and person-centered approach. You need to know the person who's overweight and ask all those questions. Trained personnel, a sensitive, non-judgmental approach, a multidisciplinary approach. I might need a sleep specialist to work with me with my patient, and it must be affordable. All these, so all this talk that we do with our patients, I love this slide and I'll explain to you. So here is this man talking to his dog, Ginger. He says, okay, Ginger, I've had it. You stay out of the garbage and understand, Ginger, stay out of the garbage or else. Okay, what is Ginger hearing? Blah, 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 Ginger, blah, 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 Ginger. That's all, the only word it's hearing is Ginger. Doesn't understand anything else. Same with how we talk to our patients. We might tell them cardiomyopathy. We might tell them something else. They don't understand, they're not processing any of that. They're only hearing obesity, obesity. They're not hearing anything else. So you need to, deconstruct all the language and keep on asking after every sentence, do you want to ask me something else? Are you following what I'm telling you? Are we on the same page? Are you in agreement with what? So it has to be a shared decision making. So remember this Ginger talk. And the simple assessment is, first thing is, you ask the patient, are you ready? Do you want to get on a weight reduction program? And if they say not ready, you go back to advising on weight gain avoidance and treatment of risk factors. But if they say yes, then of course, lifestyle modification, screening for the CV risk factors, comorbidities, consider pharmacotherapy if their BMI is more than 30 or more than 27 with some sort of comorbidities, comorbid disease. And then, of course, refer to a bariatric specialist if they are morbidly obese, because they may be considered for other things. So I'm coming to the end of my talk. This is from the Canadian Obesity Guidelines, which is now considered the global standard, the best in the world. Just came out this year. And I want to show you what they have said is the 5A framework. This was being used for smoking cessation. Now they are using it for obesity management. You ask the patient, you assess the patient, you advise the patient, you agree upon the plan, and then of course assist. Assist meaning they may need a referral to a physiotherapist, they may need referral to a nutritionist, they may need referral for smoking cessation. Whatever the things they need, we have to assist. Our office has to assist, not just say, stop smoking. How will they stop smoking? So we have to risk stratify them if they are low, moderate, or high risk. First important thing, do a complete check on what medicines they may be on, which is making them gain weight. It's kind of dumb to have advise a patient, but we have given them something that is making them gain weight. And then the next two slides are very interesting. Do you see this? This is old stuff. They used to give all these things to patients, trilene tablets, bile beans, soap, obesity soap, lard be gone. So all sorts of nonsense has been going on for hundreds of years. Now look at what we are doing now. We are doing all this. We are doing some giving HCG diet, fat burners, hydroxy cut. This everything is one word, rubbish. So unsafe and rubbish, we cannot be recommending any of this. So the art is also in how to say no to patients. Patient will ask, shall I go for liposuction? No. Are products like Herbalife safe? No. What about natural substances like Garcinia cambogia? No. Does naturopathy work? No. Can HC be tried? No. So, and to say no, you should be convinced in your own head and also have the science at your fingertips. Why no? So we should be able to answer our patients why we are saying no, but we have to say no to all of this. So quickly, you know that when people decrease their food intake, weight goes down. But after some time, the weight will come slowly start going back up. Why does that happen? You can see both ghrelin goes up. So the hunger goes up. The next thing that happens is metabolism goes down. And all kinds of diets are being promoted. And again, I want to just tell you, nothing works. What will work is what is appropriate for that individual. We take a good history, find out their lifestyle, their preferences, and what they can afford, and then we tailor a diet for them based on that, not any of this crazy diet. Have you heard of this new diet, the vegan diet? Vegan is paleo plus vegan. So there's all sorts of things that are floating around, and patients will ask you those questions. So, Tamil adukku or paramari irukku. Yetta thinna pittam thaliyum. They want to know, yetta sapta pittam thaliyum. And they're only processing those things and nothing else. So, which one? So, you ask me which one? So, not this, eat this, not that diet. But and just this, I think this week or this month, a New England Journal article has come out that has shown that calorie restriction or intermittent fasting, which is better, their conclusion was a regimen of time restricted eating was not more beneficial, meaning ultimately it is just calorie restriction. So how you do it is all depends on that patient's need. So this is the set point theory. So ultimately, this is what will happen to patients who are trying to lose weight. They start here, come down here, they start gaining weight. You see they're already a little bigger than before, then they'll start losing some weight and then go back up. So chronically, they'll keep on getting heavier and heavier. So that is the set point. And this lovely slide I mentioned to show you when people lose weight, I must thank Professor Donna Ryan for this slide. 145 kilos to 87 kilos, this person. That person is 87 kilos to start with. Basal requirement drops from 2,600 to 1,890 after weight loss. And that person's daily basal requirement is about 2,400. So when you lose weight, your metabolism slows. And that's why people hit a plateau and they have difficulty with losing weight. So lastly, there are all kinds of medications, pharmacotherapy, as you can see in the multiple, I'm sorry, this slide is a bit fuzzy. In multiple locations, you can see all the different pharmacotherapy that's being used. We had a lovely presentation by Dr. Venkatraman on semaglutide. So many medicines are available, but just to tell you right now, it's kind of dwindled down to maybe 3. Liraglutide, semaglutide, and orlistat. All the other things have gone to the back, either because of side effect or their efficacy is not good, or see, all of them work on the brain. And then the brain has a center called as the Ananda Center. Ananda means happiness. So when they go and work there, your weight will come down, but you're unhappy, or you're suicidal, or you're depressed. So not good. So really, it has now come down to liraglutide and semaglutide and orlistat. And a new one has come, which is tirzepatide, but not yet approved for obesity alone. So I just wanted to show you the semaglutide, weight loss compared with all the FDA-approved drugs. So anybody wants to guess what this guy had? Bariatric surgery. So these are all the surgical techniques that are available only for people with very high BMI or with comorbidities, and only after lifestyle and maybe some appropriate pharmacotherapy has failed. And of course, physical activity, most important, every step of the way with whatever we are doing with lifestyle. One thing I want to mention is this is for children. And when children become overweight, there is a phenomenon called plaquing. They'll become overweight adults. You talk to 100 overweight adults, many will say, I was a skinny kid. You talk to 100 overweight kids, most of them will become overweight adults. So that's a phenomenon called tracking. And we must avoid childhood obesity, very, very important. My last slide. So what is needed? Address the stigma, change the words. Nobody should be called fat and lazy and pudgy and all of those things. And prioritize maternal health and childhood obesity and growing burden of obesity in low-income settings, which we are having. Policy approaches addressing inequalities and social and physical determinants of health are particularly relevant, and appreciate that obesity is a chronic disease requiring a health system approach with both prevention and treatment for management and everything. So it's a chronic disease, but we really have to see, about health outcomes for that individual, and it shouldn't be based on something very generic like, oh, your BMI is 26, you need to lose weight. No, because BMI itself is flawed. That's why I didn't have time to talk about it. It could be its weight and height. So it could be a very muscular person who's weighing more. Their BMI may be high. So it's very, very important for us to not just base it on a number and treat them, as numbers, but actually as a very person-centered approach. So that's the art of obesity management, and lots and lots and lots of time, because they will do better, fall off the wagon, do better, fall off the wagon. So ultimately, with some succeed, some have lifelong difficulty with it for all those reasons I just showed you, but we have to be persistent in our efforts. Thank you so much.
Thank you very much, ma'am. That was an amazing lecture, balancing weight, both art and science. I think it is more of an art, as you said, than science. We just take it 1 or 2 questions, because it 1 to 10.
Madam, good morning. That was really colorful slides. I have just one question to you. You talked about a lot of aspects of it that influence the weight of the patient, social, cultural, and there are all these backgrounds around. But ultimately, do they not boil down to calorie in and calorie out? So that is one aspect of it. And we talk about some metrics. What are the metrics that you use in your practice? Do you consider this weight-adjusted waist index that is coming up more related to the quality and quantity of life than all the other metrics? Do you use them practically?
So you're absolutely right that my former chairman, who I quote almost every day to my colleagues, was, had a great sense of humor. And so he'd say, like, Usha, have you ever seen an overweight Somalian? Because there's no food in Somalia when they were going through the famine. So that's, one way of looking at it. But what I'm talking about is, it's not a pure physics, like, because we know from tons and tons of personal and clinical experience that the same amount of food can be eaten by 4 different people, and the amount that they retain is different, and that has to do with their metabolic rate, which we inherit from our parents, and this they've shown with twin studies and adoption studies. They've shown that children who are adopted show a metabolic rate similar to their biologic parents and not their adoptive parents, though the environment is that of an adoptive parent. So there is also that kind of inherited metabolic rate is there, then what is available to them. So why do people who are food insecure, meaning less food, why do they get overweight? Because healthy food is more expensive. Fruits, nuts, and who can afford all that? So that's very expensive. So they end up eating, the government gives 20 kilos of free rice. So sadam pani sapro. And then you gain weight. So there are lots of other factors, but you're right. So that's also very, very important to keep in mind. And that New England Journal study validates that point, that ultimately it's calorie restriction combined with physical activity. So ultimately it boils down to that, but there may be other things that are acting as roadblocks towards that thing. And in terms of metrics, see, what they have recommended is people should lose in the first 3 months at least 2 kilos a month. And the reason for that is, that is the metabolic rate we need to reach a 5% weight loss in the first 3 to 6 months. That is the success in terms of what we call a successful weight reduction program. See, this is for weight reduction programs where they charge people money or get into a program. For us, on a day-to-day basis with our patients, we can be a little bit more flexible and just tell them, you eat as healthy as you can and be as active as you can, sleep well, lower your stress, avoid the medications, don't eat out, do all those things and keep on gradually losing. I tell them half a kilo a month is 6 kilos in a year, or 1 kilo a month is 12 kilos in a year. In 2 years, it's 25 kilos. That's good enough. So I tell them that, but it's not easy. To have that sustained, consistent weight loss is not that easy, but they can take the pressure off them. So they can do it at their own pace, keep encouraging, keep praising them.
Thank you, ma'am. I think the discussion can go on and on, but for want of time, we will close the session. And we would like to thank the organizers for having invited us to be the chairpersons here. Thanks to Professor Chandrasekhar sir also. Thank you, ma'am. We'll move on to the next session.
Next, we move on to the next session. May I invite Dr. Arun Ranganathan and Dr. Cecily Mary Majula to conduct the next proceedings.
Good afternoon to one and all. It's a great honor to chair this session. These students are the great legends who are the speakers here. Professor Dr. G. Nyanavelu, retired professor from Madras Medical College, a real icon in the field of interventional cardiology, both coronary and structural interventions. Due to want of time, over to you, sir.
Thank you, Chairpersons. Good morning, delegates. The purpose of this talk, echocardiography in intensive care unit, is to encourage physicians and intensivists to look at the heart as soon as the patient comes in with acute illness like chest pain, dyspnea, and hypertension. There are a lot of terms, a lot of interest, a lot of papers, a lot of courses going on in the world about the echocardiography in intensive care unit. But I will choose this focused cardiac ultrasound is to rapidly detect significant cardiac pathology and assessment of volume status and biometric function, particularly in time-critical scenarios, including cardiac arrest and trauma. There are conventional windows to assess the heart, like the subcostal view, to assess the chambers, look for the effusion, and IVC, to look for the volume status. And this parasternal view, most often we have to examine the patient in the supine position. We don't have the luxury of turning the patient to the left, since they may be on ventilator, and to look at the chambers, left ventricle and right ventricular contraction and function. Apical view is particularly useful to assess the heart. All the chambers are visible, and there is a 5-chamber view to look to estimate the stroke volume and cardiac output by Doppler method. And the suprasternal view is particularly useful to look at the dissection flap and dissection of aorta. Whatever may be the view, the purpose is to look at the heart, look at the LV function, look at IVC, and look at the aorta to detect the cause of the chest pain, dyspnea, or hypertension. To go methodically, we have 5 V's in focused cardiac ultrasound. First is effusion, to look for pericardial or pleural effusion. Second is ejection, to assess the left ventricular and right ventricular function. Third is equality, to particularly diagnose pulmonary embolism. The fourth is exit, to look at the aorta, to assess aortic pathology like aneurysm and dissection. The fifth is entrance, that is the inferior vena cava, to assess the intravascular volume. It is useful to remember these values. The RV wall thickness is usually less than 0.5 centimeters. The LV wall thickness is less than 1 centimeter. RVOT dimension is less than 2.5 centimeters. The RV diameter in fourth chamber view is less than 3 centimeters. And the left atrial dimension horizontally is less than 4.5 centimeters. And the LV dimension in diastole is less than 5 centimeters. This is the example of effusion. On the left side is normal, there is no fluid around the heart. And on the right side, unfortunately, fluid and the echo is not running. There is circumferential fluid collection around the heart, and the heart is swinging. We can even estimate and quantify the amount of fluid around the heart by looking at the echo-free space behind the left ventricle. If there is no fluid, there is no peripheral effusion. If the space is less than 1 centimeter, that is small collection of fluid. If the space is 1 to 2 centimeters, that is moderate collection of fluid. And if it is more than 2 centimeters, a large collection of fluid. Pericardial effusion can be diagnosed echocardiography, but cardiac tamponade is a clinical diagnosis. And to decide about the pericardial synthesis and whether it is therapeutic or diagnostic should be decided by the clinical situation. The next is ejection. Again, this slide is not moving. Whenever the left ventricle contracts, the ventricular wall gets thickened and moves inwards. So there are two things we have to observe. One is the ventricular thickening during systole and the movement towards the center of the ventricular myocardium. Visual assessment is better than the complex and elaborate assessment of ejection fraction. Whenever the ventricle contracts throughout vigorously, you can easily say it's hypertonic contraction and ejection fraction is more than 68%. Normal ejection fraction is 50 to 68%, and moderately depressed LV function is 30 to 50%, and severely depressed is ejection fraction less than 30%. These are some of the examples of global and regional function. The left ventricle is divided into 4 segments. This is simplistic method, anterior wall and interventricular septum, LV inferior wall and LV lateral wall. And on the right upper panel, there's a global hypokinesia. There is even a collection of fluid around the left ventricle. The whole heart is not contracting well. On this, the lower left panel, the anterior segment is not contracting well. That is an anterowall infarction. On the lower right panel, the inferior wall is not contracting. That's an example of inferior wall myocardial infarction. Simple measurements like this internal dimension in diastole and systole at the tip of the mitral valve between the interventricular septum and the posterior wall in diastole and systole, the difference should be more than 30%. If it is less than 30%, that indicates left ventricular dysfunction. And the E point septal separation, in diastole there is E wave and A wave, and the distance between the interventricular septum to the summit of the E wave should be less than 10 millimeters. If it is more than 10 millimeters, that indicates left ventricular dysfunction. Ejection fraction can be easily measured by M-mode, the T-Coles method. We take the internal dimension of the left ventricle in diastole and systole, and the machine automatically gives us the ejection fraction. In this example, it is around 64%. We can easily calculate the so-called by Doppler method. We measure the aortic annulus in systole, where the aortic leaflets are starting in the LVOT. That diameter is taken as the aortic LVOT diameter, and put a posterior volume sample volume in the 5-chamber view just proximal to the aorta. That gives us the spectral Doppler of the LVOT. We trace the spectral Doppler of the LVOT. That gives us the velocity time integral of the LVOT. So we calculate the slope volume by LVOT diameter squared into 0.785 into LVOT VT, that is the velocity time integral. In this example, the slope volume is around 64 ml. The cardiac output can be easily calculated by the slope volume multiplied by the heart rate. In this example, it is 4.6 liters. When the patient comes with dyspnea, we are not sure whether it is exacerbation of COPD or heart failure. These lung comet lines are very useful to diagnose heart failure. These are indicative of pulmonary edema. Even effusion can be diagnosed by ultrasound. That may be due to that may be the reason for dyspnea. Left ventricular filling pressure can be estimated by a simple formula E by E prime. This left ventricular filling pressure is equal to the left ventricular mean pressure, left atrial mean pressure, and R pulmonary capillary pressure when there is no obstruction to the mitral valve or the pulmonary veins. The E is derived by the transmitral Doppler, and the velocity is taken, and the E prime is derived by the tissue Doppler imaging of the septal as well as lateral, taken average. And if the E by E prime is more than 14, that indicates elevated LV filling pressures. The third one is equality. Unfortunately, the videos are not running. On the left is the normal LV and RV. Normally, RV is smaller than LV. On the right is the enlarged RV, compressing the left ventricle. That is an example of pulmonary embolism. The left ventricle assumes a D shape instead of a spherical shape, and the RV is obviously enlarged here. And we can even sometimes visualize the thrombus in the right to the outflow tract or in the pulmonary arteries. And the equality, normally RV is smaller than LV, and the left is normal. When there is acute RV strain, like in pulmonary embolism, RV wall thickness is not increased, whereas the LV assumes a D shape. When there is chronic RV strain, like in primary pulmonary hypertension, the RV wall thickness is increased, and LV assumes a D shape. Pulmonary embolism is primarily diagnosed by the dilatation of right atrium and right ventricle, D-shaped LV on the left side, and the Nocturnal sign. That is the preserved contacts of the LV apex, whereas the free wall is hypokinetic. 60-60 sign, that is the RVOT acceleration time is less than 60 milliseconds, and the TR gradient is less than 60 millimeters of mercury. Then we can even visualize the thrombus as in the last panel, the thrombus in the pulmonary artery or RV and RV. The fifth one is the exit, that is look at the aorta. There is a dissection flap. There are two examples, dissection flap arising from the aortic valve extending to the ascending aorta. There is a dilatation of ascending aorta also. And this is another example. The dissection flap is seen. We can even see the false lumen and the true lumen, and look for the consequences of the dissection, like aortic regurgitation, rupture, causing pleural effusion or pericardial effusion. When the normal aorta is less than 4 centimeters, if it is more than 4.5 centimeters, that is called aneurysm. Lastly, the entrance assessment of IVC. It is done in the subcostal view, sagittal view. And the normal IVC is less than 21 millimeters. Normally, IVC decreases in dimension, that is called IVC collapse, occurring in inspiration. If it is more than 50% collapse, then the right atrial pressure is around 3 millimeters of mercury. When the dimension is less than 21 millimeters, but the collapse is less than 50%, or the dimension is more than 21 millimeters, the collapse is more than 50%, then that is intermediate increase in the RA pressure, that is 8 millimeters of mercury. Both the dimension is increased, the collapse is reduced, then right atrial pressure is assumed to be 15 millimeters of mercury. Patient in hypertension, whether to give fluids or not, in spontaneously breathing patients, near total collapsibility or IVC less than 1 centimeter, it can suggest fluid responsiveness. In ventilated patients, the opposite occurs, the IVC distance during inspiration, so we go by the distensibility index. IVC maximum diameter minus IVC minimum diameter divided by IVC minimum diameter is the distensibility index. If it is more than 12 to 18%, that suggests fluid responsiveness. We can give fluids for this patient. SVC assessment is done usually by transesophageal echocardiography. Then the collapsibility index is taken, SVC maximum diameter minus SVC minimum diameter divided by SVC maximum diameter. That gives us the collapsibility index. If it is more than 36%, then this is 90% specific for volume responsiveness. More better method is to estimate the LVOT, VT, and peak systolic variability in the patient with hypertension. If there is more than 12% change in the VTA or peak systolic velocity, that is 98% specificity and 100% sensitivity to give fluids. This should be avoided in a case of right ventricular failure. Even we can do a passive leg raise if the patient allows and condition situation allows. If there is a more than 14% change in VTA, that is predictive of fluid responsiveness. And signs that suggest fluid bolus may be deleterious or dilated left ventricular systolic dysfunction, dilated right chamber with right ventricular dysfunction, dilated IVC with little or no respiratory variation, paradoxical interventricular septal motion or D-shaped left ventricle or intensive septal deviation to the left. These signs indicate that should not give fluids to the patient. And hypotension, the cause of hypertension, the echoing shock, this is a practical mnemonic, septic or distributive shock. In less severe shock, the ejection fraction is more than 60%. In severe shock, the ejection fraction is low. In hypovolemic shock, IVC is collapsed, small and hyperdynamic ventricles with ejection fraction of more than 68%. In obstructive shock, there are two causes. One is tamponade due to pericardial effusion or tamponade physiology can be easily assessed by echocardiography. Pulmonary embolism, as we have seen, can be diagnosed easily by echocardiography. There is a large RV septal shift, D-shaped left ventricle and thrombus in the right atrium, right ventricular pulmonary artery. Cardiogenic shock, the LV function is decreased, the ventricles are dilated. And case combination, there can be a combination of septic or hypovolemic shock, septic or cardiogenic shock, etc., and other conditions like adrenal insufficiency or neurogenic shock. Lastly, we go to see this example. The 72-year-old male with NSTEMI arrested in ICU with CPR started and multiple shocks were given. There is a flat line, no pulse. Unfortunately, this video is not running. There is indication of ventricular contraction due to fine ventricular fibrillation. And multiple shocks are repeated. We are looking at the heart and still contracting. Shock is not effective. We gave adrenaline, dilatrine, and cordon. Ultimately, we could get the heart organized contraction back, and this patient was saved. So, in the use of echocardiography is particularly useful in cardiac arrest to look at the cause of cardiac arrest, like in treatable cause like complication of ventricular myocardial infarction, like ventricular septal rupture, three-valve rupture, or pulmonary muscle dysfunction. This can be easily diagnosed by echocardiography. And this pulseless electrical activity, particularly useful, usefulness of echocardiography is that to look at the ventricular contraction. The ventricular, there is some motion of the ventricle, and the pulse is, even if the monitor shows a straight line, there is no pulse, which should give DC shock to get back the organized contraction. To conclude, echocardiography is an essential tool in the management of acutely ill patients. Outcome of patients is always better when echocardiography used in the diagnosis and treatment. Simple steps and quick evaluation can be easily practiced by intensivists and emergency physicians. Lung ultrasonography is complementary to echocardiography in identifying D lines and pleural effusion. And 5E, lung ultrasound, shock, mnemonic are useful in the quick assessment of cardiac shock. It usually takes about 3 minutes to get the cardiac condition assessed in the acute setting. Thank you very much.
Thank you, sir. It was a very splendid and lucid talk, sir. Any questions from the audience?
Thank you, sir. I think we should train our MD people or even MBBS people to have the emergency echo done. That will save most of the patient. Management strategy will be varying according to the findings of your. We have to include in our curriculum.
Thank you, sir. It was a lucid talk, sir. In acute MR, sir, sometimes due to capillary muscle dysfunction or caudal ruptures and flail effect. Differentiate between flail effect and caudal ruptures.
Caudal rupture and
Flail effect.
flail effect. Caudal rupture the cause of flail effect. That is a reason for acute MR. What is your answer?
Both, we can put it as the same diagnosis.
Yeah, caudal rupture, that causes the flail effect. The papillary muscle rupture is a different condition. The papillary muscle itself gets ruptured. The whole mitral effect moves into the left atrium into the left atrium during system. That is an acute life-threatening condition. Whereas caudal rupture may not be life-threatening, they may patient may have severe MR, but that condition gives us some time to react.
Thank you, sir.
All doubt, sir. In many, the past couple of years, we have been seeing a lot of COVID cases, and many cases they got a lot of increased D-dimer. When you do an echocardiogram for those patients, for some patients only there is a correlation that when there is an increased D-dimer, RA dilatation, only some cases are there. In many cases, we are not able to find. And how do you apply echocardiography when there is setting of increased D-dimer?
If there are no significant changes in the right atrial size, right ventricle function, or this ventricles, then there may be a subclinical thrombus or small thrombus in the pulmonary artery. That cannot be detected by echocardiography unless there is a submassive pulmonary embolism that is not shown by echocardiography.
Thank you, sir.
Thank you, sir. Next, we call upon Professor Dr. P. Paranaman, another stalwart of the field of medicine, to speak on sudden death in diabetes.
Thank you, Chairpersons, dignitaries, distinguished members, and dear friends. At the outset, I'd like to thank the organizers for having invited me to talk on sudden death in diabetes. Sudden death is not uncommon in general population. It is not uncommon, but it is common in diabetes, but more common in type 1 diabetes of a longer duration with the nocturnal hypoglycemia with cardiac autonomic neuropathy. Probably that is the reason why this topic was given to me. I thank the sincere thanks to the Professor Chandrasekhar for inviting me to talk on this. Sudden cardiac death or sudden death is also called death in bed, which is defined as unexplained death occurring in a subgroup of population of type 1 diabetes where no cause is identified during life or at post-mortem. That means what? Previously healthy, even after death, no cause is found. That is sudden death. The scenario is that the victim of good health before the death goes to bed, retires to bed, and found dead in the morning. Bed is undisturbed, suggesting no terminal struggle or seizure. Again, it shows the healthy person suddenly died without any cause. It's probably due to malignant arrhythmia, even though silent death, the death is due to malignant arrhythmia, and probably due to a wide prolonged QT with fatal ventricular fibrillation that is the result of hypoglycemia in a setting of cardiac autonomic neuropathy. If you do autopsy, usually negative, and usually it occurs in the age group of less than 50 years. There is one more entity called sudden cardiac death, which comprises of 15% of all death and 50% of all cardiac death. The sudden cardiac death is 2 to 4 times more common in diabetics than non-diabetics. It occurs more in the early morning, usually in the age group of 30 to 40 years, and most of the time, 70 to 80% of the time, the coronary heart disease is associated with sudden cardiac death. Here is not moving, there is no. So, here is not moving, there is no. There is no problem. What are the effects of hyperglycemia? How this can occur? Coronary is normal, heart is normal, but patient is dead. How this can happen? So in a heart, there are two things can happen. The intravascular problem, that is called macrovascular complication. The extravascular problem, that is the perivascular fibrosis and interstitial fibrosis, which is not picked up by the angiography, which is not seen by any of the tests available as a common problem, common investigations. So the intravascular problem resulting in acute myocardial sudden cardiac death. The extracoronary problems of fibrosis that altering the conduction system signaling fatal arrhythmia, sudden death. So probably that is a cause for sudden death during night time. And the atrial problem is extracellular matrix. There are two cells in the heart, one myocyte, two the fibroblasts. These are anchored by the extracellular cells interstitial. These are nothing but macromolecules produced by fibroblasts. When cell apoptosis occurs, the cell dies, it goes, it will be vanished. Whereas in diabetes, when there is an apoptosis, the apoptotic cell becomes fibrotic because excess fibroblasts are there in the heart. That's the reason why the fibrosis occurs, which is not being seen normally. And also, there are two receptors in the heart. One, the down regulation of the beta receptor, which is causing bradycardia and sudden death, up regulation of renin-angiotensin receptor, that is angiotensin 2 receptor, that is causing fibrosis, interstitial thickening, stiffness of the heart. So that is causing heart failure. So which is not being seen by your coronary angiogram. What happens with hyperglycemia? Uncontrolled diabetes, resulting in elevation of reactive oxygen species, reactive coronary species, and resulting in the structural changes. The structural changes again due to the damage caused by the cytokines, which is released inside by the diabetic milieu and resulting in generation of something called transforming growth factor beta. The transforming growth factor is elevated, the resulting in fibrosis hyperplasia that alters the calcium, sodium, potassium channels and channelopathy occurs that resulting in ventricular arrhythmia, sudden death. There is one entity called cardiac autonomic neuropathy. What is cardiac neuropathy? The glucose is not being utilized, so alternate fuel is lipid, lipolysis. Because of the lipolysis, there is increased generation of triacylglycerol. That is the one which causes demyelination of the neurons, causing neuropathy, that is cardiac autonomic neuropathy. Because of triacylglycerol, it is mediated through the lipid metabolism. And it is found that because the vagus now starts in the middle, that is in the medulla, inhibitory center, it supplies almost all the viscera in the body. It's the longest nerve in the body. So it's get early to be affected in diabetic milieu. And that is the reason why autonomic neuropathy affects the vagal nerve. The vagal stops supplying from the there is a sinus node, atria, and stops at the AV node, does not go to the ventricle. Whereas the sympathetic node supplies entire heart, and the sympathetic innervation also can occur in prolonged exposure to the diabetes. It is found that how to make a diagnosis of sympathetic neuropathy, because by the decrease in blood pressure, there is a decrease in blood pressure, there is partial hypertension, and the fall in blood pressure during the hand grip is there when there is autonomic neuropathy due to diabetes. When parasympathetic neuropathy, you find out by the hand grip maneuvers and this pulsate variability. What happens there in diabetic neuropathy? There is sympathetic parasympathetic derivation. Because of the parasympathetic derivation, the sympathetic overactivation. Because sympathetic overactivation increases the heart rate, and the sympathetic overactivation in the night, there is a decrease in parasympathetic, resulting in increased sympathetic, and increased sympathetic due to increased derivation, that is resulting in the nocturnal hypertension. The nocturnal hypertension, one which is causing ventricular arrhythmia, that is a common cause for early morning death in patients with diabetes. So, what are the features of autonomic neuropathy? Not only the cardiac, patient may not directly present. Sometimes maybe the first presentation is a sudden cardiac death. Maybe a last presentation or first presentation. So it's very difficult to identify autonomic neuropathy early stage. So you have to go by the presence of other manifestations like GIT manifestation, and is present with the belching of gastric fullness, may be present with impotency, they present with hypoglycemia, unawareness, intermittent diarrhea, and post-hypertension. These are the features of autonomic failure. So these are the people prone for sudden death. What are risk factors for sudden death? It is found that diabetes is one of the most common risk factor. Among that, the 70 to 80% of the people with the coronary heart disease having the highest risk factor among all the risk factors, including cardiomyopathy and cardiac neuropathy. These are the risk factors. There are other causes of risk factor. CKD stage 4 and 5. How CKD can be a risk factor for sudden cardiac death? CKD is a heart, this is a kidney failure. How can cause sudden death? What happens in CKD? Like glucose, excess glucose, glycosation protein, like glycosation albumin. Similarly, excess urea, the carbamylation of albumin. The albumin is carbamylated. This carbamylated albumin triggers the conduction system, triggers the calcium metabolism, and alters the metabolism, causing sudden cardiac arrest. So the patient who are having CKD 4 and 5 prone for cardiac arrest because of this carbamylated albumin, not by the direct effect of the urea. So that is there. And nocturnal hypoglycemia, where nocturnal hypoglycemia, when patient is having autonomic neuropathy, the release of counteractive hormones like the adrenaline, glucagon, cortisol, all these are not happening. So the patient is not aware that sugar is gone low. Even below 30, they may not aware because the counteractive hormones are not released. If counteractive hormone release, like adrenaline is released, immediately patient wake up and craving for food and what also sweating, palpitation. So adrenaline is not released. And there is glucose also not released. Again, no compensation of the glucose. If your glucose, blood glucose goes below 30 for longer, more than 2 hours, patient will die. Neuronal death will occur. So that's what the concept behind it. CKD, diabetes, because of diabetes, hyperglycemia, and there is a non-enzymatic glycation of proteins resulting in glomerular artery sclerosis that is causing CKD. The CKD, because of CKD, this release of, that is longer duration of cytokines and the prolonged duration of reactive oxygen species are there because CKD is supposed to excrete to the kidney the cytokines that is not being excreted. So the longer duration of cytokines, longer duration of reactive oxygen in the blood because of CKD, that resulting in accelerated atherosclerosis. CKD sudden death is already alluded to because of this carbamylation of the elevated albumin. So your point here is the statins. That's here the CKD produce sudden cardiac death by increasing the carbamylated albumin. At the same time, the statins brings down or decreases the sudden cardiac death by bringing down the levels of carbamylated albumin. So here the role of statins there. All are interconnected. Increased blood urea nitrogen causing increased carbamylated albumin, excited that carbamylated albumin excitability of the conduction system that causing arrhythmia and sudden death. If you take HbA1c, if HbA1c is more than 8, they're prone for sudden cardiac death, but less than 1.8, less common. See the trivial, there is a marginal change in HbA1c makes a lot of difference, especially sudden complication of sudden cardiac death. The QT interval. QT interval, we generally say, what are drugs causing QT interval? What are disease causing interval? No drugs, no disease, nothing. The diabetes itself can cause, the diabetic milieu itself can cause prolonged QT interval. How? The excess glucose, hyperglycemia per se, hypoglycemia per se, excess insulin per se, by increasing cost, and retinopathy, neuropathy, nephropathy, potassium, calcium channel, all these factors is commonly disturbed in hyperglycemia that itself can cause QT prolongation, that can cause result in sudden cardiac death. And also, fortunately, ACE inhibitors and ERBs, and of course, the Mediterranean diet. What is Mediterranean diet? It is nothing but the intake of the vegetables, fruits, nuts, whole grains, in addition, omega-3 fatty acids, fish oil, and some moderate quantity of olive oil. These are nothing but Mediterranean diet. The Mediterranean diet will decreases or incidence of sudden cardiac death, in addition to ACE inhibitors, ERBs. But yet another, the important cause of sudden cardiac death now identified is obesity. What obesity does? Obesity, especially visceral obesity, where metabolically active fat, they release a lot of cytokines, especially the TNF alpha. The TNF alpha is a culprit. That is the one which stimulates and triggers the calcium channels and potassium channels, which is the conduction system that triggers sudden cardiac arrest. So certain obese individual can have this genetic called sudden cardiac death even without any other complications. The calcium potassium channelopathies, which especially when a potassium is less than 3 milliequivalents, that it increases the QT intervals that sudden cause the quantities and ventricular arrhythmia. If more than 6, they are prone, they can peak TV with the white chorus complex bradycardia. Again, it is prone for asystole and sudden cardiac death. So any change in calcium metabolism, any levels of change in potassium levels that results in sudden cardiac death. There are genes associated with sudden cardiac death. There are 5 genes that are identified: sodium voltage gated channel, subunit 5, rhinodine receptor, nitric oxide synthase receptor protein, TNF, there is a transferrin growth factor beta receptor, and the high adrenergic output gene. These are the 5 genes that are associated with the protein. Those who are having these genes are prone for sudden cardiac death. How to screen? How to screen? There is no treatment for sudden death because death in unexpected manner. There is no treatment for it. Only you can prevent it. So you have to screen for them. For those who develop the proneness, then you have to screen by ECG. ECG, of course, those who are having myocardial ischemia or myocardial infarction, whatever, so QT prolongation in ECG, you have to be very suspicious. You have to be taken all precautions to prevent sudden cardiac death, echocardiography, and of course, you can go for the angiogram, myocardial perfusion. So myocardial fibrosis, what is happening in the myocardium, the fibrosis can assess by the cardiac MRI. So whatever happening in the interstitium will be identify the MRI. Whatever happening in the coronaries, identify the angio. So if you want to pick up the person who prone for cardiac, do cardiac MRI, see assess the fibrosis level. We do not know what is the value of this fibrous scan. So you do fibrous scan for liver fibrosis. Probably we can apply the same scan for the heart also to assess the fibrosis. These are the candidates who develop fibrosis, perivascular fibrosis due to diabetes and prone for cardiac death. Cardiac arrest, sir. Yes, sir. Yes, and I proceed. Here is the problem. And of course, the CKD results in the drugs. Prevention of sudden cardiac death. There are drugs available. The most important drug being a beta blocker. They found that the beta blockers decreases the post-myocardial sudden cardiac death by 40%. Timolol decreases sudden cardiac by 44%. Propranolol decreases sudden cardiac by 28%. ACE inhibitor decreases the mortality, especially in patients with the congestive heart failure in the setting of post-myocardial infarction. And class 1C drug like encanate, flecainide also decreases the mortality. Class 3 drugs like amiodarone. These are the drugs, pharmacological drugs, which helps in prevention of sudden cardiac death. Statins, as I already mentioned, this supposed to brings down the carbon-monohydrate albumin, by thereby it brings down the sudden cardiac death. There are non-pharmacological measures, as I already mentioned, Mediterranean diet, which is rich in omega-3 fatty acid, which lowers sudden cardiac death. The lower levels of alcohol, especially alcohol lesser than 1 to 2 drinks per day, less than 3 drinks per day is beneficial. More than 3 drinks per day, probably it results in sudden cardiac death. Avoid smoking and exercise. Exercise, what's important? Exercise acts as a gene level. Exercise acts by augmenting the expression of genes involved in prevention of atherosclerosis and inflammation. So diabetes is inflammatory disease, whereas exercise is an anti-inflammatory process. So it acts as a gene level to prevent the inflammation and prevent atherosclerosis. Thereby, exercise improves the outcome. What are the exercise? Isotonic, isometric exercise. Volume mode exercise like swimming, running, biking, walking, yoga, etc. All this increases the myocardial length. You do not increase the numbers. You do only increase the size and increase the length. Whereas pressure load exercise like weightlifting, squats and push-ups, all these things, which causes hypertrophy, it increases the muscle function of the heart. What are the benefits of exercise? The exercise causes hypertrophy of the cardiac muscle by increasing the levels of insulin-like growth factor and also activation of PI3K. There is phosphorylated called 3 kinase activities increase that results in breakdown of the capillaries that causes a neovascular formation. The neovascular formation increases the perfusion, thereby increase the coronary blood flow. So there is no drug available to improve the for the circulation in the capillaries except the phenomena called this exercise that increases capillary perfusion, increases the neovascularization inside the myocardium through the capillaries. And also, it is found that 8 weeks of intensive exercise increases the endothelial function and improves the insulin resistance and gives the metabolic health, improves the capillary health. And also, we can have preventive ICDs. Preventive ICDs, there are a few roles for preventive ICDs. The following acute MI, class 2, class 3, NOHA with ejection fraction, left ejection fraction less than 35. We can do preventive, that is the implantable cardiac defibrillator. In class 1 also you can give if left ejection fraction is less than 30%, but inducible sustain or the sustained ventricular tachycardia warrants ICD. It also indicated in the case of HOCM, arrhythmogenic right ventricle, as cardiac sarcoidosis, Brugada syndrome, congenital long QT interval, non-ischemic cardiomyopathy also. These are the indications for the there is a the implantable cardiac defibrillator. So the prevention of sudden cardiac death, what happens is that how to prevent sudden cardiac death is to screen the people who are prone to the family history of sudden cardiac death, and you identify them and give them appropriate intervention like ICD, so that we can prevent sudden cardiac death in a family who had already history of sudden cardiac death. Educating the children, the schools, colleges, because they should know that sudden cardiac death is one entity can occur in diabetic individual without any other factors. So they should not blame the treating physician or the professionals for sudden happening, and they causing a lot of commotions, emotions in the public. So that can be avoided by educating the students at the college level and school level, workers, patients, and public. There's one entity called sudden cardiac death. This can happen. So let us not blame the doctors. Friends, let us focus on metabolic control, glucose control, lipid control, all the metabolism, other controls. Concentrate on a healthy diet, like less carbohydrate, less saturated fat, more fruits, vitamins, fruit, minerals. Exercise, like brisk walking, running, and improve the capillary health and also the metabolic health. Please run away from sudden cardiac death. Continuous effort in putting exercise and walking. Run away from sudden cardiac death. Thank you very much for questions.
Thank you, sir. It was a fantastic talk, sir. You gave a lot of micro mechanisms with regard to sudden cardiac death and the value of diabetes. As we have lesser time, we can move to the next topic a bit so. Thank you, sir. Thank you very much, sir. Now we request Professor Justin Paul, sir, a renowned cardiologist, interventional cardiologist, and man of great knowledge, to present this topic. Welcome, sir.
All of you, and thank you, chairpersons, and thank you, the team, Dr. Chandrasekhar and his friends for having invited me for this talk. I think this is not mine. Yeah, I think there is no laptop here. I need to look there. Now the topic that is given to me is protocol, STEMI. Yeah, I think they are connected. Yeah, STEMI protocol. Fine. So how many of you have not thrombolyzed, have not been involved in thrombolysis? I think all of you are very familiar with thrombolysis. Okay, I thought, okay, since it is something like, talking about STEMI protocol to physicians is something boring, because something that you have been doing all along. So I thought I'll just tell you how the protocol evolved over a period of time and where we are at this point of time. How does it move? This button? Yeah. The first innovation in STEMI care, I will say, is the genesis of intensive care units. And I think you will have to press it. I'm not able to move. Can you? Yeah. Is there a mic that I can stand there and speak? Is that okay? Oh, fine. You'll be doing it. The next advent is thrombolytic therapy. Next. Then came the primary angioplasty. And then came the STEMI care systems. So this are, I will say, as the innovations. Now, if you look back on STEMI protocol of 1912, almost a century back, they thought initially all MIs, they die. So this was the man who said that MI is not universally fatal. So there is some hope. And he said, every effort must be made to spare the patient of bodily effort. So bed rest is the best way forward. Next. So this bed rest continued to dominate the picture for the almost next 50 years. In 1923, there was a series on 19 patient series on bed rest, water restriction, diuretics. Next. And in 1928, you can see 100 consecutive patients with bed rest. The studies on bed rest for STEMI. And morphine was used, nitrates were considered contraindicated. Next. So bed rest was considered equal to heart rest. This was 100 years back. Next. So the first book on acute myocardial infarction reported in 1928 by Samuel Levin. So no electronic ECG monitoring was available. The nurses should keep on auscultating. So there is the protocol. Nurse every 15 minutes go and auscultate, and somebody feel the pulse. If it is irregular, you give quinidine. So this was the protocol in 1928. Next. So in 1944, there was a man, William Daw, who first wrote about the deleterious effects of bed rest. Next. So Loud and Levine then brought in the cardiac chair. So to prevent the risk of deep vein thrombosis and pulmonary embolism, they said it is probably good to allow the patient to sit in a chair. And Levine made a study of 70 patients, quickly shifted to the chair, and the mortality was 10%. 10% in STEMI in 1951 without lysis, without primary angioplasty, with bed rest and chair. Now, what is our mortality in our ICUs? We need to really look into. Next. The first edition of Harrison in 1950, treatment of MI. It talks about oxygen for pulmonary ralls and cyanosis, papaverine, and nitroglycerin for reducing spasm. Next. So Braunwald, you all know, very familiar with Braunwald. He was a resident those days in 1950s. He said, you know, they'll be keeping the patients on rounds, and they may not be surprised if they go and see the patient dead on bed the next day. Next slide. So it was not an uncommon finding when the resident goes to take blood. So bed rest was continuing to be prevalent. Next slide. Then 60s, you should really thank this man, Desmond Julian, who saved millions of lives by establishing the Cc concept. Next. So this protocol, he wrote to British Medical Journal. Patients should be admitted to intensive care, continuous ECG monitoring, and training the nurses in closed chest resuscitation. And then, you know, this was in the absence of physician, they should be trained to do massage. BMJ rejected this. Next slide. Because it felt it was irresponsible to suggest ICU care for MI patients. This was 1961. Next slide. So he wrote an article again on Lancet. It was accepted, the CCU concept. In 1964, Europe's first CCU was started in Edinburgh. And we should be happy, very early in Rayapeta Hospital, the first ICU of Tamil Nadu was started. We should be thankful to our teachers those days. I'm happy that I did my MD in Rayapeta Hospital. Next slide. The next innovation was thrombolytic therapy. Was it not sufficient to have intensive care? The next protocol was thrombolytic therapy. Next. So these are the early studies. FDA approved it before major studies. Next slide. Next. So in GC study, what they showed that was streptokinase was superior compared to placebo, 11,000 patients, and streptokinase came into the picture. We all started using streptokinase. But I am not too sure those who are trained in corporate hospitals are very jittery nowadays to use streptokinase because they're very comfortable with a single shot of tenecteplase. Next slide. So the next study, the landmark study was ISIS-2, which showed the vascular mortality was significantly less with the streptokinase compared to placebo. Then thrombolytics and streptokinase came into the picture and they are still living today. And I want to tell you that the National STEMI program as of this year concentrates primarily on lysis for STEMI. That is the protocol. Lysis for STEMI. Next slide. Then came the primary angioplasty. Cindy Grimes came out with the first study on primary angioplasty in MI, in New England Journal of Medicine, and showed that compared to retiplase, not retiplase, RPA, PAMI showed significant mortality and in-hospital benefits. And then came the Weaver meta-analysis, where he showed that with the large number of patients in multiple studies, primary angioplasty was able to save 21 lives in per 1,000 treated. So this is a very good number. People thought we all should shift to primary angioplasty. Then came the primary stent. People were hesitant to put a metal into the thrombotic environment. It was Greg Stone in 1998. He published a series of 312 patients with stenting in acute MI. And the in-hospital death was 0.8%. They showed that it was feasible. Same year, there is another study from Europe where they did a randomized control study of stent versus balloon, and they showed that in the follow-up, stent could save a recurrent MI and cardiac events in the follow-up over 6 months. So we started using a stenting. So primary angioplasty and primary stenting came into the protocol. As I think earlier Dr. Usha Sridham said, when you advise the art, we also need to know the science behind the art. So why we are advising all these things, we really need to know. Next slide. But however, next, what is really happening with primary angioplasty? Even in metropolitan cities, only 10% get primary angioplasty. And only 40 to 58% of Indian patients get STEMI in the large, you get thrombolytic therapy for STEMI in the larger data. If you look at the smaller rural areas, the numbers are likely to be very, very low. We don't have the data. So the number saved or mortality benefit is absolute number saved is only 1% between primary angioplasty and fibrinolytic therapy. So for the sake of primary angioplasty, should we hold on fibrinolytic therapy? Many times the issue of primary angioplasty is you don't have money, you don't have 1.5 lakhs, 2 lakhs, you don't have capable hospitals, you don't have transport facilities at all the time. So what do? That came the need for STEMI care systems. In a state like Tamil Nadu, we have say 8 crore population. We get about 90,000 STEMI per year. Almost 20,000 STEMI patients that die on bed, they don't get it, we don't even know what is that. And the remaining patients, they come. How many of them are taken care in the system? How many get die? So how many lives we can save by timely reperfusion? Timely reperfusion. Next slide. So as you know, there is no point in watering a field with dead plants. Kangattappine Surya Udayam Enda Pakkamanal Enakkenan oru paattu enakku Tamil nyabagam varudhu, Tamil song, old song. It is something like, if the muscle is dead, what is the benefit of reperfusion? But there is a harm in reperfusion, the muscle is dead. That is very important for us to know. It is not like a blind man and sunrise. This story is different. If you offer reperfusion to a patient after the beneficial time window, the harm is likely to be more. We need to be aware of this fact because many times patients, there is a 100% block, sir, I had a heart attack 3 days back. Remove it, sir, remove it, sir. There is harm in that. Post 72 hours, you have a 100% block. So, case by case, we need to really go by this. Next slide. So then came the pharmacoinvasive therapy. What they did was timely thrombolysis for every STEMI when you cannot take them for primary angioplasty within 90 minutes. Then after thrombolytic therapy, in about 2 to 24 hours, you do an angiogram. You shift the patient to a nearby hospital for an angiogram, do an angiogram, and if you find a critical block, that point of time you do an angioplasty. This is called pharmacoinvasive therapy. And fortunately, data showed that the benefit was equal to that of a primary angioplasty. So in a remote village, instead of rushing them 2 hours and 3 hours to go to a primary angioplasty, you lyse the patient then and there itself. In next 2 to 3 hours at a convenient time, when the relatives come and the finances are ready, when the transport is ready, when the road traffic is lean in the night, you shift the patient for the lesser traffic time. Next. So this was the multiple randomized data, and then the stream study came that showed that this is much superior to standalone thrombolysis. Next. So this is the concept of pharmacoinvasive therapy. Next. So what did we do in Tamil Nadu government? We did a study of the feasibility of thrombolytic therapy and this pharmacoinvasive therapy with streptokinase. All the studies elsewhere in the world were done by Connected Place. So we did the feasibility study, and when I was at Stanley, we did this study. And next slide. And I think I saw Satya Kumar sir here, and he was one of our spoke, and he was referring his patients after lysis from Sugam Hospital to Stanley Hospital for thrombolytic therapy. It was a public-private partnership. We worked on that. So these were the, and next slide. So we published it, next slide. So what we find was this kind of a system, where we call a hub and spoke system, where say a Stanley Hospital, Madras Medical College Hospital is networked to the nearby government hospitals where they lyse and shift. That improves access for primary PCA and pharmacoinvasive therapy. It produces cost saving to the community, and more below the poverty line patients are able to access the care. Next slide. So we formed our protocol, and next slide. And it underwent national review. Now, this is the standard protocol. When we say protocol, what do we do for a patient with STEMI in a hub hospital, in a spoke hospital? And this is what we follow and we train in the Tamil Nadu Heart Attack Management Program. Next slide. So, as you can see, the red dots are the places where we have installed cath labs at a cost of 4 crore each. Almost 80 crores we have got from National Health Mission to install cath labs in all these places. And these 192 blue dots are the district hospitals and taluk hospitals are linked up with these spokes so that they timely lyse the patient and refer them here. We also got 9.3 crores from Tamil Nadu, Planning Commission through Tamil Nadu Innovation Initiative to create the networking. What we are right now doing is doing this networking and training the protocol. Next slide. So these are various protocol trainings. Next slide. Almost most of the hubs we have finished the protocol training. Next slide. So till last month, we completed the protocol training. Some more trainings are missing, pending. So we also analyzed our system's efficiency and presented this in European Society of Cardiology last year during the COVID pandemic. What we found was we were actually doing 0 primary angioplasty in the government hospitals. We were able to increase it. But the COVID pandemic brought put a dip to it. So the thrombolysis was increasing. So what we found was we treated less number of STEMI patients, but more of them were lysed, but the mortality remained the same. What I am trying to tell you is timely reperfusion is more important. In fact, there was one study called Captain study that showed that first 1 or 2 hours, lysis is equal to primary angioplasty in the golden time window. Next slide. So this is another study. This is very close to my heart. So we see day in and day out patients going in. So we thought we'll make a small study. This is a 46 patients. 12 of them went to non-lysis capable hospitals. And 34 of them came to lysis capable hospitals, the first medical contact. Next slide. So there, 1 patient was referred to RGGH for revascularization, and 11 patients were referred to other hospitals. And 12 of them in 6 hours time window, now only 5 of them in 6 hours time window. You see that 6 numbers dropped. They went outside the time window. Next slide here. What happens here?
6 patients were lysed and referred thankfully, and 16 patients in lysis-capable hospitals were not lysed and referred. And here 12 patients not lysed and referred to other hospitals, and still 12 of them were in the 6 hours time window. Next slide. This is a second medical contact result. What we can find is 3 patients were referred without lysis in lysis-capable hospital, the second medical contact. And the third medical contact, next slide, next slide. Next slide. I'll put the summary. Next slide. What we found was, in all these green places, patients could have been lysed. Next slide. So thus, in 54 visits of STEMI patients in lysis-capable hospitals, within 6 hours time window, only 9 patients were lysed. 42 remaining patients were not lysed because they could not afford the reperfusion therapy offered. They were offered either primary angioplasty, they were offered pharmacoinvasive package, they were offered connected place or reticulase. Now, include all of them, almost 90% of them would have had 10,000 rupees. If they had lysed them with a streptokinase, we could offer timely reperfusion for this patient. I'm trying to increase this. I've done the 300 patients. I'm trying to send in for a publication. Next slide. So now, one word about streptokinase. How many of you believe, which gives more intracranial hemorrhage, streptokinase or connected place? Those who believe streptokinase, please raise your hands. Streptokinase, more intracranial hemorrhage. Okay. Now you can see this is a comparative step. This slide I made. Streptokinase versus comparator. In ISIS, GC2, a combination ISG and inject, streptokinase performed equivalently. It was only in GUSTO-1 there was a 1% benefit in mortality in streptokinase. I'm not telling that streptokinase is equal to connected place. This was not connected place, altiplase, but it is not bad. Next slide. If you look at the hemorrhagic rate, streptokinase is superior to connected place in terms of intracranial hemorrhage. There is a large misconception that streptokinase gives more intracranial hemorrhage. No. And you can see that, and again, reticulase is not equal to streptokinase. It has not been proven. Inject study, as you can see, it was a reticulase study. They showed non-inferiority, they could not show. Equivalence, they could not show. But there is more intracranial hemorrhage, but they didn't give the p-value in that article. Next slide. So what I'm trying to tell you is, patients need reperfusion at an affordable cost for STEMI. That is the protocol. Whichever center you are in, any patient with STEMI who comes in the reperfusion time window, please ensure that they get reperfusion. Streptokinase is not bad. If they can afford only streptokinase, please give that. If they can afford primary angioplasty, please do that. But do not send them to another place without linking with that patient. Supposing a patient comes in time window, a nearby hospital has a primary angioplasty, within 90 minutes they can do a primary angioplasty, please send them there. If they cannot do that 90 minutes and the patient cannot afford that, please lyse the patient there at an affordable thrombolytic therapy. And timely reperfusion STEMI is crucial, and primary PCI and feasible is better. Yeah, this is what I told. And first, and again I told, do not deny streptokinase because patient cannot afford connected place. The prime disadvantage is the need to give for a longer period, the likelihood of hypotension and allergies, and probably in the gastroangiographic sub-study, they said the angiographic patency rates are little less, but that has not been shown as a surrogate marker of mortality. And in the pharmacoinvasive system, we have not compared connected place in streptokinase. So whatever it is, when a child is hungry, it needs food. When the myocardium lacks blood, it needs blood. Please organize timely reperfusion. And thank you very much for the.
Thank you so much for the excellent exposition of the STEMI protocol. Due to want of time, sir has asked not to ask any questions. We close the session. We thank all the 3 speakers for the excellent talk. Thank you so much.
Thank you, sir. We would like to thank the organizing team for giving us the opportunity. Thank you, sir.
Thank you, speakers and the chairperson. I think for the want of time, we will quickly move on to the next session, the last session before the lunch. I think 2 speakers are there. For this, I invite Madam Dr. Jayanti. Dean of Omandora Medical College, and also Dr. our close friend, Dr. Satya Kumar, to chair the session.
Very good afternoon. It's heartening to see the in-person educational program after 2.5 years of pandemic raging. I'm told we are running behind schedule, so therefore I will keep the introduction very short. Thank you, organizers, for having me here this morning. Should I say afternoon? And I appreciate the efforts put in, the topics chosen, very well crafted lectures and very chosen experts for delivering those topics. I'm happy to share the chair with my co-chair. Without much delay, I'd like to give a very brief comment on the topic as well as the speakers. The topic for today is very, very vital. I think we've almost forgotten non-communicable diseases for 2.5 years. It's time we start business as usual. And so here we are with two big experts talking on very important and burning topics. One on diabetes and kidney disease, the challenges faced, by Dr. Edwin Fernando. Edwin doesn't need an introduction. He is part and parcel of nephrology at Stanley Medical College for years, for several years, several decades, I should say, an expert in the subject. Following by teacher of teachers, Dr. Narsingan, who talk on triglycerides, control or not in diabetes. Now I would request my co-chair to offer us comments before the session begins.
Now the talk is about challenges in diabetic kidney disease. I'll make it brief. The challenge starts with the number of CKD patients to be treated, because the number is increasing phenomenally because of the increased number of diabetics. And second one is the the CKD doesn't follow the set pattern of microalbuminuria, albuminuria, and then renal dysfunction. It's because of that we need some better diagnostic markers to identify CKD patients. And also we need some markers where we can identify people who progress to ESRD in CKD patients. If these markers are available, probably we'll be able to treat them aggressively to prevent this ESRD. But now with good drugs like the SGLT2 inhibitors and now fentanyl, the things are looking promising, but still a lot of new developments are happening. I request Dr. Edwin Fernando to enlighten us on this.
Thank you, sir. Respected chairpersons, senior colleagues, and friends. We thank the organizing team, Dr. Chandrasekhar, for asking me to speak on this very important topic, the challenges in diabetes and kidney disease. I bring to you warm greetings from the Government Stanley Medical College. So this is a very recent publication in the Lancet, which talks about a huge cohort of 75,000 patients, where the prevalence of CKD is about 14% in the general population and about 36% in the high-risk population. High-risk population meaning diabetes and hypertension. And what is very alarming is 31% of people with diabetes were really unaware that they had the disease itself. These are figures not to be very proud of, the prevalence of diabetes in our country. Way back in 2003, we were leading, and we are likely to lead again in 2025. This is the Indian Chronic Kidney Disease Study, which is ongoing, and 37% of patients in this study, the CKD was because of diabetes, chronic interstitial nephritis, and CKD of unknown origin were other causes. Diabetes is the leading cause of renal failure. You could see this, the green line shooting over the others. And what it means to have diabetic kidney disease, it shortens lifespan by 16 years. And this is again very alarming. Look at the number of people who are projected to have diabetes by requiring kidney replacement therapy by 2030. It's almost double. Look at Asia, we are far ahead. Now, the challenges we face in diagnosing diabetic kidney disease starts from screening, diagnosis. We have the non-albuminuric diabetic kidney disease, which Sir was mentioning, non-diabetic kidney disease, acute kidney injury in diabetes, and cardiovascular disease. So we shall go one by one. This is classic diabetic kidney disease. Somebody has proteinuria, presence is edema, proteinuria, hypertension, progressive fall in GFR. This is the components of the classical diabetic nephropathy. So how do we screen for diabetic kidney disease? At least annually, the urinary albumin creatinine ratio and eGFR should be done in all patient diabetes type 1 after 5 years and in all type 2 patients at diagnosis. Number one. Number two, patients with diabetes and urinary albumin more than 300 milligrams per gram of creatinine and a eGFR of 30 to 60 should have the UACR screening monitored at least twice a year. Now, what it means, what does albuminuria mean? It means that there is damage to the glomerular basement membrane. It independently predicts cardiovascular disease. And this is a standard of diabetes care. 40% of people are identified with CKD based on urine albumin, and 50% of diabetics with CKD do not have albumin. So this is where the problem starts. It's an important prognostic marker and used to monitor and guide therapy, and is included in the definition of stage 1 and stage 2 of CKD. Now, which test to use? The dipstick. This is affected by the urinary concentration. It's highly variable. More than 300 milligrams per day of urine albumin is 1+. Now, the urine protein creatinine ratio is again becoming very non-specific because it includes all proteins and not only myeloma and not only albumin. The best test would be the urine albumin creatinine ratio. It quantifies the urine albumin. So this is being worked as a standard for public health, clinical care, and research. So this is the definition of albuminuria, and you know the new guidelines classify albuminuria as mild, moderately, or severely increased, and microalbuminuria is called moderately severe albuminuria. Now the UACR is a continuous variable. So the creatinine, why do we include the creatinine here? Creatinine assists in adjusting the albumin levels for varying urine concentrations, which allows for a more accurate results versus the albumin alone. So this is used as, this ratio is for quantification of proteinuria. First morning urine sample is preferable, and a 24-hour urine test is rarely necessary. However, you must make sure that your lab is sensitive and also calibrates its equipment to do this test precisely. Is it a very foolproof test? No, not at all. There are so many variables that could affect this result, starting from menstrual blood contamination, UTI, exercise, smoking, etc. So here is a test that is very sensitive, but not very perfect. Now coming to the diagnosis, it's very simple. Now look at serum creatinine. Now if you do creatinine in 10 labs in the city, you will get 10 different values, especially if the creatinine is on the high side. So a 0.6 to 1.2 is very vague. So this does not account for muscle mass because creatinine is a muscle protein, age, gender, race. A typical example, a 28-year-old African-American creatinine 1.2 has a GFR of more than 60. However, a 78-year-old white woman with a creatinine of 1.2 has a eGFR of 43. So this 1.2 creatinine does not really mean anything. And please remember that the serum creatinine and the GFR are not in a linear relationship. You recollect your trigonometry that we learned in high school. This is a hyperbolic parabola. It's not a straight line. So a creatinine of 2 milligrams could mean a GFR drop of 50 ml only, assuming that the GFR is about 100 ml. So what is a mild renal failure of creatinine of 2 actually means an eGFR drop of 50%. So serum creatinine does not reflect the GFR. An 80-year-old man with a creatinine of 1 does not have a GFR of 90 mils. And if you're measuring serum creatinine and trying to deliver care to the patient, there's going to be a significant delay by the time the patient reaches the appropriate care. So the GFR should be measured. Now, the guideline is the serum creatinine eGFR should be measured. So what are the formulae? You all have smartphones. You can have these calculators in your phone. The CKD epi equation is one that's used to measure the GFR in normal individuals, somebody with GFR of over 60. For example, for all prospective kidney donors, we use the CKD epi equation. On the other hand, we have the MDRD formula. Now, this MDRD formula should be used for GFR of less than 60. And recently, this is September 21, where the race has been actually excluded because there's a lot of disparity in the equity of care given to patients, especially in the West, where there's a difference between the Hispanics, the whites, the African Americans, etc. So the race has now been excluded. That's good news. Now, is serum creatinine foolproof test? No, not at all. I told you that it doesn't match with the eGFR at all. There are so many other factors. Main thing is sarcopenia. Somebody who's very lean with a lean muscle mass could have a falsely low serum creatinine. So creatinine is not a very sensitive test. Now, what is the criteria for the diagnosis of CKD? A eGFR should be less than 60 mils. The UACR should be more than 30 milligrams per gram, and the urinary albumin excretion rate should be more than 30 milligrams. Now, albuminuria is not necessarily associated with a decline in GFR. There occurs a group of patients, nearly 50% of them, where proteinuria does not always precede the loss of renal function. So the classic transition from microproteinuria to overt proteinuria does not happen. Decline of GFR without proteinuria is being increasingly recognized. Renal insufficiency happens in the absence of albuminuria and retinopathy. And in population-based studies, about 50% of decline of function of kidney function, these patients do not have a preceding proteinuria. So there seems to be a non-albuminuric path for the progression of diabetic kidney disease. So if you look at this figure, the classical proteinuric path is diabetic nephropathy. Combined, it could have a primary glomerulopathy also, where there's elevated proteinuria, and then you use ACE inhibitor or depending on the glomerular disease, steroids, etc. While you have a non-proteinuric path where there's predominantly vascular and interstitial changes, there is a decline in eGFR, and we really do not know how to take care of this group other than to control the blood pressure. So this is the risk factors for non-proteinuric DKD: obesity, overweight, high systolic BP, female gender, probably hormones, hyperfiltration, chronic hyperglycemia, tubular hypertrophy, tubulointerstitial damage, repeated episodes of AKI, especially UTI, pyelonephritis, drugs used to treat them, interstitial nephritis. All this contribute to glomerulosclerosis and contributes to non-proteinuric diabetic kidney disease. So this is the trajectories. You look at the classic DKD trajectory that goes through the various stages of proteinuria. While you have a non-proteinuric kidney disease, which has a much more a different course. So this trajectory will help you to understand this non-proteinuric kidney disease. So this is renal dysfunction in the presence of normoalbuminuria. This is a demand study. And what is very classic is look at the presence of normoalbuminuria, and even in patients with stage 1 CKD, stage 5 CKD, you find the proteinuria is not much. So this is a large study, 11,000 odd patients. 17% had normoalbuminuria in stages 3 to 5. And creatinine clearance was less than 60 in nearly 20% of the normoalbuminuria. So there occurs a large proportion of diabetics with completely normal urine albumin excretion or microalbuminuria who present with significant kidney dysfunction. So when to suspect diabetic or non-diabetic kidney disease, classically it is retinopathy, which can be present about 40 to 60% of type 2 diabetics. When to suspect other causes, the younger patient short duration of diabetes, atypical presentation. These are the different causes of non-diabetic kidney disease, which could be a glomerular disease, tubulointerstitial disease, vascular disease, and other systemic causes. How common is non-diabetic kidney disease? Go through the literature, nearly about 30% of patients with diabetes have renal impairment due to non-diabetic kidney disease. So we have urological problems, ischemic nephropathy, renal artery stenosis. Somebody's got resistant hypertension. You must look at the renal artery stenosis, hydronephrosis, papillary necrosis, complicated UTI, autonomic neuropathy of the bladder, repeated attacks of pyelonephritis. All this contribute to the non-diabetic kidney disease. Again, if you look at the biopsy series, normally we don't biopsy a diabetic, but whenever we suspect there's a massive proteinuria, then you look at a diabetes, you find so many other glomerular disease that could happen in a diabetic. So is it DKD or when to suspect other cause of DKD? Because the treatment of this glomerular disease may be entirely different from the treatment of classical diabetic kidney disease. So we need to prognosticate, plan long-term renal replacement therapy and then treatment option. This is the importance of recognizing a non-diabetic kidney disease. So hazard ratio for development of ESRD in diabetic kidney disease is about 7.1. While in non-diabetic kidney disease, it's much lower. The rate of fall in GFR in a diabetic kidney disease classically is about 8 to 12 ml per minute per year. So when to suspect non-diabetic kidney disease, rapid onset proteinuria. Whenever there's a natural history of patient type 1 diabetes, because the majority of patients that we see are type 2 diabetics. Rapid deterioration, renal function, obstruction, infections, drug-induced acute interstitial nephritis, cardiorenal syndromes, placentic glomerulonephritis, active urinary sediment. When you find RBC cast in the urine, always keep in mind that that could be some other glomerular disease. A classical diabetic kidney disease does not have microscopic hematuria or macrohematuria. Whenever there is a precipitous fall in GFR and you initiate an ACE inhibitor of ARB, this could be the harbinger of significant renal artery stenosis. The GFR is maintained because of the efferent arteriolar vasoconstriction. When you use an ACE inhibitor or an ARB, there's going to be a precipitous fall in GFR. Coming to the other important topic, prevention of AK in a diabetes. See, already you have a GFR that's low, either diabetic or a non-proteinuric pathway. Now, this is a patient who's prone to develop AKI. It could be a pre-renal cause, volume depletion, congestive heart failure, NSAIDs, diuretics, RAS blockade, vascular cause like renal artery stenosis, intrinsic kidney disease, IRGN. Somebody could have a foot ulcer and that could produce a post-infectious or infection-related glomerulonephritis, sepsis, contrast, drugs, acute interstitial nephritis due to multiple causes. Many of our patients they seek alternate systems of medicine and they land up with very bad interstitial disease. And obstruction, always to be kept in mind, stones, papillary necrosis, fungal UTIs, fungal balls, and diabetic cystopathy. This is a large study that looked into AKI in patients with diabetes. Nearly about 25% of patients who were hospitalized had AKI. And if you look at the all-cause mortality, again, is high in this group, nearly 40%. So this is about 4,082 patients with diabetes. So look at the graph here. As the number of episodes of AKI increase, you find that the mortality keeps on increasing, survival is poor. So AKI episodes are associated with cumulative risk for developing advanced kidney disease in diabetes, independent of other factors of progression. And again, this is what we see very common, that this AKI is proceeding to CKD. Normally, an AKI would recover this way, the brush borders establish, the epithelial cell integrities back. But here we have something called maladaptive recurrence, which is epigenetically determined. So there is a group of patients who would not recover kidney function at all. A creatinine of 2 due to diabetes will increase to 6 with a pyelonephritis and get stuck at 6. Okay. So this is because of multiple epigenetic changes, persistent inflammation, unopposed action of TGF-beta, etc. So this is what we increasingly see. And these are the risk factors for AKI to CKD transition. The higher the age, number of AKI episodes, etc. Multiple episodes of AKI, etc. Cardiovascular disease, frequently accompanies all diabetics. And we know the majority of patients with CKD with diabetes die because of cardiovascular events, even before they reach end-stage kidney disease, sudden cardiac death. Lack of awareness about DKD is another major challenge that we face. 57% of patients in stage 3A did not know that they had kidney disease. 30% in stage 3B did not know that they had kidney disease. Now, these are well-formulated studies that looked at the systolic blood pressure and the decline in GFR. So the X that I have marked there is no treatment. And with the different studies, you have shown that the mean slowing of 58% per year of eGFR decline can be made with ACE inhibition or ARBs. So what is a decline of 4.2 ml per minute per year can be brought down to 1.8 ml per minute per year. New therapeutic strategies, plenty of them have been tried, none of which are really useful other than ACE inhibitors, ARBs. However, amidst all these challenges, please remember we have a lot of opportunities to treat diabetes. Biomarkers, which Sir was mentioning about, we don't have anything as of hand now, but maybe one of these biomarkers could help us to detect the disease early. And these are the novel therapies that we have right now. The metabolic factors can be controlled with the GLP-1 agonists, SGLT2 inhibitors, which both act hemodynamically as well as metabolic. And the RAS inhibition has always been there. There's always options of looking at other pathways and ASK1 inhibitors and inhibitors of demethylation, which could be a challenge. We all know about the Credence, DAPA-CKD, and the EMPA-Kidney studies, which have proved beyond doubt that these drugs are wonderful in the treatment, the prevention of diabetic kidney disease. One has to weigh the advantages and disadvantages, and it's very clear that the cardiovascular benefits and the renal outcomes are much better with these drugs. Aldosterone is an old hormone with renewed interest. Aldosterone excess strongly associated with cardiovascular and all-cause mortality in patients on chronic hemodialysis. Findrinone is a drug that's going to be available next month. The oral non-steroidal mineralocorticoid receptor. We had spironolactone, we had eprilonone. Eprilonone is still there, predominantly used in cardiac disease, but we now have Findrinone, which is going to be available next month, has been approved by the US FDA. And this is the Fidelio DKD study, which has been widely spoken of, and the graph there shows the clear difference between the patient on Findrinone and the patient with placebo. So there is an 18% reduction in combined primary endpoint and good safety profile in normocalemic type 2 diabetes with albuminuria, CKD, G2 to G4. The only worry here is hyperkalemia, which could be monitored. So if you look at the multifactorial interventions that could be beneficial, if you look at this red dotted line, that's no intervention. This is how fast your GFR will fall. But if you use a RAS inhibition, it is delayed. If you use an SGLT2 inhibition, it gets further delayed. And if you're going to use the combination of MRA, the mineralocorticoid receptor antagonist, it's going to further delay the progression of CKD. So I would wind up here by saying, screen for kidney disease by UACR annually or at least twice a year, check for eGFR. Glycemic control is the key. There's no substitute for that, and blood pressure control is mandatory. Once overt proteinuria happens, the only thing that could save the kidney is intensive blood pressure control. Recognize non-diabetic kidney disease because treatment could be entirely different. Identify the group that have non-albuminuric DKD. Screen for cardiovascular disease. Look at prevention of AKI. Of course, we have a lot of hope in SGLT2, GLP-1 receptor agonists, and the mineralocorticoid receptor agonists. Thank you very much for the patience.
Thank you, Dr. Vijay Fernando. You have shown us that it is less challenging to treat diabetic kidney disease, but the want of time, we cannot take any questions. Thank you. I'll go on to the next topic. Professor S.N. Narsingh will be talking on can triglycerides reduction minimize cardiovascular risk in diabetes. He doesn't need any introduction. He's the authority on lipid management in our country. He's one of the experts in the panel who formulated the Indian guidelines on lipid management through Lipid Association of India. So now there is renewed interest in reduction of triglycerides because so far everything was centered around only LDL reduction because we did not have enough evidence in the form of RCTs. But last few years we have got very strong evidence through certain studies which have thrown light on reduction of triglycerides, benefit on coronary artery disease. So all these aspects will be now dealt with the most apt person, Professor S. N. Narasimhan.
My honor to introduce the speaker, a teacher of teacher, my own teacher, authority on lipids in the lipidology. The topic itself assumes importance. Why we should control triglyceride. There are, as Dr. Satyaraj had said, there are enough and more compelling data and evidence to show that reducing triglycerides in the background of risk factors such as diabetes is of paramount importance, and we're going to hear from Dr. S. N. Narasimhan. Over to you, sir.
Good afternoon, everyone. Thank you very much, respected chairpersons. At the outset, I would like to thank Dr. Chandrasekhar and his team for giving me this excellent opportunity to be with you this afternoon to talk on can triglyceride reduction minimize the cardiovascular risk in people with diabetes. Look at this data, which we got it from arteriosclerosis way back 1933. It was published. In the absence of hypercholesterolemia, maybe LDL cholesterol or remnant cholesterol, this is where I would like to stop and tell you. The remnant cholesterol was identified as one of the important risks for atherosclerosis, which is now giving a lot of importance now in the last 5 months, 5 years or so. People have started showing a lot of interest in the field of remnant cholesterol. So it is actually impossible to cause atherosclerosis in an experimental model, which appeared way back 1933. It is still valid. In fact, if you ask about the lipids and the lipoproteins, they are all associated with atherosclerosis in general and coronary atherosclerosis in particular. Out of all the lipoproteins, it is LDL cholesterol that plays a central role, not only in the initiation of atherosclerosis, but also in the progression of atherosclerosis, ending in clinical cardiovascular event, including sudden cardiac death. We need to remember what is the evidence to talk about the LDL role. Number of evidences. The best evidence is familial hypercholesterolemia, where you have higher levels of LDL cholesterol, pushes the patient for early coronary, even premature death, which occurs even in children. Let us talk about the other evidence which is robust. What is that? Randomized control trials, which are shown beyond doubt. The more the reduction that we discussed, not only in primary prevention trials, but also in secondary prevention trials, it is clearly seen that the HMG coenzyme reductase inhibitors usage had brought down not only the morbidity, but also the mortality in cardiovascular disease. That is the best evidence. So our aim has to be only on LDL all the time. It must be lowering LDL and keeping it low throughout our life. That should be the prime focus of prevention of atherosclerotic cardiovascular disease. When we talk about the diabetic dyslipidemia, we have a specific terminology called atherogenic dyslipidemia, which normally is high triglycerides, low HDL, increased proportion of small dense LDL cholesterol with an increased ApoB content. Let me now try to tell you how important it is to identify the lipid abnormalities in people with type 1 and type 2 diabetes. Type 1 diabetes, as long as they have the glucose control, they will not have any sort of differences in the lipid parameters, and they will be almost equal to the controls. Whereas in type 2 diabetes, you have triglyceride rise, VLDL increases, IDL increases, non-HDL cholesterol goes up, HDL comes down, the normal LDL cholesterol. I would like to tell you the normal LDL cholesterol even in people with type 2 diabetes. The small dense LDL cholesterol goes up, particle number goes up, ApoB levels also go up. When a patient has got abnormal, inadequate control of blood sugar, you have the same parameters, but there will be slight increase in the LDL cholesterol. That's the one which attracts our attention here. In people with the diabetes, always you must know that the triglycerides are associated with increased coagulability. There is an increased plasminogen activator inhibitor, and factor 7 abnormalities can occur along with hypertriglyceridemia. The activation of prothrombin to thrombin also takes place in presence of hypertriglyceridemia. We need to remember, not only in people with diabetes, whenever you have hypertriglyceridemia, you need to remember that there is always an increase in the non-HDL, there is always an increase in the small LDL particles, there is always an increase in the small LDL particle number. What is important is the non-HDL cholesterol is now considered as a greater predictor of cardiovascular risk when compared to LDL cholesterol. This is about the non-HDL cholesterol. If you remove the HDL cholesterol, whatever is remaining, that is considered as non-HDL cholesterol, which includes LDL, IDL, VLDL, VLDL remnants, lipoprotein little, and then the chylomicron remnants. Everything comes under the subcategory of non-HDL cholesterol, where you have ApoB all the time. Look at the ApoB 100, 100, 100, except for the chylomicron, which has only about ApoB48. Having seen this, this is a picture which I thought I should probably request you to concentrate. This is about the HDL cholesterol, you remove it, LDL cholesterol, you remove it, you remove the lipoprotein little, whatever is remaining there, IDL, VLDL, VLDL remnants, chylomicron remnants, they are all coming under the remnant cholesterol. Very, very important information. We ask for the lipid profile. We know that the HDL cholesterol is directly measured. LDL cholesterol, most of the laboratories, it is directly measured, except that people follow a Friedewald formula. In the past, nowadays, we don't follow that. And the remnant cholesterol is the one. How to identify? This is not by your any laboratory test. All that you need to know, total cholesterol minus HDL cholesterol, you get non-HDL cholesterol. From non-HDL cholesterol, you remove LDL also. That means you are actually getting a figure and that demonstrates that is the component of the remnant cholesterol. Lipoprotein little mass, we actually measure it. These are the three test tubes which contain the so-called plasma. On the left side, you have the plasma, which is actually removed all these RBCs. Then you have the plasma. It is yellowish in color, which may contain the LDL cholesterol, which may contain the lipoprotein little, pushes the patient for an early cardiovascular event. The middle one, which is actually turbid plasma, where you have the remnant cholesterol, which are very high, the triglycerides are high. These are the people who are likely to get more cardiovascular events. The last one is the milky white serum of the plasma. You have the chylomicrons, which are very much increased, the triglycerides are very much increased, prone to get repeated attacks of pancreatitis, and probably less amount of cardiovascular disease. Having seen this, this is about the remnant cholesterol. Look at the data. Whenever you have an increase in the triglyceride level, starting from 1 millimole, that is about 88.9 milligrams of triglyceride, going up to 5, nearly about 500 milligrams of triglyceride, you have an increase in the remnant cholesterol. That is what I thought I should probably impress upon you, that whenever you have an increase in triglyceride levels, you have an increase in levels of, not be forgotten, because that has gained lots and lots of importance in the recent past, connection with atherosclerosis. Having seen this, we know any primary prevention trial, secondary prevention trials, you always encounter the problem of residual risk, where the people are likely to get an attack in spite of the fact that these people receive adequate dose of statin or higher dose of statin. That means you need to go away from LDL and look at some other parameter. What is that? Is triglyceride a cardiovascular risk? Look at this data from PRO-VICTIMI-22 trial, which was conducted in people with acute coronary syndrome. People who had higher levels of triglyceride, more than 200 milligrams, had recurrence of events, like again another attack of myocardial infarction or death can occur in those people in whom they have identified that the triglyceride levels were very, very high. Having seen this, I need to take you to the genetic study, very important, ApoC3 levels. Whenever you have an increase in the ApoC3 levels, you have hypertriglyceridemia. So if you have a loss of function mutations of ApoC3, you do get the triglyceride levels lower. In this study, which included about 75,000 participants and 34 years of follow-up, it clearly indicated compared to the levels of 350 milligrams of triglyceride, people who had levels less than 90 milligrams had shown a reduction of cardiovascular disease by 60%. The next question comes, can we treat triglyceride to reduce the cardiovascular risk? That's the question which has to be probably now answered. You look at the data from fibrate trials. You have bezafibrate, you have gemfibrozil, you have fenofibrate, all those fibrates. You look at individually all these trials, it may not be giving a lot of information about the cardiovascular benefit. You pool the data and try to do a meta-analysis. You will see that about 35% risk reduction in cardiovascular disease in those people who received a PPR alpha agonist, that is fenofibrate. Can we depend on this meta-analysis? In fact, fibrates have not shown any sort of benefit in cardiovascular risk reduction. So I will not recommend fibrate to be used in controlling a triglyceride, except when the levels are going beyond 500. Want to say that probably you can give it to save the patient from acute pancreatitis. Having seen this is an excellent study, ladies and gentlemen. This is reducive trial. The reducive trial which had shown both men and women above the age of 45 years, established coronary artery disease, established risk of coronary artery disease, or a diabetic persons with more than one risk factor, or atherogenic dyslipidemia, where you have hypercholesterolemia under control. People who were recruited for the study, they had their LDL cholesterol down to 70. And they had taken those patients into consideration for this particular study, reducive trial, where they have used icosapent ester, which is an EPA, which was used 2 grams in the morning, 2 grams in the evening, good follow-up of nearly about 4 to 6 years for the initial follow-up, and people actually had a median follow-up of about 4.9 years. And you can look at the data. Reduction in the primary endpoints by 26%. Secondary endpoints came down by 25%. I think this is the first study to say in people with hypertriglyceridemia, very high risk, diabetic people, established cardiovascular disease, you give them icosapent 2 grams and 2 grams in morning and evening, you get a benefit of reduction of cardiovascular events to the extent of 26% primarily, and the secondary endpoint of 3%. First study emphasized the role of reducing the triglyceride even in people with diabetes. That's the message what I thought I should give it to you. What are the advantages? Umpteen number of advantages. You can just look at it. The triglyceride levels come down to about 39 milligrams. Change in the LDL cholesterol, no, not at all. The CV death came down. All-cause mortality came down. Revascularization, submission also came down. Thereby emphasizing that this is probably a wonderful drug which can probably reduce the triglyceride in most of them. Even those people who did not reduce the triglyceride also have shown benefit. You can look at the beneficial effects of the EPA, that is icosapent ester, which has shown improves endothelial function, reduces the plaque size, improves the lumen size, so many things which I don't want to tell because of the lack of time. Ladies and gentlemen, it is my duty now to talk about the triglyceride-rich lipoprotein particles. Very, very important message. Whenever you have a triglyceride-rich lipoprotein, there are higher levels of triglyceride. Number one, it creates an inflammation, it creates atherosclerosis, push the patient for myocardial infarction. And what are you expected to do in that situation? To reduce the triglyceride. At the same time, you can reduce inflammation. That probably you can aim for a reduction of the cardiovascular events. How are we going to do that? Do you have any data? Look at the data derived from Copenhagen heart study and Copenhagen general population study. The study included nearly about 96,000 people. In this Copenhagen study, which was conducted in Denmark, nearly 3,287 events were occurring and myocardial infarction. The events were actually about 5.1 hazard ratio in those people in whom they had hypertriglyceridemia going above 528 milligrams. The second one about the ischemic stroke, the same increasing triglyceride levels in non-fasting state can push the patient from ischemic stroke to the extent of 3.2 hazard ratio. All-cause mortality is also higher in those people in whom you have hypertriglyceridemia or high triglyceride levels. Observational data has shown repeatedly that the LDL cholesterol observational data, you can just see the hazard ratio on the lower side. Look at the other one, the hazard ratio for the remnant cholesterol is actually exceeding, thereby showing the remnant cholesterol is much, much more important than the so-called LDL cholesterol. The Copenhagen study, they have analyzed how many people are there with 1 millimole. Just see about 27% of them are having only 1 millimole, 88 milligrams of triglyceride. Nearly about 46% of them are having between 1 and 2, around 170. That's why the ACC I mean, the American College of Cardiology tells you that you should keep the levels less than 170. Whereas the Lipid Association tells you that it should be less than 150. Please remember that. 27% of the patients also had higher levels, but just look at it beyond 2 and going up to 6, 10, and all. You have about the one that I was projecting it more of triglyceride-rich lipoprotein particles or the remnant particles, which is seen in the test tube in the middle. The last 1.1% is the milky serum, which contains mainly the chylomicrons. Having seen this, the same Copenhagen study conducted by Dr. Scott actually is coming for the next month to our Lipid Association of India International Conference. This gentleman had analyzed the data, nearly about 35%, 1/3 LDL, 1/3 were having HDL, nearly 1/3 of them were having IDL and VLDL. So very, very important data is what I thought I should share it with you. Increasing body mass index can push patients to accumulate more and more remnant cholesterol, what is seen as the last one. Even those people who consider as normal, even increasing BMI levels in the normal range, which is marked as green, also showing an increase in the levels of remnant cholesterol. So remnant cholesterol is dangerous now. Having seen this, LDL has got the capacity to penetrate the subendothelial surface, reach the intima, because less than 70 nanometers. So then what is seen is your remnant cholesterol can pass through, yes, reaches the intima, but the remnant cholesterol is acted upon by a lipoprotein lipase, an enzyme which pushes a lot of free fatty acid on monoacyl glycerol, which increases the inflammation, which leads to macrophages, foam cells, macrophages. Look at the last one, chylomicron, huge one. Lot of triglyceride, very small amount of cholesterol. It cannot enter the subendothelial surface. It cannot enter. Only these two things can easily enter into the subendothelial surface and create atherosclerosis. People in whom you have hypertriglyceridemia, simultaneously they analyze the high sensitive CRP. High sensitive CRP is taking a higher level, as when the triglyceride levels are going up, you can see the high sensitive CRP is also going up. On the contrary, look at the LDL levels. When the LDL levels are going up, the high sensitive CRP is coming down. It is not going up. So high sensitive CRP is connected with the so-called triglyceride and the triglyceride-rich lipoprotein particles. Having seen this, let me now try to tell you the triglycerides, chylomicrons, creating inflammation and then causing the pancreatitis. The triglyceride-rich lipoprotein particles, the VLDL remnants, the triglyceride portion probably is involved for the so-called fatty acid production and inflammation, whereas the cholesterol component of the VLDL remnants are responsible for foam cell, atherosclerosis, myocardial infarction. Having seen this, when you have an increase in the levels of chylomicrons, you see pancreatitis. When you see an increase in the levels of LDL, the atherosclerotic cardiovascular risk goes up. Whereas the myocardial infarction goes up to some extent beyond 500, beyond 1000 milligrams of triglyceride. You don't get much of problems with myocardial infarction. It is going down. Please remember, pancreatitis is more, myocardial infarction is coming down. Having seen this is an excellent projection made by Dr. Scott. What is normal? In fact, the Lipid Association of India recommends that those people in whom you have a very, very high risk, you need to keep the levels of LDL cholesterol less than 30 milligrams. We are reaching almost to the levels of newborn based on many, many studies starting from 4A study. So the CTT meta-analysis, cholesterol treatment trialist collaborators have come out with data. The 21 trials, LDL cholesterol coming down by 29%, ASCVD risk comes down by 22%. Now look at the one on the right side. You can see the reduce it trial, what I have shown, reduce it trial. Reduce the triglyceride by 20%, the CRP. The CRP levels go up in people with triglyceridemia. So you can just see 40% reduction. ASCVD reduction is also 25%. So ladies and gentlemen, that tells you that beyond reduce it trial, probably you should go on aim for reduction of triglyceride. 170, 150. Probably 150 will be ideal. Optional will be 100. Optional will be 100. So probably we are now reaching to the newborn level. The newborns are born with only 30 milligrams of LDL cholesterol. Please remember that. So the chain of events which I started with my slide, the high triglyceride pushes patient for inflammation, atherosclerosis. How to reduce it? Reduce the triglyceride, reduce the inflammation. What is the best trial that we have learned now today? Easy trial, reduced trial, which has shown reduction of CRP also. So having seen this is about the latest data. VLDL cholesterol accounts for one half of the myocardial infarction. Remnant cholesterol and not the LDL cholesterol is associated with incident cardiovascular disease. These are all the latest studies, which I don't want to tell because of the lack of time. PCSK9 inhibitor is the best drug to reduce not only LDL, even the triglyceride-rich lipoprotein particles, the VLDL particle number comes down, ApoB comes down. The one drug that can reduce the lipoprotein little a is PCSK9 inhibitor. Having seen this, let me now try to take you to our recommendation. If you permit me to have only 2 minutes of my last, is it okay? 2 minutes. Lipid Association of India recommendation, if people having 150 to 199 or 200 to 499, what are they expected to do? Try to assess the LDL levels, assess the atherosclerotic cardiovascular risk, advise lifestyle modification, and concentrate on the reduction of LDL cholesterol with a statin with an ezetimibe. Okay, the next one is the patients are having more than 500 but less than 999, aggressive lifestyle. Then very aggressive lifestyle changes if it is going beyond 1000. Aggressive lifestyle management is most important for reduction of triglyceride. Start the patient on fibrate. If you want, you can probably add omega-3 fatty acid in that situation. If the patient has got atherosclerotic cardiovascular risk, put the patient on statin, ezetimibe, followed by fibrates. Like that, that's the message that I thought I should probably share it with you. Therapeutic lifestyle changes, I think I need not talk about it because already some previous speakers have talked about lifestyle changes. I don't want to spend time here. So ladies and gentlemen, my take-home message on the topic, what I have chosen to do, the lecture here, there is a substantial evidence today to say that the TGRLP play a positive role in atherosclerosis and coronary artery disease. TG levels remain a significant predictor of a residual risk. Focus on non-essential cholesterol simplifies the management of triglycerides. The reduced trial has given a promising results to reduce the triglycerides, to reduce inflammation, to bring happiness in the minds of those people with diabetes when they have high triglyceride levels. Thank you very much, ladies and gentlemen. Thank you, Chairperson, for a wonderful opportunity.
Thank you, sir. It was a really wonderful, enlightening, very convincing presentation on why and how we should reduce triglycerides in the backdrop of diabetes. I don't know if I'm permitted just one question.
Yes, madam.
Since we are running short of time. So just a very quick question. This is about controlling triglycerides in special conditions like pregnancy. What do we do? Life-threatening hypertriglyceridemia, say a range of 900 or 1000 plus.
Triglycerides, I think the lifestyle modification is the most important, even during pregnancy also. I think you need to probably associate it comorbid conditions like hypothyroidism, hypertriglyceridemia, chronic kidney disease, hypertriglyceridemia, people who are eating too much of carbohydrates, hypertriglyceridemia, people who are very obese, hypertriglyceridemia, people who have consumption of alcohol habit, hypertriglyceridemia. So try to rule out all the secondary causes of hypertriglyceridemia, restrict the carbohydrate intake, increase the vegetable consumption, fruits consumption, and then reduce the exercise is very important. Even during pregnancy also, I don't think we should interfere because there is no specific drug intended to concentrate only on triglyceride.
Post-MA patients, two trials actually. Post-MA patient on top of atorvastatin 80 milligram. If the triglycerides are more than 200, if you add anti-triglycemic drug, you can reduce the CV mortality further 15%, 15 to 20%. It's the truth.
What anti-triglyceride levels? What anti-triglyceride drugs that they use?
Fenofibrate and or APE or EPA, sir. EPA.
At present, we don't have sufficient amount of data to say that triglycerides beyond LDL lowering will be beneficial in patients who recovered from myocardial infarction. We don't recommend it at all. Even in the ADA recommendation, fibrates are not routinely recommended because there is no cardiovascular benefit. If you, as patients have more than 500, use fibrates to reduce the pancreatitis risk. That's all.
And of nursing in even SMAB is not indicated in severe hypertension in pregnancy.
Yes, it might, but we don't know exactly how much of problems will be created in a pregnant woman.
Especially in pulmonary hypercholesteremia, we have to take it.
Now, if you have increased levels of triglycerides, the best way to manage is to only about the food, diet, and exercise. No drug is allowed during pregnancy. In case the patient is suffering from a familial hypercholesterolemia, where LDL levels are very high, patient has become pregnant. How are you going to manage? Bile acid sequestrant. Polycevalam has been found to be safe during pregnancy, but it will increase the triglycerides. That's the problem. Did I answer your question?
Yes, yes.
Thank you very much. I think we are all in a hurry to take food.
Thank you, sir. Thank you very much. We conclude if there are no more questions. Thank you, organizers, for the opportunity.
Thank you, Chairperson, and thanks for the amazing talk, sir, Professor Narasimhan, sir. We'll have a short lunch break, and for the faculties, the lunch will be served in the Fondi Hall. For the delegates, it will be served in the Sunday Hall. We'll come back by 2:40, please. We have some exciting talks in the post-lunch session. Please come forward. Thank you.
Excuse me, sir.
It shows only the
சரி, என்ன லஞ்சுக்கு டோக்கனா இல்லை அப்படியே போயிடலாமா? கேளுங்க.
College, a real icon in the field of intervention.
Hello. Check. 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 Hello. Hello. Check. Hello. Check. Hello. Check. Mic check. Hello. Test. Mic check. Hello. Test. Nice. Mic check. Okay. Fine. Fine.
Hello, hello, check. Check, check. Hello.
Hello. Check.
Hello, hello. Check, check. Yes. Hello. Hello. Check, check, check. Yes.
Hello. Check. Hello. Check.
Hello. Check, check, check. Yes. Hello.
Yes. Hello. Check. Yes. Clear.
Hello.
Clear.
Check, check. Yes. Hello. Hello.
Clear. 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 Clear.
Check, check. Hello.
Hello. Check. Clear.
Check. Yes.
Hello.
Hello. Hello. Mic check.
Mic check. Hello. Clear.
1, 2, check. Hello. Check.
Hello. 1, 2 check. Hello. Hello. Mic check.
Hello, check.
You will join. Vijay also has come. We can wait for another 2 minutes. Suppose in case ಇವರು ಒಂದು ಕಾರಣ
Sir, very nice. Session start பண்ணுங்க. Hello. Hello. Hello.
in case you will join.
Good afternoon, ladies and gentlemen. Next, we move on to the next session. So to chair this session, may I now invite Professor A. Muhammad Khalifa, Professor of Medicine in Stanley Medical College, to chair this session.
Good afternoon to all. Now we are going to have a wonderful lecture by Sir Emmanuel Bhaskar, a case of an interesting about hypertension in acute clinical care setup. We know that hypertension is very common problem in the critical care unit. Sir will elaborately tell about the hypertension in acute care, only practical approaches. Thank you, sir.
Good afternoon, everyone. Good afternoon, everyone. I take this opportunity to thank Dr. Chandrasekhar and the organizers for giving me an opportunity to share a practical approach. So I just made a very brief presentation. I'll be touching mainly on the concepts of hypotension in critically ill patients. So this will be outlined for discussions. So I'm not going to tell anything really new on the topic, but rather I'll just emphasize on the most important critical aspects which will result in survival of the patients. I think in hypertension, one thing we should always remember is to not to make error which result in mortality. That's the first thing you should not do. Always remember that. You'll understand why I'm stressing that's so important. The Hippocratic statement of don't do harm is highly relevant in hypertension because quite often we complicate the picture right in the emergency. That should be avoided. So having that in mind, so I just prepared with this outline, which will be the definition and the types of shock, a very critical knowledge we need to gain. Second thing will be the most important history and clinical examination aspect. Quite often these patients are very sick and we assume that history and clinical examination is not going to help us. It's not so. History and clinical examination can add extreme critical information which could change the way you decide treatment in a patient with shock. Principles of intravenous infusates, you would have heard in many conferences. Still, I'll add a little bit more clarity to that and share with you certain evidence which has emerged in the last, say, 3 to 5 years. And the principles of vasopressor use, I'll touch only on the practical day-to-day aspect which you should be knowing. Then the debate between invasive and non-invasive. Again, I'll touch upon the real evidence and how the evidence differs from guidelines. This is something we should remember. Guidelines may say so something based on expert opinion, but evidence may be lacking. So starting with the definition, shock is a life-threatening state of cellular and tissue hypoxia
I repeat it, shock is a life-threatening state of cellular and tissue hypoxia, most commonly due to circulatory failure, which means that circulatory failure is not the only thing which we should call a shock. Right? So this is something you need to always remember. So ultimately what we are looking at is cellular and tissue hypoxia. So I just put you one simple question. I'm not going to tell the answer in the end. If I have some time, I'll add it. I just leave it as a homework for you people. Can you call any cause leading to hypoxia as shock? In COVID, we saw a lot of people who had, say, saturation of 54, 60, arterial blood gases showed 30, 40. Still, they were comfortably breathing, even without any symptoms. So can you call anything which is leading to hypoxia as shock? I'll just put this diagram. This is the oxygen dissociation curve. Hope most of us would have forgotten after the physiology exams. But this is the clue to the answer. I come back to it if time permits, otherwise I leave it as an assignment for you people to read. So before I go forward, can I know how many of your postgraduates, because primarily I've targeted it on postgraduates. So I see a few hands, good. So these are all basic principles. So first is the type of shock, something which the guidelines do not discuss at all. It's very important for you to know what is the type of shock the patient is having to decide on therapy. Most guidelines, most literature keep talking about intravenous fluids that are type of infusates, colloid, crystalloid, noradrenaline versus dopamine versus dobutamine, pulmonary catheters, arterial gases, but everyone forgets how to identify the type of shock. So that's the first thing I want you people to understand. So just remember this, the tank, pump, and the pipe. The tank is the reserve, the fluid reserve of the body, the dynamic fluid reserve of the body, which includes your extracellular fluid compartment, to some extent the intracellular fluid compartment, and also the pleural space in the peritoneum. Don't forget it, because disease states may have fluid in the pleural space and in the peritoneum. So that is the tank. You need to know about the tank. Next is the pump. Pump is obviously the heart. You have the preload, you have the afterload, then you have the intrinsic heart in between. Then you have the pipe. So pipe starts from the aorta and to the smaller vessels, which comes to peripheral, all the peripheral resistance we talk. So fix this in mind. How is the tank of the patient? How is the pump of the patient? How is the pipe of the patient? This is the first question you should put when you handle a patient with shock. So I've just brought what is given in the books here. So first thing you should always think about is the tank. How is the volume status? We know that hemorrhage and non-hemorrhagic causes hypovolemia. Think about the tank always. This includes patients with heart failure, patients with end-stage renal disease, patients with liver disease, who expect to have a fluid overload state. I repeat, even in those patients in whom you expect a fluid overload state, think about the tank, the volume status. Second thing is cardiogenic. I'm not going into that much. The prime cause for cardiogenic shock is myocardial infarction and arrhythmia. I just want to add a point here. Do not forget conditions like septal rupture. Ventricular septal rupture is quite common in myocardial infarction. They are the sickest of the patients who need more intensive assessment and early therapy. Have that in mind. So don't restrict yourself to the myocardium and the rhythm alone. Have mechanical dysfunction of the heart also, especially the valve rupture. You have the papillary muscle dysfunction, valve may rupture. In all the emergency, you will miss it out. Right? I'll stress on this at a later point of time when I touch on the evaluation. And the septal rupture, pump. Next one is the pipe. Here we talk about the peripheral resistance. We can call it as a vasodilatory shock, but I think distributary shock is a more preferred term. So here basically the pipes are dilated. It is not really giving the resistance you need for the tissue perfusion. Septic shock, anaphylactic shock, Read a little bit about endocrine shock. I'm not elaborating it more. I leave it for the postgraduates. Go and read. It's a new terminology is coming up, and I'll tell why it is particularly relevant in subsequent slides. Last one, obstructive shock, a very challenging shock. This is also something like a pipe, but it is in the preload. Pulmonary thromboembolism, pulmonary hypertension, tension pneumothorax, and restrictive cardiomyopathy. So this is the type of shock. So when you have a patient Remember this and assess. I'm not going in detail, but don't be in a hurry. A patient who's coming with myocardial infarction, previous heart failure, don't just label it as cardiogenic shock. Just fever, 1 day fever, hypotension, don't just label it as septic shock. Have a broad approach. It could be multifactorial. 3 out of 5 patients with shock do have a multifactorial reason for shock. So have this in mind, approach every patient with a broad perspective. So coming to the second objective, what are the history questions you need to look in shock? History of volume loss or poor over intake. You may think that why is he putting this question as the first? What I mean is that this question should be asked for everyone. I'll just go the other way. You have patients with heart failure, you barely take 750 ml a day. Some people take 500 ml a day. Patients on dialysis, they take 1000 ml a day. If for 2 days, the heart failure patient does not take that 500 to 750 ml, he will be hypovolemic. Do not forget that. So history of volume loss is more relevant in a patient who's been on fluid restriction. With increasing age of survival, we get more and more people who have multiple comorbidities coming with shock. So do not forget that. So inadequate fluid intake of just 500 ml for 2 days for a heart failure patient may push him to a hypovolemia. History of any disease which could lead to shock. Again, remember cardiac part. Cardiac people are prone for shock patient, even during sepsis. They may have an underlying cardiac problem, but the shock they have may be due to sepsis. You have end-stage renal disease patients, they may have other problems. So history, main thing, disease, remember the heart. Do not forget adrenal insufficiency. As a student, as well as a faculty, a delay of at least 48 hours occurs before we diagnose adrenal insufficiency even today. That's because we don't get the history right. The risk factor for adrenal insufficiency could be a remote use of steroid for 10 days. Post-COVID, we saw a lot. These people were taking dexamethasone for 6 days to 10 days. Rampant use, substantial number. Adrenal insufficiency has raised like anything in my institute post-COVID. And I would squarely blame on the indiscriminate use of dexamethasone or any of the steroid. It's sufficient if they have taken a steroid for 10 days, 6 months back, they are at risk for adrenal insufficiency. So remember intake of steroid, which includes inhalational steroid. High dose inhalational steroid taken for a long time puts the patient on risk for adrenal insufficiency. So try to see if there is a possibility of adrenal insufficiency in this patient. Treatment is completely different. You push whatever vasopressor, you put them on 3 days, and then you give the patient steroid director, then it means that you missed the diagnosis on 0 hour. Symptoms of infection. Just one point I want to make here is it can be very subtle, very common in diabetics. People who have seen will know. Just 2 or 3 episodes of vomiting, a vague abdominal pain. But keep the threshold for infection very low in patients with comorbidities and who have immunosuppressed status. Always have it in mind. It may look like a straightforward cardiogenic shock. Don't forget infection. Look for subtle symptoms. Now, cardiac symptoms preceding shock. I'll just give a typical example. Recently, 2 weeks back, a young guy who came with history of shock. Turned out that it could be insect. He told that it could be insect. Label anaphylactic shock. But he had a recurrence of shock in the ward again. When we went to the intensive care, we asked him, can you just tell me what happened last first shock when it happened? You told it was due to some insect. So please tell us what happened there. I want to know. He came out telling that I was just lying down on the cot. If the patient is I had an episode of severe dizziness and palpitation. I just went up and attempted to take some water. I just fell down. I didn't know anything. Then they brought me. Second time when we had shock, he had a ventricular tachycardia. The ventricular tachycardia was possibly missed at admission. He fell down because of the arrhythmia and not because of the hypertension. Subtle cardiac symptoms, coronary bleeding, again post-COVID depression. Especially this June, July, we have seen a lot of patients, those CABG patients, coronary artery disease patients, recovering well with therapy. But within 6 weeks to 8 weeks, they're having a sudden MI and we are losing them.
or 60%.
So this is creating a problem. I do not know, but we are seeing a lot of serious have prior cardiac problems. Are very subtle. A few days back, post-COVID, very subtle.
And sir, the patient is intolerant to statin. He plain vegetable upon those ones. Statin don't have. That case is the burden with 38.4%.
So subtle cardiac symptoms prior to the shock could indicate there is an added cardiac problem. And risk factor for pulmonary embolism. Now here, do not stick to the conventional risk factor. Emerging diabetes appears to be a strong risk factor for pulmonary embolism, especially more than 15 to 20 years of diabetes. In a patient with shock, how low is too low a BP? You may think. If you are 90, you are comfortable, then you BP. If you are 100, you are symptomatic. So it is a relative time. Don't try to fix an absolute. Though we fix less than 90 as a definition of hypotension. If there is compensated, the compensated shock I mean, you get a dengue. Tachycardia is there, BP is just 100. We don't label it as shock. It could be a compensated shock. All we need to do is prevent the problem. So there are certain signs which you should not ignore in a patient with shock. So always consider that hypertension is relative.
And we are already monitored by
absolute only by the time that it has caused severe organ hypertension.
It is available in this
pharmacy. Is a very good sign. I would stress again. Recovery of oliguria in a patient with shock is a very despite close to 25 years of septic shock, urine output of 0.5 ml per kg per hour is a one parameter. That is because oliguria still, I can even compare this with advanced hemodynamic parameters. But I'll touch it later on. Confusional state. What I'm trying to mean is that patient in shock. What tablet? Talking to you, he may be giving the history. But look, how much is the confusion? Is he oriented? Is his memory fine? Ask him few questions about the calculation. Assess the higher especially if you see the patient is oriented but is not able to calculate, memory that is a good intervention. If I see a patient before I give him treat for hypotension, BP has not picked up with my therapy. Perfusion has picked up. I will be happy. Because his organ perfusion is working.
The only brand available in India.
Less confused. It will give you a lot of information. Sometimes we chase the blood pressure. Oh, BP is not coming. I have more and more vasopressure. But if the unit is improving, his menstruation is improving, I will be happy that his tissues are coming back. Always you think, oh, this is septic.
Those are not achieving LDL goals.
The types of shock, I'll touch upon only the 4 aspects of cardiogenic and septic shock. I put all under others because I don't want to dilute the content.
That is a 6 to 7% maximum reduction.
Additional.
Statin
do not use clinical.
Second thing is cost factor. Upon statin dose 30 milligram resolution costing is almost 40. That's not good. Price because once daily dosing
people use lactate across India as an indicator of lactate.
You can kindly request for it.
It is venous lactate. Second thing, lactate at admission. Venous lactate at admission helps you, and not venous lactate after hydration helps. Patient is coming with hypertension. You push the patient with IV fluids. Do a lactate. Reason is very simple. Perfusion.
Major request top plat.
You may have a very high lactate post perfusion.
Thank you, sir. Thank you.
So do a venous lactate if possible at admission. Don't go by the arterial lactate. I just do a very simple thing. You just go and certain centers. They do ABG for all ER patients. I'm sure many corporate hospitals do that, including mine. You just go and take all the ABGs and look at the lactate. I can assure 25% to 30% of stable patients will have elevated lactate in ABG. It's not validated. Arterial lactate is not validated in ABG, like the way the carbon dioxide is validated, bicarbonate is validated. So it is a venous lactate you need to look at, and you need a venous lactate on admission, pre-resistage. Just 5 minutes. So I'll just run through a few things. So procalcitonin again, procalcitonin is not an absolute marker of degree of sepsis. Procalcitonin may be very high, but they may not be sepsis. Procalcitonin may be low, they may have severe sepsis. Don't rely on procalcitonin in diagnosis of severe acute sepsis, but maybe you can use it for tapering antibiotics. When it falls, when it becomes negative, you can taper the antibiotic for a shorter course. So I'll just quickly run through. So this is basically what is called a rapid ultrasound. Rapid ultrasound, it's a point of care thing in hypotension and shock. So if you can use it, it will be nice. Look at the pump, the cardiac echo. Look at the tank. You're looking at the vena cava, you're looking at the pleura, the peritoneum, and look at the pipes. A point of care ultrasound is essential in the diagnosis of shock. I think we all should learn to look at point of care ultrasound there. Now, sepsis, crystalloid versus colloid. We all know that crystalloid is better than colloid. I just want to tell one thing, which is about dextran 40. It is a colloid which is used in dengue. I personally use it a lot. Using it in the ward or in the ER prevents hospitalization in intensive care. There are centers where I work with where we give dextran in patients before referring to tertiary care. By giving dextran, I have kept them back in the secondary care level center without care. So there is a role for colloid in dengue there. Now, vasopressor, I'll just touch on the practical points alone here. The dose I'm not touching. Noradrenaline versus dopamine. There is no evidence that dopamine is inferior to noradrenaline. Right? So the points you need to remember in noradrenaline is start at a medium dose of say 0.4 microgram per kg, titrate, put it at the central or large peripheral line because it can extravasate. You may ask me what happens when it leaks out. Try to put nitroglycerin ointment there. Phentolamine is given in the books, it is not available. Use nitroglycerin ointment, that will help you a lot. Now, cardiogenic shock. So this you would have seen. I just want to quickly look at that. You see the top right corner. The top left corner, you have the classical shock where you have the wet and the cold. Lungs are fluid filled, extremities are cold. Classical cardiogenic shock. You may have a second type where the lungs are dry, but the extremities are cold. We call it as a euvolemic cardiogenic shock. The third one is the lung is wet and the peripheries are warm. That is called a vasodilatory shock. So peripheries are warm, but lungs are wet. This is what I was telling. Don't rely on the warmth. Last one, if lungs are dry and the peripheries are warm, then it is not cardiogenic shock, it is septic shock. Now, going on to the management part. How many of you use dopamine? Now, I see some hands. See, don't feel that you are inferior if you use dopamine and not noradrenaline. This is the 2017 statement and nothing has changed over the last 4 years. Dopamine, noradrenaline comparatum, there is only one study with 1,600 patients where there was a trend towards increased mortality. There was a trend towards increased arrhythmia. There was not a clear significant statistical significance. Dopamine is still good. Guidelines still tell dopamine. There is no way norepinephrine is superior to dopamine, right? And the second one, euvolemic, again you can use norepinephrine or dopamine. All I'm telling in cardiogenic shock, you can still use dopamine. Evidence supports the use. The third one, look at vasodilatory shock, consider hemodynamic. First two categories, the guidelines themselves tell no need of hemodynamic guided therapy. You don't need to put an intra-arterial line in them, even going by guidelines. But guidelines tells that if it is a vasodilatory cardiogenic shock, put it, but see, there is no references. It's an expert opinion. So in guidelines, always remember that it can be an expert opinion of the panel member or it can be based on published data. Here, there is no evidence that intra-arterial BP monitoring is superior to conventional monitoring, even in vasodilatory cardiac shock. Right? Just remember this document is available free. But don't miss a right ventricular shock. Inferior LMA, typically you would have seen. Fluid boluses helps. Again, don't push too much fluid bolus because right ventricle can distend into the left ventricle and it can make the LV cavity smaller and it can create more complications. So just remember this table here. In cardiogenic shock also, dopamine is as good as norepinephrine. up-titrated and rely on the parameters. So here I will just touch upon urine output again. Still, even in the setting of invasive monitoring, you bring in urine output. They call it invasive because you put a police case. So it is still there in the monitoring. So rely on the urine output. I told confusion you can add. Now, BP monitoring, traditional monitoring is sufficient if you really measure it properly at the bedside. You have very good automated devices available now which measures the external BP, not the conventional BP apparatus. We have certain brands which is available that can be used to supplant your physical measurement, especially in obese individuals where the cup size may be inadequate. So in monitoring, I just want you people to remember that urine output and confusion improvement is something you please have in mind. So I just stop with that. So I think I'd be happy if I had gone through the message of the important points in history, which I told you, the list I gave you, the examination part, which you need to really look at in these patients, how it helps, how you should not miss a compensated shock, tachycardia, mild tachypnea, volume is little low, but BP is normal. It is still a shock, but it's a compensated shock. You need to identify whether it is cardiogenic or is it hypovolemic or is it obstructive. So compensated shock is as important as the decompensated shock. Infused choice, it's always, most of the time it is crystalloid. In dengue, you can consider colloid, which is dextran 40. Vasopressor, dopamine is as good as noradrenaline. There is no substantial data which says this noradrenaline is greatly superior. We need more studies in that. I think if you are using dopamine, please come out with data on that. That's the data we need. The dopamine is equally good, but remember potassium, magnesium, hypokalemia, hypomagnesemia, and precipitate arrhythmia. Anything you may use noradrenaline, you may use dopamine. Both can precipitate arrhythmia. So remember that to be looked at. Non-invasive monitoring, just remember on the urine output, confusional state, conventional BP apparatus is more than sufficient. I just conclude saying that I had the opportunity to coordinate the second level critical care in COVID patients in Tiruvallur district, Kanchipuram, and Chengalpattu district, where we prevented patients coming to Stanley and LMC with shock. We treated them with ventilator support there. Many times in remote, many times we went there, and the mortality I didn't see is different from great corporate intensive cares. So all you need is meticulous care, looking at the basics and doing the basics right to make the patient survive. So thank you for listening. Thank you. Maybe I can take them up.
I have a small chart in my hospital for the duty doctors and the staff nurses to understand. Somebody comes with a chart, shock. A is for anaphylaxis, B for bleeding, concealed bleeding, something like ectopic recession rupture. Somebody has got internal intergastric bleed, or obvious bleeding. C for cardiogenic shock, D for dehydration, E for endocrine cause and endotoxic shock. No G, H for heat stroke. I think mostly 99% the shock they'll be able to come to the conclusion with this chart. Very easy to for them to understand. They'll say, so this case belongs to this category. I remember I had a patient, as you said, the abdominal insufficiency. A lady was treated for septic shock. She could not recover at all. Later on, the staff nurse, when she cleaned up, she saw the 30-year-old lady had no axillary hair, no pubic hair, and the nipple was pink. Then we checked the ACTH, it was 0. One dose of hydrocortisone, she woke up. We were missing a lot of the adrenal insufficiency. Thank you, sir. Very excellent erudite. Thank you, sir. Thank you.
Okay, sir. Thank you, sir. Thank you so much, sir. We learned a lot from you. Dopamine is not inferior to noradrenaline. It's my pride to invite Dr. Vijay Vishwanathan, sir, to deliver his speech on diabetic food guidelines in practice. Welcome you, sir.
Thank you, Dr. Khalifa. Since we're running 1 hour late, I'll finish in 10 minutes. And I'd like to thank my good friend Chandrasekhar for his invitation. Can I have the first slide? Yes. In the interest of time.
relevant to this particular conference, but I think you should know something about diabetic foot because many of the physicians, this is not working, huh? Can change the pointer back. I need a mouse further on. Okay, in the interest of time, I'll just get started. So we treat diabetic foot as it is. But what I'm going to show you in the next 10 minutes is how to treat according to the guidelines. And that's what Dr. Chandrasekhar asked me to talk about. Huh? Not working. It's okay. So this is a state in which many practitioners with diabetes see people. You know, already you see one leg is amputated, the other leg is developed a gangrene. This is a state in which many people are coming. So I think we should prevent the situation. And if you see the cost of, this is not working, it's okay. So if you see the cost of people whose legs are amputated, one toe, second toe, third toe, these are the people whose foot is not amputated at all. You can see that the expenditure for last 2 years was about 46,400 rupees in this category, whereas it was about 1,68,000 in that category. 16 lakhs, 1,68,000. So it's about 4 times more the amputation, the expenditure of people who undergo amputation. So this is one of the first studies from India where we looked at what is the cost for amputation across India. So we had 31 diabetologists from across the country, and you can see the spread of these 31 diabetologists across the country. And this was published in JAPI in 2011. And what we found was infection on top of diabetic neuropathy was the commonest cause of amputation across India. It is not in Tamil Nadu alone. You can see that 88% of the amputations were minor amputations, but it was happening on the setting of neuropathy. Trauma is again 22%. So together, maybe 100%, you can see that 100% of amputations which happen among people with diabetes is due to neuropathy. So I think that's very important. So this is the patient, and my guideline talk starts from here. During the lockdown, acute lockdown, when the police did not allow people to go into the streets, this patient came with maggots. So this tried to show up a lunch break. But you can see the maggots. He cleaned the wound and then did a skin grafting about 1.5 months later, all during the acute lockdown. Therefore, I think how do we recognize infection? That's going to be my talk. You can see that if you have abnormal granulation tissue, anybody can say that the granulation tissue here is not healthy. And there is odor and exudate. There will be odor. It shows that there could be granulocytic sepsis or anaerobic infection. And there is exudate, as you can see there. Many people think that biofilm is very easy to treat by just changing the dressing. But I think the surgeon has got another pointer. This pointer is really not working. Unless the pointer works, this talk is quite futile. So you can see that the biofilm has to be removed by the surgeon by his scalpel. So it's very important that a surgeon spends time and doesn't allow his nurse to do the dressing. The surgeon must spend time on the wound. Once he debrides the wound, he cannot think that nurses can or the ward boys can do the dressing. The surgeons must clean the biofilm, remove the biofilm. But the best way of removing the biofilm is the surgeon's scalpel. Now, in the last 8 minutes, let me talk to you about the International Working Group on Diabetic Foot Guidelines. And I was fortunate enough to be in the editorial, not in the editorial board. Editorial board is consisting of 6 people. It's mostly from Netherlands. And you have people from 40 countries and 5 continents. And I was fortunate enough to be in this allied group talking about the International Working Group on Diabetic Foot. So what I'm going to talk to you in the next, say, 7 minutes, is going to be on the IWGDF guideline. It's available in the website, in the online. You just put iwgdf.org, you'll get all this. So you need not bother to take it down. So when you have moderate infection, that is somebody whose erythema is extending more than 2 centimeters from the wound margin. So the cellulitis or erythema is extending more than 2 centimeters from the wound, you definitely have a moderate infection. Severe infection is when you have systemic symptoms like temperature, increased WBC count, and so on. In addition to these signs, then you can say that it's a severe infection. Now, these are the characteristics which suggest hospitalization. You can see the guidelines. If you feel that you've got severe infection, that's severity 4. And if you have severe foot ischemia, or if you have any of these, the patient is unable or unwilling to comply with outpatient treatment, you have to admit them. So the hospitalization is not needed for every foot infection. But please remember these 8 reasons for hospitalization. Now, when you get a person with foot infection into the hospital, these are things which you need to do if your infection is mild, and these are things you need to do if your infection is very severe. So you can see on the right-hand side, these are things which you need to do. Now, which antibiotic, because antibiotic sensitivity takes about 48 hours. So which antibiotic will you start from the casualty, from the ER room? So the IWGDF guideline says that if you have a mild infection or if the person has not been exposed to antibiotics, you just need to treat only gram-positive, GPC, gram-positive. Supposing the person has been exposed to antibiotics in the recent past, then you should cover the gram-positive and the gram-negative, GNR and GPC. Now, if you have severe infection, you should cover gram-positive, gram-negative, and the anaerobes also. If you have an ischemic necrosis, and you see, you can cover anaerobes. Now, you can add metronidazole, but if you take clindamycin, it's got a beautiful gram-positive cover and an anaerobic cover. So you can give clindamycin, and gram-negative, you can cover it with any cheap gram-negative bacterial cover. So I think you wait for 48 hours, you get your report, and then you treat accordingly. So this is for the empiric antibiotic that you can see on top. Now, foot osteomyelitis. So many people get ulcers and they have underlying osteomyelitis. So these are the, you don't need an MRI. You don't need an MRI to make a diagnosis of osteomyelitis. All that you need is only a simple digital X-ray, good X-ray. So if you have loss of bone cortex, bone sclerosis or erosion, you can easily see the presence of sequestrum. It's diagnostic, and if you do the probed bone test, which has only got about 78% sensitivity, but the X-ray has got 90% sensitivity. So I think you don't have to do an MRI to make a diagnosis of osteomyelitis. And the diabetic osteomyelitis, some people used to say that you have to treat it for 2 months, 3 months, that those days are gone. If you do what is called sequestrectomy, if you remove the infected bone, you need to treat with antibiotics only for about 2 weeks. So gone are the days when you were treating osteomyelitis for 2 months, 3 months, and so on. So don't use antibiotic for beyond, say, 5 to 7 days or 1 week or whatever, few days. If you remove the infected bone, you consider doing a bone biopsy. Whenever you remove the bone, you consider doing a bone biopsy. It's not routinely done. I think you should do bone biopsy because bone biopsy will clearly show infection. And my last 3-4 slides. See, some wounds, antibiotics have already covered. Now I'm going to talk about revascularization. So this was a patient who came to us some time ago. You can see that the heel is completely gangrenous. and the calcaneum is exposed. There's absolutely no blood flow to that area, to the posterior tibial artery. So this patient was advised below knee amputation. So we did an angioplasty. We put a balloon into the posterior tibial. You can't put a stent. Below the knee, you can't put a stent. You can only put a balloon. You put a balloon into the posterior tibial artery, and you can see the perfusion, beautiful. And you debride the wound, you put a negative pressure wound therapy, and finally put a skin graft, and you have saved the feet of this patient. And lastly, I think with this I'll end, offloading is very important. So in the IWGDF guideline, they put me along with some big names like David Armstrong to talk about offloading. This is the 2019 guideline. The 2023 guideline will come next year. So this is one way of offloading. If you have a plantar ulcer in the midfoot, all that you need to do is in the developing country, because I was asked to write about the developing country. You can see in the last picture a felted foam which goes all around the wound and it offloads the feet. If you have a midfoot ulcer, you can do something like this. So this is how you offload with a felted foam. This is an accepted method according to the IWGDF. Let's not forget about the total contact arts. If you have somebody who's got a non-infected ulcer, infected ulcer, you can't do a TCC. But if you have non-infected ulcer, you can do what is called a TCC. So thank you, Chandrasekhar, for asking me to talk. I think it's a pleasure to talk about guidelines, because we need to know where to apply the guidelines and when to use the guidelines. Thank you.
What's the best dressing material you recommend for the practitioners?
So dressing material, though there is IWGDF does not recommend, there's only one dressing material which is recommended by the IWGDF, and that's Urgostat, because it contains sucrose, maltose, sulfate or something. And it's useful in neuroischemic wounds. But all the other dressing materials have no proven efficacy. So it is not what you apply onto the wound, what you take off the wound, the biofilm. So dressing material has no role, but people put all sorts of creams and and all the medicines onto the wound, which has really no evidence base.
When do you recommend vac therapy? Most of the people do it before the skin grafting.
Yeah, so like right now we have a person who's got no blood flow beyond the knee, and some surgeon has put a vac therapy. And you should not use it in somebody who's got peripheral artery disease or infection. So two absolute contraindications for negative pressure wound therapy or vac therapy is one is coexisting peripheral artery disease, or if you have infection. This patient had both, and they put him on that, and he came with an infected wound. We did a bypass in our hospital, femoral popliteal bypass, because he could not afford a stent of the superficial femoral arteries. It cost about 3 lakhs. So he went in for a bypass, and they first cleaned the wound, looking good. So now he can put a vac therapy. So vac therapy is only when you have corrected the ischemia and the infection.
And I think high pressure oxygen, we have 4 missions. I remember I referred a case to you, very bad, impending. He survived. And right now, even after 2 years.
I'm not supposed to, because I have signed a confidentiality note for the next IWGDF. I'm doing hyperbaric oxygen.
Just give a small note. No, audience should know that. It is available in Chennai. And,
yeah, so hyperbaric oxygen
patients.
right now has no role, according to what systematic review we did. But topical oxygen is showing some benefit. Topical oxygen, so but not hyperbaric. But where we use hyperbaric oxygen for the last 10 years is after revascularization. If you do revascularization, then it will help you to open up the collaterals. So hyperbaric oxygen is best suited or best used in after revascularization. So topical oxygen is a small machine which gives oxygen only to that area. Hyperbaric, you lie inside the chamber because in this room you have 21% oxygen. Once you get into the chamber, you have 100% oxygen. So there is a difference between inhaling 100% oxygen and getting oxygen only onto your wound. That's a difference between topical oxygen and hyperbaric oxygen. Topical oxygen, some benefits is there. So we use topical ozone therapy. We got it in Germany, but ozone also does not have a good evidence base. We use a lot in Germany, ozone therapy, but topical oxygen and ozone have no good scientific basis. I should not stand in the way of Pioneer Pen and you.
Thank you so much, sir. Next time, I'm inviting Dr. Palnepan, sir, for the topic of cardio-diabetic physician.
Good afternoon, ladies and gentlemen. Thank you. Thank you very much, my dear friend, Dr. Chandru, and all the organizers and chairperson for his kind introduction. Today, my topic is cardio-diabetic precision medicine. The aim of my talk is hit hard to save the acute coronary syndrome patient and revive from the acutely decompensated heart failure patient, and hit fast to increase the ejection fraction and to live 85 years. Here is the patient, 46 years old male Subramani with a 6 vital signs: 136 pulse rate, temperature normal, respiratory rate is 46, BP is 160/100, SpO2 is 78 in room temperature, and random capillary blood glucose 268. Other findings: emergency ECG, acute anterior STEMI, A1C 6.9, and cardiac arrhythmias like this mitral dysfunction, and moderate dyslipidemia. Echo shows 30% emergency echo, 30% EF, and LA detector akinetic, moderate mitral regeneration. Ultrasound kidney is normal. So this patient is middle-aged male, tobacco chewer, and type 2 diabetes mellitus, high blood glucose without TKR HHS, high BP. Here it's a high BP. Moderate dyslipidemia, acute coronary syndrome, acute anterior wall STEMI, not waiting for even elopsin. So it is in the non-cath lab center. So you have to treat STEMI as well as heart failure, acute pulmonary edema, severe LV dysfunction, and patient is having acute kidney injury and sinus tachycardia. So this is the complete diagnosis of this patient. So various guidelines, 2022 guidelines, American Heart Association, American Cardiology Society, and Heart Failure Society of America, 2022 February, they have released various guidelines, 4 pillars of heart failure management. I am including evaporating also, so I am going to talk about the 5 pillars also in this patient. So here, before treating this patient, acute coronary syndrome, heart failure, you have to manage which drug, what drug, and how to titrate everything, and how to improve the EF 32, 40, or 45. So this national guideline, international guideline shows you have to do the diagnosis. The patient is having stage C, symptomatic heart failure. Stage A is at risk heart failure, pre-heart failure, here symptomatic heart failure. So 4 pillars, that's very important thing is beta blocker, MRA, ORNI, and HLP inhibitor. All 4 has to be instituted appropriately. And diuretic has to be acute pulmonary edema, prompt of position, non-invasive ventilatory support, and diuretic furosemide IV stat followed by continuous infusion of torsemide. So acute pulmonary edema. So you are reducing the acute pulmonary edema, as well as EF is 30%. So 5 pillars of heart failure drugs has to be instituted appropriately. So here, this is the 2022 guideline says all there's a 5 drugs. There is beta blocker. Either you can use AC inhibitor or ARB, but preferably ORNI. But this decompensatory heart failure, you have to give AC inhibitor, cardioselective ACE has to be inhibited by ACE inhibitor, ramipril or enalapril or perindopril has to be instituted. After that, you can switch over to ORNI. Nowadays, always you have to switch over to ORNI to reduce the morbidity and mortality. And beta blocker, 3 important beta blockers are well proved. It is sustained is metoprolol or carvedilol or nebivolol. If the BP is high, metoprolol. If the BP is medium, carvedilol. BP is normal or low, better to push them on nebivolol because nebivolol reduces the heart rate than the BP. But metoprolol reduces the BP more than the heart rate. And MRA, spironolactone, epiledone, pendulone, recently available 80 rupees. It will come to the market. So this MRA is very important to reduce the sudden cardiac death and CV mortality and morbidity. Morbidity from benefit you will be having. And another thing is HLT inhibitor. Irrespective of the presence of type 2 diabetes mellitus, you have to put them on HLT inhibitor, provided eGFR is more than 30. Previously 40, 45, now you can use up to 30 eGFR. So these are all the important 5 pillars you have to add. And many times beta blocker alone, BP is 100/70, still that heart rate is 110. You have to reduce the heart rate without reducing the BP. So you have to add beta blocker along with that ivabradine. So these are the selection of the drug. So here acute pulmonary edema, prompt of position, non-invasive ventilator support, and diuretic infusion. So within 6 hours, lung become dry. So within 24 hours, we can remove the NIV and continuous IV diuretic if necessary or down titrate. And beta blocker here, carvedilol has been used in this patient. AC inhibitor ramipril is started with 2.5 milligram, and patient was better. And spironolactone has been started twice a day as a tablet. And African American patient and right heart failure patient, Indian patient also, refractory heart failure, still failure is not adequately controlled. You can add hydrolysis with isosorbate dinitrate. Even the TP is normal. And ivabradine, always, heart rate is very important. Always ancient Asian doctors always look into the heart rate and BP. Heart rate, BP, respiratory rate. These 3 things are more than enough to treat your heart failure. So here, less than 75 years, start with 5 milligram BID, more than 75, 2.5 milligram BID, and every 2 weeks you have to update it or down titrate. If it is reducing by less than 50 symptomatic or 50 to 60 symptomatic giddiness, everything, you have to reduce the dose from 5 milligram to 2.5 milligram BID. And it's still not done. Heart rate is not under control, 5 milligram BID, you can increase by 2.5 milligram extra, so 7.5 milligram BID. This is the titration of the various 4 pillars of drug. And here this patient, all the things I was under enumerated, NIV support, prompt of position, furosemide given, soluble aspirin, ticagrelor 180 followed by 1 BID, atavast 80 milligram, ramipril started. Carvedilol has been given because heart rate is not coming down. So combination of carvedilol with ivabradine off tablet BID is started, and torsemide and spironolactone tablet. And here IIT therapy, insulin infusion therapy, along with that eGFR is okay. This patient more than 40 only. So I have started them on HLT inhibitor also, along with there is ultra fast acting insulin IV infusion therapy. So we are treated. Second day, slowly lung condition acute pulmonary recovered. Third day, patient is good. Fourth day, again developed acute pulmonary edema and cardiogenic shock. CPR given, NIV support, everything, patient came back normal. And hypertension may manage with noradrenaline. Here, all the 4 drugs can produce hypertension. So you have to down titrate or withhold all the drugs according to the BP. And here, from the 1.2 milligram, it has pushed to 1.8. Creatinine is increased to 1.8. So continuous IV, no fluid, and continuous torsemide infusion in 100 ml, and this electrolyte corrected this patient on 4th day. After 4th day, so I want to start them on ORNI instead of ramipril. So ramipril has to be holded for 36 hours before starting ORNI, because I want to get an increase in EF for this patient. So the important diet is starting. That's the indication for ORNI. Always you have to. The tablet is 100 milligram tablets cost only 85 rupees. Monthly budget is 2,500 rupees. But I got a wonderful, enormous benefit if you start early. Previously on discharge, after 15 days only you have to start them on ARNI. Now, no. Acutely decompensated heart failure, once you decompensate to compensate, you can start them on ARNI. Here, this patient, BP is more than 100, no noradrenaline trip, and diuretic has not been escalated for the past 6 to 24 hours. So, it's a typical criteria to start ARNI. And EGFR is more than 30. So, already the patient is ramipril. I want to get a better longevity, thereby I am starting on ARNI. So, this patient is a fit patient to start ARNI. After stopping ramipril for 36 hours, I started this patient. So, yearly, this study, NT-proBNP, actually NT-proBNP, the baseline is 760, that is 860 for that patient heart failure. Within 1 year, it will come to 455. First 14 days, 70% of the NT-proBNP decreases within 14 days. So yearly, as early as possible, you have to start to get a fantastic benefit. So first 14 days, NT-proBNP will come down by 75%. Another 11.5 months, it will take to reduce another 25% of the NT-proBNP. So nowadays, heart failure diagnostic criteria is different. Heart failure, the definition is lack of improvement in the NT-proBNP, and it should be, it's a persistent heart failure, not a stable heart failure. Prompt optimizing therapy is very much required to treat this heart failure, because heart failure patient means previously stable heart failure. It is a misnomer. It's a persistent heart failure. Asymptomatic, mildly asymptomatic heart failure or mildly heart failure patient may prone to develop hospitalization of heart failure as well as sudden cardiac death. So it's a persistent heart failure. It has to be addressed properly, adequately titrated. Otherwise, it will end up in sudden cardiac death. In paradigm heart failure study, the 81% of the death is due to cardiovascular mortality. Out of the cardiovascular mortality, 45% is due to the sudden cardiac death. So, heart failure patient already on the top of beta blocker and MRA, 93%, 55%. If you add ARNI, you can reduce 25% of the sudden cardiac death. Now, it is not seen in enalapril, but enalapril can reduce the hospitalization of heart failure, but not sudden cardiac death. So, sudden cardiac death can be reduced if you use ARNI. This is the study, and EF is increased by 12 if you use for 1 year. And inadequate, not reaching the target itself, you are increasing the EF by 9. So it's a phenomenal benefit of using an ARNI. The first 1 month itself, you are reducing the CV mortality, hospitalization, heart failure is reduced by 33%. On the 56th day, 42% reduction is there. This is the titration. So ARNI, even EGFR 30, CKD stage 4 also you can start with off tablet 100 milligram, off tablet 50 milligram OD or BAD, and if it is increasing, you have to stop or reduce, and or alternative day you can give in CKD stage 4 also. So up titration, maximum dose is 200 milligram BAD. But Indian patients, off tablet BAD 100 milligram, 90% of the patient works fantastically very well by improving the EF. So this patient, 6th day I have started them, fourth day, 5th day I have stopped the ramipril, switch over to ARNI, off tablet BAD 100 milligram, and 6th day I have started, 7th day, daily I am estimating creatinine as well as potassium. 7th day, 8th day, from 1.22 it is increasing to 1.8. So what to do? This is the criteria. Reduce the ejection fraction. If creatinine is increasing less than 30%, continue with the same dosage. If it is increasing by 30 to 50% of the creatinine, baseline creatinine, you have to reduce by half, or you can stop, depends upon the patient. And diuretics, by giving diuretics, definitely the creatinine will come down. You need not be panic. 80% in my clinical experience, 80% of the patient it will not occur. Only 20% of the people, the creatinine rise will be there. So don't panic. So 80% patients should get benefit. Even 20% people, if you hold or reduce the dosage, again you can restart. Like ATD hepatitis. You have to restart after you reason after 1 month, you know, it is idiosyncratic reaction. Like that, you have to reduce or taper or stop and restart the drug to get the benefit. Even CKD stage 4 also, it's a fantastic benefit. For this patient, I have reduced to 50 milligram OD, and I have hypotension treated with noradrenaline trip and torsemide, continuous infusion. Other drugs, that is BP lowering drugs, is reduced dose, tapered dose was given. So AKA regression, and from 1.8 to 1.3, and BP is fantastic, normal, asymptomatic, urine output is normal. After 3 to 4 days, again I have escalated dose of escalated dose from 50 milligram to 50 milligram BID. So ORNI can be used in hypotensive patient also to reduce the cardiovascular mortality and all-cause mortality by 12 to 15%. So this patient finally on 11th ICU day, 50 milligram BID, again escalated. It was maintained for 2-3 months. So here hyperkalemia also, ORNI can induce hyperkalemia, but the NLR, compared to NLR, it is lesser. So stop, we have to stop nitrocontin. Other drugs has to be reduced the dose. After that, if not reducing, you have to reduce the dose of ORNI. Fantastic benefit. Hyperkalemia is lesser in this patient, and potassium, reduced dietary potassium, all the things to treat all the things. So 10th ICU day, hit fast, and glycemia, hyperglycemia has to be addressed. IIT therapy followed by subcutaneous insulin, followed by HL2 inhibitor. After that, only GLP-1 receptor agonist, metformin, AGA, sulfonylurea, especially glycoside. And reduced ejection fraction converted to improved ejection fraction from 30 to 41%. Fantastic benefit as the patient is on ORNI. And this is the definition: improve from less than 40 to more than 40, and E bar E ratio improved from 8 to 15, more than 15. Less than 8 is normal, more than 15 is abnormal. So reduction in the E for E ratio, that is increased pressure, LV pressure. So we are getting the reduced to improved, reduced to improved. So mildly reduced ejection fraction. It's a fantastic benefit you are getting, as well as you have to continue the dosage according to the patient. And here 2A indication is HL2 inhibitor. Other drugs are 2B indicators. And preserved ejection fraction also you can use except beta blocker. So this patient on the discharge improved ejection fraction to mildly reduced ejection fraction. Cardiorenal syndrome recovered. Severely symptomatic hypertension with dyspnea treated with 5 pillars of heart failure with a modified dosage. That's very important. So on top of that, all the comorbidities also has to be addressed properly. Atrial fibrillation, any PTCA has to be done. Atrial fibrillation, anticoagulant, anemia has to be addressed properly with IV iron therapy and mechanical circulatory support or refractory heart failure, cardiac transplantation. Everything has to be done appropriately. You have to address the comorbidity also at the same time at a time. So this is the final before discharge with this BP. Again, after 2 months, patient developed hypotension, symptomatic hypotension, again started with only 50 milligram, and cardiac evaporated only half tablet a night. Patient is fantastically very well, and iron therapy also was given. So to conclude my talk, the take-home messages are goal-directed medical therapy, 4 pillars, not 4 pillars, 5 pillars, include that HL2 inhibitor has to be given. HL2 inhibitor has to be started for all heart failure patients, even preserved ejection fraction, irrespective of the diabetes status. In non-diabetic status also it's useful. New recommendation of preserved ejection fraction, you can use class 2A indication HL2 inhibitor, others are 2B indicator. So this is the improved ejection fraction, and that is you have to do E bar E ratio normally is less than 8, more than 15, it's reduced ejection fraction, it has to be addressed properly. And you have to treat comorbid conditions like OSA or anemia and other atrial fibrillation. All other thing has to be treated accordingly. Stage D, you have to give ICD or CRT, all other device therapy has to be given to get a better benefit. If you start all other 5 pillars of heart failure management, you can increase the longevity. These patients also can live up to 85. Thank you so much for the patiently listening.
When you mentioned 3 beta blockers,
yes, sir.
One is Deviviral, no?
Yes, sir. Nebivolol and corbivolol and sustained release metoprolol.
Bisoprolol, not nebivolol.
Sir?
It must be bisoprolol. CITES 2 is the largest heart failure study. CITES 2. We have a very small study with nebivolol. Seniors up to the age of 70. I think you would revise your top drugs are metoprolol, bisoprolol. Young fellows don't start them on carbon drugs.
Bisoprolol, yes, sir.
Bisoprolol. It's not nebivolol.
It is not nebivolol, it is only bisoprolol, metoprolol, and carvedilol.
Nebivolol, it's a bisoprolol. No, sir?
Not nebivolol.
It's a bisoprolol.
Bisoprolol. Now the super drug for heart failure.
Yes, sir.
We have the large study, CITES 1 and CITES 2.
Yes, sir. Thank you.
Thank you so much. Let us conclude this session.
Thank you, Chairperson and the speakers. Now we will move on to the panel discussion. In 1 minute, now they will arrange the chat. For this, the moderator will be Dr. S.S. Lakshmanan. I think everyone know about him. He is the scientific committee chairman, Chennai chapter of APA, and also a very good clinician. And for that, the topic is young diabetes clinical approach. We got very good learned speakers. Professor Dr. C.R. Anand Moses is one of the, I think I should remember his father. I don't know, some of you may not know. Dr. Sandeep Moses. He is the son of Dr. Sandeep Moses, great teacher and diabetologist. And we got another teacher, Dr. Madhavan, who is also professor and retired from GH, diabetologist. And we got Dr. A. Nadarajan. He is the diabetologist and family physician. And we got Professor A. Shanmugam. He is also a diabetologist and in charge in KMC, I think. Yes, thank you. Now, I think within 2 minutes, we'll go for the panel discussion. I think Dr. Lakshmanan will initiate and try to finish up in time ahead.
Stage got ready for
Dr. Moses sir, Dr. Madhavan sir, Dr. Natarajan sir, and Dr. Shanmugam sir. Want to stand?
Yeah, it's fine. I'll stand. Thank you, Chandrasekhar. I think given a good opportunity to discuss the diabetes in the young. So gone are the days we have the diabetes by guesswork, type 1, type 2, moody. Now we have got a precision diabetes. We can find out the exact cause for diabetes in young by proper investigations as well as the clinical profile. We have Dr. Anand Moses, Dr. Shanmugam, Dr. Madhavan, and Dr. Narajan. We'll have later we have 10 minutes time for any questions from the floor. We'll start with Dr. Narajan. Narajan, what's the definition of diabetes in young? And up to what age group is it considered diabetes in young in India? And is the diagnosis criteria is different?
Thank you, Dr. Assessment. I quickly start my talk without wasting much time. There are a lot of controversies in the definition of diabetes in young because various bodies give various guideline and age limit. And the commonly used diagnostic criteria is the diagnosis of diabetes, the onset is below the age of 35 years is called diabetes in young. When you look at the diagnostic criteria, it is something similar to the adult diabetes. That is fasting blood glucose with no calorie intake for about 8 hours, more than 126. And OGDT, 700 gram glucose, 2 hours post-prandial value more than 200. And HbA1c more than 6.5. And random blood sugar more than 200 with signs and symptoms of diabetes is considered as diagnostic criteria. But In type 1 diabetes, the A1C value is not yet very clear. So the common etiology, in fact, that the diabetes in young is type 1 diabetes, which is about 40%, and type 2 diabetes is about 40%. We have fibrocalculus pancreatic diabetes, which is about 15%, and we have MODY, which is about 2 to 3%, and we have Flatbush diabetes, which is about 1 to 2%, and mitochondrial diabetes and syndromic, the rest of things.
Thank you, Dr. Rajan. Want to add anything? Other questions? Want to add anything? Yeah, later. Now the next question will be, what are the common causes of diabetes in young? Addressed to Dr. Shanmugam.
Good afternoon all. Already Dr. Natarajan has been pointed out most common causes of type 1 diabetes and body, and type 2 diabetes also quite common in young people, and pancreatic diabetes. These are the 4 common diabetes we come across in young diabetes: type 1, MODY, and pancreatic diabetes, and type 2 diabetes. Apart from that, rare causes like diabetes and mitochondrial diabetes, Flatbush diabetes, and otherwise ketone positive type 2 diabetes. These are some rare types, but these are the 4 common types of diabetes.
Thank you, Shanmugam. I think you mentioned about the type 1, type 2, HCPD, plus the monogenic diabetes. Now we call MODY as a monogenic diabetes. This next question is Dr. Madhavan. What are the uncommon causes of diabetes in young?
Thank you, Dr. Lakshmanan. It's actually a long list. They fall under a very broad category of about 6 types. I will briefly mention the categories and maybe give 1 or 2 examples for each one. The first one is a genetic defect in beta cell function. The typical example is the transient neonatal diabetes and the permanent neonatal diabetes. The second one is genetic defects in insulin action that results in the so-called type A insulin resistance. The typical example is leprechaunism, Rabson-Mendenhall syndrome, and lipoatrophic diabetes. Of course, exocrine pancreatic diseases can also result in diabetes in young people. The typical example is the pancreatitis causing diabetes, FCPD causing diabetes, pancreatectomy, trauma, malignancy, all this can result in diabetes due to exocrine pancreatic diseases, endocrinopathies, again, acromegaly, Cushing syndrome, glucagonoma, all these things again can result in diabetes. And of course, there are certain drug-induced diabetes. We should not forget it. Pentamidine, nicotinic acid can cause diabetes in children when it is used. And of course, the commonest is the glucocorticoids. And there are, of course, certain genetic defects like Stickman syndrome, and of course, so many other endocrinopathies and diseases which are associated with endocrine organs and result in diabetes. These are all the uncommon forms of diabetes in children.
Can I make a few lines on Stickman syndrome? That's quite interesting for the postgraduates.
Stickman syndrome is actually a type of a genetically induced diabetes. So it's very uncommon. In fact, in the last 38 years of my experience, I've seen only 1 case where it's very typical. You can easily diagnose this case, and the treatment usually is not very specific.
My classmate's son is Stickman syndrome. He's in Australia. The lumbar puncture will tell you the CSF so much rise the guide antibodies. That's the diagnostic of Stickman syndrome. Quite difficult disease to treat. They normally get IV immunoglobulins. Now rituximab is given 30 milligrams once in 6 months for Stickman syndrome for the postgraduate sake. What are the uncommon causes? I think I mentioned it. What is monogenic diabetes and how we make a clinical diagnosis of monogenic diabetes? The previous is called MODY, and this is to Dr. Anand Moses.
Thank you, Dr. Lakshmanan. MODY, or as you call it, monogenic diabetes, was described way back in the 70s by Tattersall in UK and Fajans in USA, where they found diabetes in young people, which behaved like type 2, which did not require insulin. They had a very strong family history of diabetes, and they did not develop ketosis. See, any diabetic who is young was classified as type 1 universally. And the present clinical criteria, nowadays MODY is no longer diagnosed clinically. You have to have a
genetic diagnosis. But since the question is on clinical diagnosis, any diabetic below the age of around 25 who's normal weight and who has a strong family history through 3 generations, who does not have ketosis, history of ketosis, though he's treated as type 1 diabetes. We have found out many people who are treated as type 1 diabetes for years together with insulin, and we have found them to be moderate. So if you have patients who are on insulin, on type 1 diabetes, who are type 1, but even they miss insulin for a few days, they do not go for ketosis. They have diabetes through 3 generations. Always have a suspicion that this could be a MODY. You go back, take a good history. There may be a good history of vertical transmission through 3 generations. And you could as well put many of this, some of these MODYs can be treated very beautifully with sulfonylureas. There are 14, genetically there are 14 types of MODYs. And now it is possible even in Chennai to do a genetic screening and find out which MODY you belong to. And if you are a younger age patient, another differential diagnosis would be type 2 in the young. There are people with type 2 in the young. They could also be differentiated by the patient as obese, as acanthosis nigricans. Probably you will put them as type 2 in the young. And the usefulness of genetic screening is though there are 14 types of MODY, 3 are quite common. One is your glucokinase deficiency patients. Many of them are mild. You can manage them with lifestyle modification. If it's a TNF alpha A, you could manage with sulfonylureas, and TNF alpha B, you can manage with insulin. But others, rare types are also there. But it's worthwhile remembering that any young diabetic, not all young diabetics are type 1 diabetes. That is the general rule. But there is nothing wrong in start when you are diagnosing a patient with 400, 500 blood sugar. Always use insulin. If you are unsure of a diagnosis, bring down the blood sugar. You can reclassify your patient.
Excellent, Moses. I think no evidence of any insulin resistance, both by investigations as by clinical examination. No acanthosis nigricans, no blackening of the knuckles, no fatty liver, no PCOD, no abdominal obesity. So all those things differentiate MODY from a person with type 2 diabetes. Type 1, the fellow always prone for ketosis. First admission in the hospital will be emergency for ketosis. I think you mentioned about neonatal diabetes, Madhavan. Can you say a few lines about neonatal diabetes?
Neonatal diabetes falls under 2 broad.
This again belongs to monogenic diabetes. In adult, we call MODY. We have a group of very interesting now. I think a lot of cases coming now. Started with about 100 cases now. Plenty of cases coming with the neonatal diabetes.
And they fall into 2 broad categories. One is transient neonatal diabetes. Immediately after birth, you see that the child is causing loss of urine, constantly crying. They say a child crying without any reason, you should always check for sugar. And sometimes when they don't go into any complications usually. And one thing very important is that these children, the child need not be treated with insulin. Very often, in fact, I remember Dr. Mohan explaining about one case of it's also very rare neonatal, transient neonatal diabetes. He treated with glibenclamide. You are surprised to see that the child improved extremely well because he titrated. He took a 2.5 milligram glibenclamide, diluted it with water, and gave very small quantities multiple times every day. The child improved enormously. And it is a transient diabetes. Usually it improves, the child becomes normal. But of course, there are rare cases of permanent neonatal diabetes. That has to be treated more aggressively.
Yeah, the time of onset is less than 6 months. Above 6 months, you think of type 1. Below 6 months, please think of neonatal diabetes.
Neonatal diabetes can occur up to 1 year.
No. Commonly it's seen below. Yeah, very important thing. That's the point of thing. They respond to quite a large dose of sulfonylurea. Shanmugam, how do you make a clinical diagnosis of type 1 diabetes? And what's the usual onset of age of type 2 diabetes in India?
Yeah, type 1 diabetes is quite easy to diagnose type 1 diabetes. Though much difficult to diagnose MODY and all other parameters. Clinically, a young patient all along is good within a very acute onset. Otherwise, the patient have classical symptoms of diabetes, polyuria, polydipsia, and classical weight loss If you there past 2 weeks. Before 2 weeks, patient was absolutely fine. Within 2 weeks, patient had classical symptoms, and most of the time, patient ketosis would be positive. Ketone urine ketone would be 1+ or 2+, and 50% of type 1 diabetes at the time of presentation, they develop DKA. They will, we have to admit them for that ketoacidosis. If a patient have a documented ketosis, most of the time it is type 1. There is something called flat push diabetes or type 2 in length. That is quite rare, leave it out. So if a patient have a ketone spontaneous ketosis, what we mean by spontaneous ketosis without a precipitating cause like infection or severe anything like that. The patient had a spontaneous ketosis, acute symptoms, and negatives of type 2 diabetes like PCOD, obesity, and apondosis. All these things are negative, and with the positive symptoms of ketosis, typical type symptoms of diabetes presenting within a short period of time, this is very easy to diagnose as some type 1 diabetes. This is a clinical diagnosis. Anyway, we have to confirm them with antibodies. Once the glycemic control has been achieved, we have to do serum C-peptide to double confirm that they are type 1.
Age of onset.
Most of the, even though the classical textbook says less than 15 years, the common age group is around 10 to 15 years of age. We come across even 20 years or 25 years. Sometimes the textbook used to say that type 1 diabetes prevalence is quite high during winter. But in Chennai or we come across most of type 1 diabetes throughout the time of year. Sometimes during summer also, because of many viral diseases, type 1 diabetes numbers are slightly increased. Diagnosis of type 1 diabetes is quite high during the summer period.
Age is no more a criteria for diagnosing type 1 diabetes, but that has been given up long back. So it can occur in older people also, so somewhat little rare.
You considered LADA as a type 1?
Yes. LADA is closer to type 1. Yes, definitely.
If your GAD antibodies and IA2 are positive, probably you will have to consider. I think we should get into the habit of
checking at least GAD.
Huh?
GAD.
GAD and IA2, which are available very cheap, you know.
But the most is a clinical examination. Look for markers of resistance.
You should know that it is available in MGR Medical University. They use it for not 1,000 rupees. They charge 1,000 rupees. Where outside it costs 6,000, 7,000. You can have GAD, IA2 antibodies, and C-peptide. All three together for 1,000.
I saw a very interesting article on ketosis prone diabetes called KPD. They call flat bush diabetes. Have you heard of it?
Yes.
They mention a few lines on flat bush.
Flat bush diabetes is ketosis prone type 1.
KPD.
So they present typically as type 2 diabetes.
Type 1.
Classically, the features of type 2. They have apondosis, they are obese, fat liver, all these things. So clinically we think of type 2 diabetes, but they have ketosis, and ketosis will remission of ketosis will occur. Sugar will come down over a period of 6 months to 1 year. So suddenly they will develop hyperglycemia. They will develop ketosis. It is otherwise called African diabetes. Is quite high in the African continent. We don't have that much patients, but the complications is quite high. It is a combination of severe ketosis with the features of insulin resistance. Otherwise, we call it double diabetes. That is totally different criteria.
Yeah, initially they need insulin. I think after that we can manage them with the oral drugs.
Between the ketosis, episodes of ketosis, they may be treated just with lifestyle.
Where it's called flat bush?
Africans. It's more common in Africa.
It's an area in Brooklyn, like Vanarapeta in Chennai, where the Africans live. So then it's called flat bush diabetes, KPD. Please remember the different diagnosis of patients requiring insulin at the time of admission. I think next question to Dr. Madhavan. How do you make a diagnosis of type 2 diabetes in a young person, school-going children? And what are the clinical and ultrasound markers of insulin resistance?
I think a high level of suspicion is important. I think the history, good history, will definitely give you a clue that the child may be having type 2 diabetes. One, of course, the most important is one or two, both the parents having diabetes. The child is obese. Very often these children are inactive, especially the days of the gizmos, electronic gizmos. Most of the children they become obese, inactive. They do have blurring of vision and fatigue will be, easy fatigue will be there. But of course, you have to look for the markers of insulin resistance, like acanthosis nigricans, skin tags are again very common. Because the international recommendation today is that you start screening after 10 years of age or after puberty. But if you have a high level of suspicion, you can even screen them before 10 years also. The diagnostic criteria is the same. The correction for instance, the 2-hour glucose post-load has been given up now. The same 75 grams of glucose can be given for a child also. And of course, if you look at the markers, there are certain markers are being developed, but they are all highly theoretical, not in clinical use now. For instance, ferritin is one of the markers which shows a direct correlation with high risk of diabetes in the young. And then, of course, the adipocytokines. I think Dr. Anand has some experience. Adiponectin, low level of adiponectin again is a very good marker of high risk of diabetes in the child. And of course, you can also do a CT scan or MRI of the abdomen and look at the fat content in the abdomen, but these are all more theoretical, not routinely practiced in clinical use.
Now, fibroscan is available plenty. I think we can do that. I think rightly Marvin said, there's no GAD antibodies in these children, very important. And you do a C-peptide, it will be very high. The initial stage of type 2 diabetics, especially young people, somebody comes with PCOD, abdominal obesity, school-going child, 8 years, 9 years, you do the C-peptide, it will be alarmingly high.
Also, I think we should look at the lipid profile. I think one of the things, especially in Indian phenotype, the high level of triglycerides, that can be a marker of diabetes.
On Moses, how do you make a clinical diagnosis of FCPD in your practice? Fibrocalculus disease of pancreas.
You want only the clinical diagnosis.
Presentation and
yes.
You can also say bioclinical.
And we used to see a lot of FCPDs about 20 years back when we were working in Medical College, 20, 30 years back. Almost every week we used to see one or two cases. At that time, routine X-ray of the abdomen was done for all diabetic patients. And the classical, it was defined almost in the 50s in Kerala early. And Dr. G. Varghese at this time. And it also formed a part of the World Health Organization classification. And somehow it has been removed and gone into secondary diabetes now. Now it is classified as class, I think, type 1, 3C. 3C diabetes. Type 1, 3C is fibrocalculus pancreatic diabetes. The clinical presentation, what patients we do not see nowadays, those days, is a younger age patient with high insulin requirement and emaciated. Ketosis may not be present, but classical facial features is enlarged parotid glands. Enlarged parotid gland, lean person with enlarged parotid glands and a bluish hue around the lips. As soon as this patient walks into the OP, we will talk that this patient is probably a fibrocalculus pancreatic diabetes. So clinically, the diagnosis is there. And if you take the history, it used to be described in Kerala, but now it's described in some parts of Chengalpet, where we used to get patients regularly. In Orissa, it has been, a large number has been described. And they also have features of exocrine pancreatic, like steatoria. And many of them are lean. And what happens is when they are lean, they are pushed with extra fat in the diet to make them fat. And this gives more steatoria and other problems to them. But nowadays also, and X-ray clinical classical features, you have to distinguish between alcoholic pancreatic calculi and fibrocalculus. Here it's intraductal calculi. The classical, there it is specks of calculi. Alcoholic calculi disease will have specks of calculi. The classical definition is diabetes in a non-alcoholic patient. And many of them have reserves of beta cells, so they do not go into ketosis. Even if they don't take insulin for a few days, they lose weight, but they don't go for ketosis. But many of them require insulin.
Yeah, no ketosis, but they are very lean, emaciated. I think the investigation X-ray abdomen is very important. A person with diabetes in the young, one X-ray will tell you the patient will HCPD or not. And if you are very keen on doing an exocrine function, do fecal elastase. So that will also give a thing. So need pancreatic supplements with insulin. Some people also respond little to oval shares also. So one time now I think long weight is better with the newer insulins and the pancreatic enzymes replacement therapy.
Yes, they require high dose of insulin. And a lot of cases are reported from Kerala. So it was thought, even in Kerala, the lower socioeconomic class, people working in rubber plantation and other areas where they were consuming cassava, that is your, what do you call it? Instead of rice, they take that as a staple food. And this was described more in them. So it was thought it is due to some toxin in that cassava. That was one of the hypotheses, but it has not been proved.
Naraj, I applied for some time. I request you to answer how to clinically differentiate monogenic diabetes versus type 2 diabetes.
Till now, Dr. Anand was discussing extensively about it, as well Dr. Madhavan said about type 2 diabetes. Anyway, quickly summarize that. We clinically examined the family history of 3-generation diabetes with the autosomal trait. Straight away it is going to be MODY. The onset of age, if it is going to be less than 6 months, we know it is more of neonatal or congenital diabetes. We know the MODY is going to be peripubertal age, and clinically, the monogenic diabetes is going to have no features of metabolic syndrome or insulin resistance. That's typically we discussed about it. So there is no obesity, there is no fatty liver, there is no appendiceal diagram, there is no skin tag, there is no PCOS, there is no disturbance in the lipid profile. And we also should suspect monogenic diabetes if there is going to be a coexistence of neurogenic abnormality as well as neurogenic abnormality like renal cyst, development of absence of vas difference in the individual, the deafness, optic atrophy, all this, there is going to be coexistence, suspect more towards monogenic. Laboratory, it's going to have no antibody and the presence of Dr. S.S. mentioned presence of a good amount of C peptide. Quick clinical approach to the diabetes is young. If it is type 1 diabetic, we know it is the patient is going to present with the weight loss and decay and absence of GAD antibody and absent C peptide. In type 2, we have features of insulin resistance, obesity, and there is a good amount of C peptide. We discussed about it. In MODY, generally occur below the age of 35, and we said about the history, 3-generation and absence of antibody, and there is no decay in those individuals. The mitochondrial diabetes, which is also monogenic, has presence of deafness, myopathy, cardiomyopathy, and so on, and short stature. And if it is Ditman syndrome, the diabetes is present with diabetes insipidus with optic atrophy, and lipodystrophic syndrome. Clinically they have fat loss either central or all over the body, and fat loss. We just now discussed the patient will have very fluctuating blood sugar and presence of ketosis and symptoms of insulin resistance.
But it's important to recognize this MODY versus type 2 diabetes in your practice. Is it important?
Definitely.
Because both are going to get the OHS.
Definitely, because the certain type of MODY will require very, say, MODY 3. You require 1/4 the dose of sulfonylurea. If you are going to give a regular dose of sulfonylurea, patient certainly will go for hypo. Say MODY 5 will require insulin. And clinically we need to definitely differentiate. Of course, if the facility is available, we should warrant for genetic test.
But for
MODY is mostly a secondary defect.
Okay.
Whereas type 2 diabetes is insulin resistant.
There are no markers of insulin resistance in MODY. That's very important. Fasting C peptide will be very high in type 2 diabetics. It's very low in monogenic or MODY diabetes.
Type 2 diabetes, the treatment are starting with metformin. For MODY, no use of metformin.
Yes. Great.
You should stress more on the lifestyle management in type 2. Because many of them are obese.
We can do it.
We have recognized children, obese, very obese children, started on metformin, but just with lifestyle modification and intensive weight loss, they have become normoglycemic.
If you get them at the time when the fasting C peptides are very high, we can really make them revert back to normal with exercise. A risk called diet, drill, and discipline. You see school children coming out of the school with chips, all sorts of snacks. Shanmugam, how do you? We are talking about early type 2 diabetes. Yeah. Dr. Shanmugam, how do you clinically differentiate monogenic versus type 1 diabetes?
Monogenic, most of the time, will not be asymptomatic because the sugar will not be that much high to cause symptoms. Usually, it is a gradual disease, not like acute onset like we discussed in type 1 diabetes. And there are most of the time asymptomatic with the classical history of 3-generation diagnosed family history. They don't have any complications associated except OD3. And in type 1, already we have discussed their classical symptoms, ketogenic and lean, and C-peptide is quite low. But in monogenic, it is a normal weight. Family successive family history should be there. Non-ketosis and they are asymptomatic.
Yeah, no, majority of the cases, it is not difficult to identify between type 1 and monogenic because type 1 we know is an explosive onset. But there is a small category of people called slow onset type 1 DM. Now we recognize it increasingly in India, where the loss of beta cell is not total. So these patients may initially present as type 2 diabetes. So I think in those small category of people, the slow onset type 1 DM, sometimes it's difficult. One has to do a peptide and other investigation.
Modi guys are very smart to look. They never have something like diabetes at all. They look very smart, no waistline, no abdominal obesity. The casual recording of the sugar will show. He says all the 3 generations had a high blood sugar.
Lakshman, one word about the C-peptide measurement. When you initially diagnose a patient, when the sugars are very high, there is a condition of glucotoxicity in this patient where beta cells are suppressed. So don't do a C-peptide at the time of diagnosis. When you are seeing a patient with very high blood sugar, you will get it may be a type 2 diabetic, you may get a falsely low blood sugar, C-peptide level. So normalize the blood sugar first. And sometimes beta cell starts functioning. Then you measure a C-peptide. Only then you will know the exact function of the beta cell. There are sometimes, even in type 1 diabetes, you can get a normal C-peptide. In what condition? Any postgraduate wants to volunteer? A type 1 diabetes, a florid diabetes, can you get a normal C-peptide? There's a condition called honeymoon phase of type 1 diabetes, phase of remission. In a type 1 diabetes, when you start treatment, whatever remaining beta cells starts functioning, and the patient can be off insulin also. You remember, it's a type 1 diabetes, but they can be off insulin for a few days, for a few months also, without insulin. At that time, if you measure the C-peptide, it will be normal. So that is why C-peptide and GAD should go hand in hand. These people, GAD antibodies are still positive, or IA2 antibodies are positive. So one condition in type 1 diabetes where C-peptide is normal is during the period of remission, or what you call it as a honeymoon phase of type 1 diabetes.
Sharma, what are the antibody titers you look in type 1 diabetes?
Antibodies commonly we do is GAD antibodies, insulin auto antibodies, that is islet cell antibodies, and the zinc peroxidase. Zinc, that is most sensitive antibodies.
Yeah, zinc transporter 8. Yeah. So that's very important. ZNT8, GAD plus the islet cell antibodies. All the 3 are
most sensitive one, and GAD exists for so longer period. So most of the time we do GAD antibodies.
Of course, a very easy question for Madhavan, differentiate monogenic versus FCPD.
I think we have individually discussed about the two diseases. Monogenic is genetic. You find already described 3 generations vertical transmission. Weight may be normal or slightly a little overweight, but definitely not obese. And it's a very mild form of diabetes. Most of the time, all that they require is lifestyle modification or a small dose of being a secretary defect. Sulfonylureas will take care of the hyperglycemia. FCPD, of course, we know there is no family history. History of chronic abdominal pain from childhood with steatorrhea. They are very lean. Most of the time, the BMI will be less than 19. The cutoff is usually 19. Less than 19 is BMI. And of course, the diabetes is very, very severe one. The hyperglycemia is very severe.
they require very large doses of insulin. And as Anand was correctly telling us, they won't go into ketosis in spite of the fact that they do not have very high blood sugar and they do not gain weight. That is another very important clinical feature. Most of the type 1 diabetics, when they present, they are very lean, cachexic. You put them on insulin, they gain weight. But the FCPD people, whatever is amount of insulin, they do not gain weight. So most of the time they are cachexic. And of course, your investigations, X-ray will show the calculi. I think it's very easy to identify. They are two ends of the spectrum.
Natarajan, a very big question for you. So you also shared your points. Briefly explain to the audience the types of monogenic diabetes, which is the commonest mode in India, and genetic effect. And I told you the common types, and which is most common in India.
This question is a symposium of its own. It is so extensive, but I quickly wrap up in less than 5 minutes time. Monogenic diabetes are responsible for 1 to 3% of the diabetes in young. Multiple genes are involved. Can cause 1 or 2 types of phenotypes. One is the neonatal or congenital diabetes. It is caused by a few member of overlapping genes, even in MODY. And we know the MODY, it's a maturity onset diabetes of young. And there are 14 types and 14 genetic gene involvements are there. I'll quickly tell about a few important things. In a question, common monogenic diabetic in India are the MODY 3 and 2 and 1. These 3 to 1, they respond to sulfonylurea well. The MODY 5 and 10, it requires insulin. And MODY 12 and 13, it is neonatal diabetes. They respond to high dose of sulfonylurea. When you look at MODY 1 and 3, they look like type 2 diabetes. The onset is in adolescent, progressive beta cell dysfunction occurs, and it responds to sulfonylurea. The MODY 3 is the most common monogenic form of diabetes. It's all over the world, also in India. The onset is generally in adolescent at the age of 14 years around. There is a progressive insulin secretory defect. The chromosome involved is chromosome 12. The gene involved is hepatocyte nuclear factor, that is HNLF1 alpha. That is a gene involved. And it is generally associated with low glucose threshold, there is a glucosuria, there is a low HSCRP, there is a high risk of CV disease. That's why in the treatment we should include statin, and there is a risk of benign liver adenoma. They respond very well to sulfonylurea because they are highly sulfonylurea sensitive. Start with 1/4 of the dosage of sulfonylurea and slowly uptitrate. And they also respond to the GLP receptor agonist and DPP-4. The MODY 2 is the second commonest form of monogenic diabetic. The defect chromosome is the chromosome 7, and the enzyme involved is the glucokinase enzyme. And the onset is anything ranging between 0 to 18. The common age is 10 years. And it is a non-progressive hyperglycemic state, mainly the fasting hyperglycemia. Generally, it doesn't require any treatment. It is incidentally found when you do a regular glucose tolerance test or during pregnancy. When you do the test, generally it's picked up just like that incidentally. And most of the time, they do not require any active treatment. The fasting glucose remains between 100 to 145, and generally they don't go in for any complication, except in pregnancy. In pregnancy, we have to decide whether we have to give treatment or not, because in fetus, if the fetus inherits the glucokinase in a mutation, the mother hyperglycemia is also recognized by the fetus, and they act accordingly and they don't respond. But if the fetus is not carrying the mother mutation, they recognize the hyperglycemia and start secreting more insulin, resulting with the macrosomia and further complications. So these are the category of people they need treatment. And how do we pick up the fetal mutation is by the fetal ultrasound. The abdominal circumference in the second trimester makes a difference. If it is more,
we need to treat. If it is normal, we don't need to treat. The next commonest type is the MODY one, and the chromosome involved is the chromosome 20, and the HNF4 alpha gene is involved. The onset of the age is generally 40, and macrosomia is the common feature, and there is a congenital in infancy. There is a congenital hyperinsulinemia can take the child to a hypoglycemia at birth, and generally they respond to sulfonylurea and DPP4 and GL receptor agonist. The MODY 5 is another commonest one. The defect in the chromosome is 17. The involvement is the HNF1 beta. It is generally associated with pancreatic hyperplasia, and there is genitourinary abnormality, like the renal cyst. There is agency of VASP. There can be hypogonadism. It is also called RCAD, that is renal cystic disease and diabetes. The RCAD, and this people can go for renal failure not because of the diabetes, because of the renal cyst. And the additional features are elevated liver enzyme. There can be gout, uric acid can be high, and they require only insulin. The common neonatal or congenital monogenic form is MODY 12 and 13. And as Dr. Madhavan already said, it can be either a permanent type or it can be a transient type. The transient one, the onset happens around 4 weeks, and it gets over by the remission happens around 35. It can arrive, come back later. It can, and they respond to high dose of sulfonylurea. And there is no, if there is going to be no response to sulfonylurea, we can go for insulin. The MODY 10 is a defect of insulin gene, and it's also seen more in the neonatal diabetic state, respond to OAD or insulin. And the other monogenic diabetes can be, as I already told you, the lipotricyclic type 1 and mitochondrial diabetes, which can be associated with deafness and short features and myopathy. Dixman syndrome, I already told you, is associated with diabetes insipidus and optic atrophy in the first decade and deafness in the second decade.
Want to add anything, Madhavan? One type of MODY where I would like everybody to be cautious is the one we described about the hyperglycemia renal syndrome. It's MODY 5, because many of these people, we have been telling repeatedly that MODY is a very mild form of diabetes. Most of the time, lifestyle and small dose of secretococcus take care of the hyperglycemia. But this is one syndrome where there can be rapid progression, and they can go in for renal failure. I have a family of 3. All the 3 of them have this type of MODY, and all of them ultimately develop ESRD, ultimately even needing renal transplantation. So this is one type of MODY where ultimately they may require insulin, and we have to be cautious about the renal failure.
Yeah, MODY 5 is called retract syndrome, renal cyst and diabetes. As rightly said, they go in for renal complications. They have low magnesium levels, increased uric acid levels. That is a clue to your diagnosis. Anything else, Moses? You want to add? I think MODY 3 is the commonest, number 1. As rightly Rajan said, the low HSCRP. I think I was in a conference in UK, Oxford International. Speaker was very, very particular that the low CRP and low HSCRP, low in MODY 3. I think we discussed quite a lot with the MODY and the chromosome defects and the what are the things to be treated. I think all of you can summarize the biochemical changes which helps in the diagnosis of different types of diabetes in young. Some diagnosis. So what are the tests you do? In differentiate all the 4.
Many of them can be clinically diagnosed itself. If you see a younger age patient with type 2, if the patient is underweight and emaciated, always think of a type 1 or a FCPD. Normal weight, you think of a MODY. Overweight, you think of a type 2 diabetes.
You're like your daddy. You made diabetes simple.
Yes, it is very simple. You think of these 2, then you investigate on these lines. If your patient is emaciated and down, then you investigate, you go for investigating with your antibody test, you do the urine ketones, take a ultrasound abdomen for pancreatic calculi. This is for an emaciated patient.
For a normal weight, patient think of, and you are going to take a good history. You can pick out 2 or 3 generations of diabetes. Then you can think of a genetic mapping, which could be done. If the patient can afford, I think, normal weight, when you think of a body, a genetic testing should be done.
I think it costs about 20,000 rupees.
17,000 rupees.
17,000 rupees at. Okay.
6,000. But
is what doing the market.
3 places, I think. One is Jipper, they are doing, and CMC Vellore and Mohan Center. Another private center is doing for around 20,000. Because it's going to change the line of treatment. And future line of treatment also can be planned.
I had a patient 3-4 months back. All the time sugar was 450, 550, 650. Insulin, OHS, everything. He's only 21 years old. Then finally the doctor referred the case to me. When he opened the shirt, he had full of striae in the abdomen. I said, you check for Cushing's. When the report came as Cushing's, later on he went for surgery. So some of the conditions were treatable diabetes. So remember, young people, apart from these 4, some of the endocrinopathies which can manifest as diabetes. So he was getting treated for 3 years. People have now opened the shirt and seen his hump and the lower abdomen. I think we had a wonderful session. I just appreciate all the panelists who have been a very excellent insight. I think all the folks will be very happy to now in future look for young diabetes. It's not only type 1, type 2, but other forms of diabetes. Any questions from the floor, they'll be ready to answer for you.
I think you can. Yes.
Speak in the mic.
Yeah, thank you for the wonderful session. Just 2 questions. One question was that C-peptide should not be evaluated at the time of diagnosis, accepted. But what if a person started on sulfurine ureas, assuming that the patient is having type 2 diabetes, and maybe 6 months or 1 year later down the course, they come to us and we are in a clinical suspicion that whether it's type 1 or type 2, and will the sulfurine urea mask the actual C-peptide which should have been diagnosed earlier?
One thing, your type 1 would not be normal. If it's a real type 1, 6 months without insulin, it is unlikely. The
Type 1 always present in the hospital. Admission, infection and ketosis.
It's
There's no other way of presentation.
It's a very florid presentation. Patient has all the polyuria, polydipsia, polyphagia, weight loss, and you cannot have the patient on a sulfonylurea for 6 months. If your patient is on a sulfonylurea for 6 months, it's not probably a type 1. You have to think of a MODY or a type 2 in the young or a FC.
Oh. My question is, C-peptide.
Okay, right. That is a question.
Yeah. So when would be for the diagnosis of an actual C-peptide?
Yes.
Can we rely if a person is already on a sulfonylurea? Can we rely on that diagnosis?
Yes, we can rely, because if the beta cell mass is not sufficient, your sulfonylureas are not going to work. So if in spite of sulfonylurea, if the C-peptide values are low, then probably it's a type 1 diabetic or a
what
it's a test for beta cell reserve.
Yes,
what C-peptide is normal?
Yes, if the C-peptide reserve is very poor, even if the patient is on sulfonylurea, endogenous insulin secretion is going to be very less. Your sulfonylurea is going to function only if there are adequate C-peptide. Adequate beta cells.
Now you are asking if the C-peptide is normal at that point in time. You have to say that probably it is not type 1 diabetes. It is still some other category of diabetes.
No, the reason is because
the method of, if you understand the methodology of doing C-peptide has to do both in the fasting and the stimulated C-peptide. Stimulated C-peptide means that either you have to give glucose or mixed meal without any drugs. You should not give any OHA, insulin should not be given that time of measuring the C-peptide. The same C-peptide should be done along with the random blood sugar. So either if you do in fasting and postprandial. If patient already on sulfonylurea, the fasting C-peptide already will be elevated, as you said. So if I stimulated C-peptide, if it's again elevated much more, it's classical type 2 diabetes. If even with the stimulated C-peptide, even with mixed meal or full meal, the C-peptide level is less than 0.5 nanomole, then we call it as type 1 diabetes. In Modi, there will be normal C-peptide or the stimulation also be moderate. In type 2, there is a huge stimulation that happens after the stimulated C-peptide. So C-peptide has to be done in 2 ways. By doing only the fasting C-peptide alone will help us only for insulinomas. If a patient have a fasting hypoglycemia, then fasting C-peptide will help us to diagnose insulinomas. But stimulated C-peptide is the one to make help us to differentiate between OD type 1 type 2.
In most of the cases, type 1, the onset is explosive. The way they present, I don't think you are going to miss a type 1 diabetic. But there are, as I told you previously, a small group of type 1 diabetic patients where the destruction of the beta cell is not complete. It progresses very slowly. In those patients, you may have difficulty, but again, we call them ambulant ketosis. They walk into a OP, their blood sugars will be 400 plus, you do a urine stone, it is positive, but they are not in, they don't have any electrolyte disturbances or their mentation is normal, everything is normal. That is called, we call it ambulant ketosis. In fact, we coined the term way back in MMC in 1980s. Initially, it was not accepted internationally, but now international literature, some of the literature accepts the terminology, ambulant ketosis. So those small percentage of patients, sometimes you find it difficult. But again, I think with the antibody testing and other things, it should be easier. It's not at all difficult.
Because many of
mostly 300 postmortem newly detected type 2 diabetes collectors. For 15 days, insulin alone, just 10 units PAD, beta cell preservation of the precursor, converted to only metformin you can manage. Like type 2 diabetes at this early phase, like type 1.
Early type 2 diabetes, they don't respond to insulin. Sometimes if you burn our fingers, patient comes with 100, 140 units of insulin. Those one simple OH or a DT4, the sugar will come to normal. So it's not advisable to put these guys on. That's why the clinical examination. Somebody's got markers of resistance. You always think it is a type 2 diabetes.
Yeah. Because I am into basically online diabetes management. So I get people from across the country where they present with 5 years, 10 years duration of diabetes with only lab reports, no clinical examination. You have to rely only on history and lab reports. They come with the C-peptide, normal C-peptide, or the doctor will tell low C-peptide, so you are type 1. So there's no need for a C-peptide in a type 2 diabetes. Why do you want to do a C-peptide?
C-peptide.
You have a normal sugar post part of the package where at the initial examination C-peptide is done, fasting insulin is done, HbA1c, everything is done. That creates
Lakshman, there may be a role for C-peptide measurement even in type 2 diabetes of long duration.
Beta cell reserve.
When you know when there is a beta cell failure, how to find out a beta cell failure. One way is to do a fasting and a stimulated C-peptide, as you said, fasting C-peptide, and after a meal you do a C-peptide. If it is very low, then there is no point in continuing the oral drugs the patient needs it. Otherwise, as a routine test, C-peptide is not required.
Most of the time, the patient also has a psychological barrier. Very difficult to convince them to go in for insulin, type 2 diabetes. So you do a C-peptide, tell him, see, your insulin reserve is totally not there. So you have no choice but to go in for insulin. That way also helps us. Dr. Anand was telling us, before deciding whether you are going to discontinue oral agents and put the patient on insulin, C-peptide might be done. Otherwise, in a typical type 2 diabetic, there is no role for C-peptide estimation at any point of time.
I think Shanmugam is restless. He wants me to finish. You can give a big hand to them.
Thank you, Dr. Lakshman.
Thank you, Dr.
And your team,
Thank you.
Dr. Anand Moses, Dr. Madhavan, and Dr. Natarajan, and Dr. Shanmugam. We should know that the youngsters, even without slides, you can make the audience more attentive and also informative doing panel discussion like this. And the moderator and the speakers, they have done very wonderfully. And it's very difficult to diagnose very early the young diabetics with so many modifications you got with type 1, type 2, MODY, etc. With this, we'll finish this one and complete. We'll go for the next one. Thank you for your timing also. Contingent. Before inauguration, we will have the last session. We got 2 cardiological and 2 diabetic talk. For that, I will request the chairperson, Dr. Balaji Nathan, he is the Dean, Teni Medical College, and also Dr. C. Balaji, the diabetologist from Kumbakonam, to chair the session. We got eminent speakers, Dr. A.M. Karthikeyan, interventional cardiologist from Apollo Hospital, Dr. T.R. Muralidharan from SRM, Ramchandra, and later on now we will have Dr. Jayasri Gopal. She will be on web, leave. And the last one, Dr. Veena Asirvadam. She will join sometime later. Now the stage is open to the chairpersons.
Good evening to all. Now we will go straight away to the lecture by recent Dr. A.M. Karthikeyan on recent advances in management of heart failure.
Good evening, respected chairpersons, my dear colleagues and friends. Good evening, everyone and all. At the outset, I would like to thank the organizers for this opportunity. But topic is today's recent advance in management of heart failure. So, as we are discussing more about cardiometabolic and diabetes, so a lot of correlation with the heart failure also. What are the advancements happening in the management of heart failure? I will just take you through in the next 10 minutes. As you're all aware, heart failure is a complex syndrome. It includes symptoms and signs, which you are all aware of that from our MBBS days. We are being taught how do you identify the heart failure from clinical symptoms and signs, and it happens because of structural or functional impairment of ventricular filling or ejection of blood. Structural means either myocardial heart disease or defects or valvular heart diseases. These are a structural problem. Or functional impairment where systolic dysfunction or diastolic dysfunction, which causes heart failure symptoms and signs. These are more of clinical diagnosis based on symptoms and on patient symptoms. The guidelines are very clear about it. You have to, someone has a stage A heart failure, which is they have all the risks, but they don't have any signs and symptoms, even no biomarkers, but there are at risk. Then stage 2, pre-heart failure. They have the structural heart disease, they have the biomarker positive, but they don't have any signs and symptoms. And stage 3, they are the classical patients who come across all the symptoms and signs of heart failure, the structural abnormality, and clinically they need medications to manage it. And then stage D is advanced heart failure. Here we are going to discuss about the stage 3, symptomatic heart failure. How do you manage? What are the ways we can manage this patient? Again, further classification, you are all aware of that based on the ejection fraction. So you have to know that based on less than 40 is called reduced ejection fraction. Anything mild reduced or mid-range ejection fraction 41 to 49, or anything preserved ejection fraction is more than 50%. So anybody is heart failure, we have to classify accordingly whether it's a reduced ejection fraction or mid-range ejection fraction or it's a preserved ejection fraction. And any of these patients can go into by deteriorate or they improve in terms of ejection fraction. So that I will take you to the newer advancement in these patients of 3 different categories. What are the newer advancement happens in the drug therapy? What are the newer advancements happening in device therapy? How do you manage arrhythmias and heart failures? So these are what are the advancements. I don't want to touch the already established therapies, but we will go for what are the advancements happening in this field. We are all aware that when you talk about heart failure management, the cornerstone is beta blockers. Once upon a time, 3 decades back, we have been taught beta blocker should not be given. But now beta blocker is the cornerstone of heart failure management. It is a maximum reduction in the mortality by 34%. And then comes AC or ARE inhibitors, which is a 16 to 17% mortality reduction. And then an MRM, mineralocorticoid antagonist, which is a 30% reduction. So these are all drugs are available to us. We have been managing that. Despite of all these drugs, the management, still significant number of patients we get into death due to heart failure, which is more than 50% of people die in 5 years after diagnosis. So the research is continued. What are the newer ways we can manage this patient in terms of the medical management? Then came almost 8 years back, has been published angiotensin neprilysin inhibition when you compare it to enalapril. That is an army drug. So John McMurray has published this drug, wherein this drug, which we know that ARBs, which is RAS inhibition, ATU receptor 1, which inhibits the deleterious effect of the angiotensin blocker, which is by inhibiting the vasoconstriction, so it will provide the positive effect, which has already been established. We know that ARBs have beneficial role in the inhibiting the RAS inhibition. But when you add this sacubitril, which is inhibits the neprilysin, which is the enzyme which degrades the good peptides like natriuretic peptides, which has a lot of beneficial effect in the heart failure patients. By inhibiting that, it increases the blood level of natriuretic peptides. So you get the beneficial effect of the natriuretic peptides like relaxation, reducing the blood pressure, reducing the sympathetic tone, reducing apoptosis, reducing the hypertrophy, vasoconstriction, everything is get reduced. You get the beneficial effect of the neprilysin. So the combination of valsartan with the sacubitril, when the particular combination, when they give to this patient, that's what the study, the paradigm trial showed that when you give this particular combination, the patient gets a lot of beneficial effect over and above that AC inhibitors. When they compare to the enalapril, which is a well-established drug for AC inhibitors, a lot of heart failure trials have utilized enalapril to the proven benefit. When you compare it to enalapril, this combination showed there is a 20% reduction in the primary endpoint, that is death and cardiovascular death and hospitalization, and death alone from the cardiovascular cause reduced by 20% and 21% reduction in the hospitalization due to heart failure, and death due to any cause is 16% mortality reduction. These are all over and above the AC inhibitors and beta blockers and MRAs. So already well-established drugs are patients, most of the patients were on. When you give this drug, which proven much more beneficial effect compared to the established drug. So based on that, the current guidelines and the recent past has clearly said that class 2, class 3 patients should be initiated ARNI, that is sacubitril valsartan combination. And because of it is reduction in the morbidity and mortality. And somebody is already taking medicines like AC inhibitors, like nowadays we use ramipril or ARBs, valsartan or losartan. They have to be replaced with the sacubitril valsartan combination because of that added advantage in reducing the mortality and morbidity. Then the next drug came, which has been many of you are aware that dapagliflozin and empagliflozin, which has come off the diabetic drug, then later established its role in the heart failure management. Again, John McMurray published in 2019, it clearly showed that when we compare it to all other drugs, including ARNI and the device therapy plus AC inhibitors, ARBs or beta blockers, if you give this drug, the dapagliflozin, it reduces the further primary endpoint like heart failure and hospitalization and death. So the guideline is very clear that irrespective of the diabetic status, all the heart failure patients should get this SGLT2 inhibitors, that is dapagliflozin or empagliflozin, based on these trials. So in summary, the drug therapy, if you talk about the drug therapy, all the reduced ejection fraction patients should be on beta blocker, AC inhibitors or ARBs, preferably ARNI, and then they should be on the SGLT2 inhibitors as well as MRA. All these drugs, 4 drugs should be on board. If you are not giving this drug, unless there should be a contraindication or patient is not tolerating this drug, we need to put it up and mention that. So otherwise, this is a standard line of medicine is these 4 drugs should be on board somebody if you are managing with reduced ejection fraction. Is it enough? But there are a lot of practical difficulties you face when you're trying to manage this patient because lack of complaints or the patient continue to be symptomatic despite of all the medication, or they will not tolerate it. The BP doesn't permit you to start the medication, or renal parameters doesn't permit you to introduce this drug. There are COPD or asthma, they will not permit you to start. So there are a lot of intolerant or inadequacy or compliance related issues will come. But somebody is on all the drugs also, still they can get into the problem of sudden cardiac arrest instead of taking all the medication. So the benefit of device therapy comes when improvement heart failure symptoms, reduce the hospitalization, improvement quality of life, prevention of sudden cardiac. This is a primary goal of managing any heart failure patient. This device plays very vital role in establishing this over and above the drugs. Let me show the example. This is a gentleman of 62 years, EF of 30%. This is the ECG. We can see that when a postgraduate should be able to identify there is a left bundle branch block. Clearly, you will see the left bundle branch block in this ECG. So what this shows? See this. When you see this echo, there is a So there's a rocking motion. When the septum contracts, the lateral wall goes out. When the lateral wall contracts, septum goes out. There's a dyssynchrony. We call it dyssynchrony. This we'll see in a heart failure patient while it is more than 1/3 of the patient when they have the ECG showing like left bundle branch block or intraventricular LBV like intraventricular conduction defect. We will see this sort of findings in a echocardiogram and ECG is very wide ECG. When you see that, then you have to go for a resynchronization. When your ECG is showing that white QRS complex like LBV, it is likely to cause dyssynchrony, which worsens the heart failure, wherein you have to go for a resynchronization. So you can see this again, this patient is a moderate mitral regurgitation with a dysynchronous contraction. And then you go for a resynchronization therapy. Everyone should have, because these therapies are available more than 25 years. For more than 2 decades is widely practiced in India. Every practicing physician should be aware of that. When a heart failure patient with reduced ejection fraction has the white QRS complex, this is established therapy for more than 2 decades, which is wherein the QRS more than 130 millisecond, ejection fraction less than 35%. We put 3 leads, one is the RA-RV, one is with the coronary sinus, put it in the lateral wall of the LV and try to stimulate the heart by both the RV and LV. You resynchronize the heart, increase the cardiac output, eliminate the dyssynchrony, establish the synchrony between the atria to ventricle, ventricle to ventricle, that is RV and LV. By that, we can improve the things. The patient comes after some time, after 1 year, you can see that how the LV shrunk, that is called reverse remodeling. The dilated heart will become shrunk, the normal diameter comes, mitral regurgitation disappears, all those things come. And these are all happens over and above the standard medical treatment, which I discussed before. So this patient should not be missed and they should be referred to the appropriate person to get the device therapy done, which can normalize their heart failure symptoms and normalize the ejection fraction. It reduces the hospitalization in a class 2, class 3, and ambulatory class 4 patient. And then why should wait for someone to develop heart failure symptoms? So you can even a mild symptomatic patient, when they have a reduced ejection fraction less than 38% of the white QRS, we can go ahead and put a device therapy so we can prevent the heart failure treatment. So the indication is anybody is a heart failure patient less than 38% with the QRS more than 150 millisecond LBV pattern or 130 to 140 in the LBV pattern, and is a class 2 indication, more than 150 in a non-LBV patient like RBV or IVCD, more than 150 is a class 2A indication. So conduction system pacing is a newer advancements. What I have shown is well established more than 2 decades. What is advancement is the conduction system pacing. How is this conduction system pacing? It provides you to improve the heart failure symptoms. Rather than stimulating the myocardium directly, which I shown the ECG, you pace the pacing lead near the electrical system of the heart. Like you can see that his bundle and then left bundle, right bundle. You put the lead near the his bundle and pass the electricity to the his bundle or left bundle. So the stimulation goes via the intrinsic electrical system. So that when you stimulate the myocardium, it takes longer time to spread, it causes dyssynchrony. When you stimulate the directly conduction system, it spreads very fast. So the synchronized contraction establishes. So this by doing this synchronization, the conduction system pacing, we are moving towards more physiological pacing, not causing any pacing-induced cardiomyopathies. The patient with LVEV, you can see the syncope, intermittent AV block, and also has LV dysfunction, where you can put a his bundle pacing, stimulate the his. Not only LVEV disappears, the QRS becomes pretty narrow, so that the patient of dyssynchrony also eliminated, his ejection fraction also improved, and the pacing purpose, bradyarrhythmia, pacing, syncope also eliminated. So by doing his bundle pacing, you can do that conduction system pacing with a regular 2 leads. We can narrow the QRS complex and improve the ejection fraction. Again, the patient with non-ischemic cardiomyopathy, LVEV, you can put a simple conduction system pacing. You can remove the LVEV, make the QRS like a pretty narrow QRS complex, and these patients' ejection fraction improves and they come back to normal ejection fraction very pretty soon. Sometimes all the patients who may not able to the traditional CRT may not able to establish it. Sometimes we optimize it with either by along with the left ventricular lead, we place the right ventricle through the his bundle or the left bundle, what you call his bundle optimized or left bundle optimized CRT. So where the scar ventricle, wherein if you stimulate from the LV as well as from the conduction system, it narrows the QRS complex, better synchrony we can establish. So nowadays, because of this avoidance of pacing-induced dyssynchrony and heart failure, any of these patients post-TAV or any brady indication also, we are moving more towards conduction system pacing rather than doing the traditional pacing, because traditional pacing itself can cause heart failure and pacing-induced cardiomyopathy, ejection fraction drop over a period of time. By doing this conduction system pacing, you can avoid that. Rather, somebody is having LV dysfunction, you can improvise the ejection fraction by doing conduction system pacing. So other important factor is one should remember is that sudden cardiac arrest. Less symptomatic patients are likely to die of sudden cardiac arrest because of VTVF. So one has to remember that the patient after 5 years, 10 years, 20 years after CABG or PTCA, they can get into problem of VTVF. Some very few will reach the hospital with monomarker VT or something. Many people will perish before even reaching the hospital. That's why you heard of sudden cardiac arrest. So these are the patients who benefit with what you call resynchrony with the ICD implantation. So the indication is somebody is lucky enough to survive after sudden cardiac arrest with a reduced ejection fraction. You should recommend them to go for a AICD implantation. But one should not wait. As I mentioned, very few will reach the hospital. So you should upfront in a clinics before they get into VTVF. You should identify the ideal patient like EF less than 35% or post-MI more than 40 days or post-CABG more than 3 months, and the EF is less than 35%. You should counsel them to go for AICD implantation apart from the routine drugs which we discussed. Over and above that, ICD offers more benefit in terms of preventing sudden cardiac arrest. Few words about arrhythmias is very important. Sinus tachycardia, heart failure patients, heart rate maintenance is very important. If you are not able to maintain the beta blocker, you should add evaporative to maintain the heart rate, sinus rate around 70 beats per minute. But many times these patients also can develop atrial flutter fibrillation because of common arrhythmias because both are interrelated. Heart failure further aggravates atrial flutter fibrillation, or sometimes atrial flutter fibrillation, uncontrolled ventricular rate causes heart failure. These are the patients, so young patient, persistent atrial fibrillation, gone into heart failure, referred to the transplant, wherein even cardioversion failed. When we offer them the pulmonary vein isolation, it's often forgotten. Many physicians, cardiologists, even they think that atrial fibrillation is only medical treatment. There is a role for AF ablation, especially more so in a patient with heart failure, wherein we ablate the pulmonary vein around the circumferential pulmonary isolation, and then we establish the sinus rhythm. The patient within 6 to 8 months, the ejection fraction comes back normal. To refer to the transplant people, now is out of the transplant and the normal ejection fraction. So when the drug refractory atrial flutter fibrillations or especially atrial fibrillation, one can consider radiofrequency ablation for maintaining the sinus rhythm. That technology also over the 2 decades has improved a lot of things. But 20 years back it was only 60%. Now it has become 85% with advanced technology of smart touch and the recent technology of ablation index and so on. The technology has improved that a good success rate can be established in a patient with atrial fibrillation. And recently we launched in India cryoablation, even with heart failure patient with the AF, where you can put a balloon and isolate the pulmonary vein ostium, we can maintain the sinus rhythm in this patient. So establishing sinus rhythm and heart failure is very, very important. That's what the randomized trial has shown. In a patient with the heart failure patients, if you maintain sinus rhythm, the atrial kick is very, very important for the patient and heart failure patient. If you maintain the atrial kick by any means, heart failure symptoms definitely they will improve that and ejection fraction improves. So not only this, all patients we don't ablate it, some of the multiple comorbidity patient, wherein the patient AF with the uncontrolled rate when the tachycardia sets in, where we ablate the AV node, create a complete dot block and put in this conduction system pacing. So when you create a complete dot block, whatever the atrial rate, nothing gets conducted. Uncontrolled ventricular rate only causes tachycardia myopathy. We create a complete dot block, disconnect the atria from the ventricle, take over the complete rate with the ventricular pacing, with the pacing. So these patients will do very well. So you can see the bad LV, and then within 6 months after pacing, after AV node ablation, the ejection fraction comes back to normal. So you have to identify the patient who benefits the AF ablation, who benefits with AV nodal ablation based on their clinical symptoms and the risk benefit ratio. AV junction ablation definitely improves it. So in summary, as I mentioned it, first think of all the drugs on board. You should consider for all residual ejection fraction, you should consider all the drugs on board, which we discussed it. And then you look for, you should not stop. That's where we are facing the problem. Every practicing physician cardiologist, they stop with the medications. We should think beyond that. When the QRS complex is narrow, less than 130, think of ICD. When the QRS complex is more than 130, LB pattern or something, you consider CRT, CRTP or CRTD. There is a huge role of device therapy in this patient, not only maintaining the heart failure, preventing heart failure worsening, and also improve their heart failure symptoms as well as preventing sudden cardiac arrest. When they are during the course of the time, they can develop atrial flutter fibrillation and these ventricular arrhythmias, non-sustained VTs, which can further deteriorate their heart failure symptoms. When they are refractory to medical treatment, you should consider radiofrequency ablation to control the arrhythmias by by AF ablation or VT ablation or by PEC ablations. So these things will maintain their ejection fraction or help them to improve the ejection fraction to overcome the heart failure symptoms. I think, thank you very much.
Thank you, sir. Thanks for the wonderful presentation. So hope I covered the medical management and the device management within a short span, I think crystal clear, so we'll have the questions at the end of the session. Yeah. So we'll move on to the next session. So for this heart failure essentials, to go with the guidelines, the ACC and ESC guidelines, I invite Dr. P.R. Muralidharan sir, who is a professor from Ramachandra Medical College and is the C3 founder. So over to you, sir. Thank you.
Thank you. May I have the first slide? Wonderful talk by Dr. Karthikeyan. He completed my talk also. I thought I am going to talk on guidelines and he is going to talk on research advances, but he has set the floor. He has set the floor. So as I was giving talk, I thought I should get back my laptop and delete slide one by one. Then I realized better to revise. I saw a lot of students. I still remember. I still feel I'm a student, but I see a lot of students. Let us try to understand. Can I get the first slide? I have to compare. Hello. So, the need of the hour is understanding heart failure. For decades, we are talking about heart failure, reduced ejection fraction only. But day immemorial, from 1980 Davidson, we used to say heart failure is a constellation of symptoms due to inability of the heart to eject. Heart can do only at the expense of increased filling pressure. The Frank-Starling law put into stress. It is well known. Later over time, it was getting dissected into HF with revs, HF with PEF, that is preserved ejection fraction, and today we know mildly reduced ejection fraction also. To understand where do we stand? Should we offer every treatment to every patient? Or should we offer differently the type of treatment? To understand the problem, first thing, what you are seeing is 1 out of 3 patients are readmitted in India with heart failure. That's one thing. You can see 1/3 of the heart failure patients die within 1 year during the productive life years. That's the fact. So the treatment is not in devices, but rather treating or preventing something more. Because you see the in-hospital mortality, which increases as the days go, 1 month, 3 months, 1 year, 2 years, 3 years, the cumulative mortality. If someone asks me, which is a killer disease, is it malignancy? No, equally killer is heart failure. The very sad truth we all know is not only reduced ejection fraction, even preserved ejection fraction patients face the same fact. That's a big problem we see. So in India only, but 25% of patients get guided after medical therapy. That is a sad thing. Though we know we have to follow things, we learn, we add. I'll come to the criticism of guidelines a little later if time permits are doing discussion. But in India, it is being denied. But don't worry, even in US, 43%. Devices, appropriate devices is only 36%. This is a fact across the globe. But we all know when you don't follow guideline directed medical therapy, the mortality increases. Guideline directed, they live better, suboptimal, they don't do well. That is very well known. Patient who did not receive guideline directed medical therapy had higher mortality or higher morbidity. Lot of trials. For avid readers, there are so many trials, starting from placebo to AT inhibitor, then beta blocker, then came ARB and the combinations, receptor, AT, ARB, beta blocker, ART, and then came ARNI, MRA, our epiduron or sironolactone, everything. Plenty of drugs, several trials, 30 years, we have been trying everything possible. What is the result? The mortality still remains high. There are drugs are being used which have got significant reduction, as nicely shown by my friend Karthikeyan. It varies from drug to drug. The drugs sometimes shunned like beta blockers seems to be better than other drugs, but we are seeing many drugs, and RNA is the latest addition, it seems to be doing wonder, and we know our glucose makes a big difference. So this I'm going to go quickly because I covered already stage A, stage B heart failure. We know the most important thing is as I bring this thing, the arrow is only one side. That's the most important thing I want to tell my young colleagues, because at least for heart failure, if you progress to pre-heart failure, it is there. He's not going to come back. A to B, B to C, C to D. Only NYHA grading can go from 1 to 4 to 4 to 1. But here, once it happens, it happens. So treatment is prevention, early identification, correcting the risk factor. I used to tell, if you are treating diabetes very well, you are preventing heart failure. Not by putting a device or not by a series ventricle. That helps for a small number. But you help a large mass, like in the population of countries like India, you lose plenty of things. But coming to this, once you have symptomatic heart failure, what will happen? A good treatment going to make a resolution of symptoms. A good treatment. Whereas a bad treatment or inadequate or sometimes the patient is unfortunate, the disease can progress to persistent heart failure or worsening heart failure. That is the problem, and once they go to advanced heart failure, we are having very limited options, do help. Coming back for all friends here, the definition is very important. Look at the ejection fraction. Below 40, reduce the ejection fraction. Above 50, preserve the ejection fraction. 41 to 49 is a mildly reduced ejection fraction. Many times have been used, but today we have come to a conclusion that it will be mildly reduce the ejection fraction. We can call mid-range also. That is the thing. And look for objective evidence in the symptoms, like look for filling pressure elevation, how to look up we can discuss, and look for natriuretic peptides. So the diagnostic algorithm, when a patient comes, assess him well, as per the guidelines. Look at his natriuretic peptide. A natriuretic peptide even just 125 above NT-proBNP is significant. And do an echocardiogram. We do echo more than NT-proBNP because it is more much economical than NT-proBNP in our country. But once it is confirmed, what will we do? Initial classification. This I wanted to spend a little longer time because if you see here, a person with LV addition of 40 reduced, above 50 preserved, mid-range 40 to 59. But if you treat them, you can move him to preserved to reduce. You can move to mid-range to preserved or reduced, or even preserved ejection fraction can worsen. What it means? A good therapy can preserve the ventricle. A good therapy can keep the ventricular function intact for a very long time. That's the most important thing we can learn from graphs as recommended. Plenty of primary prevention, secondary prevention things have been in this. I'm not going to go into the details for want of time, but some are the important things. In stage C, that is patients who have got a stage C as overt heart failure, these are the drugs we know. You want to do beta blocker, MRA, latest SGLT2, all my friends, we don't know the diabetic drug or cardiac drug, diuretics as needed. Indiscriminate your diuretics are bad. You do this only for volume overload, and RNA seems to be a new entry which seems to working very well in the group. So that is the first thing, keep assessing the patient. What happens to ejection fraction? Is it improving or falling? And then look at all the special groups, people who are African American, not others. But I feel it may be applicable to India also to some extent. You can think of drugs like hydrogen nitrate combination. And you can think of ICD as Karthikeyan is telling, when the ejection fraction is less than 35, ICD. When the ejection fraction is with a white QRS, you can think of CRTD, shown already. But the point of importance is, watch this. Survival was more than 1 year. If a person comes with malignancy, if a person comes with end-stage interstitial lung disease, we are not going to advise them devices. You have to know that the person will survive, but for this disease, do it. Otherwise, we are going to offer an expensive treatment with its own morbidity for a very short term of a less utility. That's the most important thing we have to see. So, refractory heart failure, of course, we have several things. You can hospitalize them, you can give a mechanical respiratory support, you can think of transplantation, newer devices, everything can be tried in the group. Coming back to the economic part, quick look for our thing. You know, RNA is better than instead of ACE inhibitor. Only when ACE inhibitor is not good, you think of, I mean, RD is not feasible, you think of ARB or ACE inhibitor. We know beta blockers seem to be working very well. We know SGLT2 seems to be working very well. So there is an economic value of giving RD therapy, even more than SGLT2 is selected to reduce the ejection fraction. Same way, in patients who have got RD recommended sustained therapy in hospitalized reduced ejection fraction, and this particular group, de novo heart failure. If you have a de novo heart failure, it's going to be as bad as acute decompensated heart failure, where RD will help. And coming to the guidelines, what we said, as I told you, we know the newer drugs like RD, I know gliptin, will be soon covered. The ACE inhibitors are better, but RD is superior in most of these groups. And some of the newer drugs, as per the guidelines, point the ivabradine. 2A indication. Ivabradine 2A indication, not for mortality benefit, only for morbidity benefit. And drugs like Vestigua recently entered in India, digoxin or polyunsaturated fatty acid or potassium binder. See the recommendation, 2B only. This is just a 2B only, not a 2A. In a limited, selected thing or investigation, you can try. And the CRT recommendation has been well discussed. Point of importance is look at the EF, look at the symptom. Less bundle band block, it helps. That too wider the QRL, more than 150. But a lesser LBD, it is better. Right bundle band block, questionable. Non-specific IDC, questionable. But in a person special situation, when there is a patient hiding the heart block with LV dysfunction, you are going to make him patient dependent. Think of CRTD or other thing. And coming to the other additional device therapies, as if there is a coronary artery disease, look for surgical revascularization. When a secondary MR, look for specific treatment in a very, very small group. Selected patient, selected few, you can take offering mitral group. A very expensive treatment, just entering for limited centers. And coming to the peer pressure monitoring, get to do in a big way in our country. So when we, before going in, few points about mild disease factor. People with the EF of 41 to 49, what do you want to do? Recommended, accepted is diuretic needed. SGLT2 inhibitor 2A recommendation. All others are 2B. Want to do ARB, ACE, MRA, or evidence bit of seems to be not working in patients with mid-range or mild ejection fraction. We have to apply to preserved ejection fraction. Symptomatic, same outcome. 5-year mortality nearly 50%, but in the group, diuretic seems to be working really. Some real symptoms. SGLT inhibitor seems to be useful. All of us still 2B only. We want to evolve more and more. And to cover this, almost same thing covered by ESC. Since the topic of both ACs and ESC is a big difference, but they have covered the same thing in the slide. Nothing new in this. So at this point, you can ask me, what do then do the guidelines? What to do, how to improve it. To conclude, I used to quote one of the interesting talk I had with William Abraham, who has chaired more than 5 guidelines committee of heart failure management by ACC. I asked him one day, what is the guidelines which are 2A before has become 2B, 2B become 1, 3 becoming 2A. Guidelines keep to changing. So if my topic is guideline directed medical therapy, you want to follow guidelines, he said a beautiful word. He said, a regular clinician will follow guidelines. A regular physician will follow guidelines. A good academician will form guidelines. Only a great intellectual mind will change the guidelines. So we are here to learn and change guidelines. Thank you.
So the next speaker, Dr. Jason Gopal, is online. The journey of Dr. T.
Good evening. Good evening. Good evening, Dr. Balaji and Dr. Balaji Nandan. Let me just share my screen. I hope you can hear me. Are my slides being projected? Hello.
Yes. So, meanwhile, we will have some questions for the first two speakers. So, any questions about?
I think I cannot. When you will not introduce your army in suspected case of cardiac failure, because now they say even in acute failure you can start using.
So a few situations. One is patient intolerance, number one. Patient throughout angioedema, number two. Patient on AC inhibitor, at least for 36 hours. I do 48 hours. Of course, says 36 hours. We have to give a drug-free period of 36 hours. I do 48 hours of AC inhibitor. ARB, no problem. Now I do one trick in that. Most of my patients are ramipril. I go to Unicata. After third day, I go to RB. Simple. So I don't stop it. We do that way. That's the only thing. Extreme hypertension. We are cautious. The manufacturer recommends 50 million PD to begin with. We started 25 PD. Rarely we are starting at 1.5 80. Gradual progression. Hypertension is worried. And nowadays they are becoming more and more liberal. Even systolic people 90 to 100 people do when they are in the hospital. That's what we do.
The pattern heart failure subgroup, those who have a BP less than 100, they also get the so I think other
Yes. Now, when you will not initiate the DAPA.
Hello.
Yes.
Good evening. Yeah.
Except the hypersensitivity.
Yeah, just a bad cough.
That there is no contraindication for hypertension.
Yes, I can, and I can see you, but I projected my slides. I don't know.
Inhibitor initially or ARNI, because there are so many people not.
I did. Okay, I shared the screen. I didn't see it up there.
Your experience counselor.
It's visible. Okay.
I do use both of them, but
fine.
Patients who are got a highly resistant fraction, I always got SGLT to first.
Yes. I can hear Dr. Muralidharan talking right now. Yeah.
Off late, some amount of the commerce also plays. Glyphosate has become much more economical free to offer to most of our patients. So we tend to use when there's that question comes economy of the patient, whether he can afford. So we move to glyphosate.
Adherence also.
Adherence also better. Because many times we start early, they stop on their own. Whereas glyphosate they don't stop it on their own.
When the patient is enigmatic, we start early.
When the patient enigmatic, we are worried, sir. We do start, but usually they are hospitalization. We keep a watch at Yes. You know what is it? Oh, okay. I'm not aware. I think that is how not it.
Yes. Okay. So I think we'll have Dr. Jayashree Gopal, madam, who will be talking on the journey of vildagliptin revamp. Over to you, madam, without much delay to this.
Yeah. Good evening, and I'm sorry. I'll try and share my screen again. Yeah, I think you can see the screen.
Yes.
Yeah.
Just log off from, you are logging in 2 devices, I think so.
No. I just started sharing my screen and this happened. Let me try again. I'm only logged in on my laptop. Now, can you hear me? I hope you can hear me. I hope you can hear me now.
Yes, madam. Everything is fine.
Thank you. Thank you. I don't know what had happened. So sorry about this. I'm very sorry. I'm not there in person. Thank you to all the organizers. I came down with COVID about 2-3 days back. And so I'm just recovering at home, basically, trying not to be a super spreader. So my talk today, in the next 10 minutes or so, I'll talk quickly about the revamp of an old molecule, which is vildagliptin. The number of people with diabetes is increasing. This is a slide we are shown very often. Though what we are doing really to prevent it, I do not know, but it is estimated that by 2045, almost about 750 million people will be diagnosed with diabetes. And of these numbers worldwide, India accounts for all 1 out of every 7 adults with diabetes lives in India. And this is a study from the NNMS survey, which is the National Non-Communicable Disease Survey, Monitoring Survey, which was conducted in 2017 to 18. And it's a very interesting paper to those of you who are interested in looking at it. Between the ages of 18 to 28 years, 80% of people have normal fasting glucose. But by the time they reach an age of 50 to 70 years, only 50% of them will have a normal fasting plasma glucose. They did not do a postprandial, only a fasting plasma glucose was only done in this survey. And the numbers of people with newly detected and previously diagnosed diabetes increases with age. And with the increasing numbers worldwide, there has also been an increasing number of medications that are available. Apparently, since human insulin was approved in 1982, the FDA has approved 59 unique anti-hyperglycemic drugs. That is a lot. And all of them, and of them, 36 are categorized as new molecular entities or as monotherapies, and some of them, 23 of them, are combination therapies. The gliptins have been around for almost 80 years. We came to know about the incretins back in 1930, soon after the discovery of insulin, actually. But it took another almost 80 years for the first DPP-4 inhibitor to hit the market, because GLP-1, as we all know, is a very short-lived molecule. As soon as it is made, the half-life is only about like 3 to 5 minutes. It is broken down immediately. So they had to find a way to make the GLP-1 remain in the system for a longer period of time. The DPP-4 inhibitors have been around for about 15 years or so now. And this is a quick graphic to explain how it works, particularly for the students. Once we eat, the GI tract secretes active GLP-1 and GIP. Like I said, the half-life of this is very short. It is immediately acted upon by the DPP-4 enzyme so that it gets inactivated. But while in the time that it is active, its two main sort of actions are, it works on the beta cell and augments the insulin release that is happening because of this meal. It increases it, it further boosts it, and it acts on the alpha cell and it suppresses the glucagon. And we all know that in people with type 2 diabetes, a significant contributor to the burden of hyperglycemia is this unsuppressed hyperglucagonemia. So one of the ways in which DPP-4 inhibitors are so beneficial or helpful is the fact that they suppress this glucagon release from the alpha cells. And because of this, of course, there is an improvement in, because the insulin is increased, there's more glucose uptake in the cells. And because the glucagon is suppressed, there is reduction in the hepatic glucose output. So this is the main way that all gliptins work. Of course, vildagliptin, again, at least in India, we've been using it for quite a while. It has a very favorable safety profile. It's well tolerated. Its main advantages are that it does not increase the risk of hypoglycemia. It does not cause weight gain, and it has it's very CV safe. It does not increase the risk of hospitalization for heart failure. It does not increase a MACE risk compared to some of the other gliptins. So it is a very safe molecule, and it is effective across the disease spectrum. It can be used as monotherapy, it can be used as dual or triple therapy, it can be used even in late stage complicated disease because, again, very low risk of hypoglycemia. It can be used in newly detected diabetes also. Studies are ongoing to look at its use in pre-diabetes, but it is not approved for use in this condition. The verified trial showed very definitely that dual therapy using vildagliptin and metformin soon after diagnosis of diabetes led to good blood sugar control even 5 years after the diagnosis of diabetes, with lesser number of people who were initiated on the dual therapy needing a third agent or needing insulin to control the blood sugars. Now, glycemic control among our Indian diabetic patients remains a cause for concern. That same NNMS survey that I spoke about earlier determined the prevalence of diabetes, both newly detected and known diabetes, in the population to be about 10%. And of this, the diabetes was not under control in a large 85% of people. Only about 15% of people had their diabetes under control. Again, I have to emphasize that whether the diabetes was under control or not under control was just based on that one single fasting plasma glucose. So I'm not sure how representative this is of the general practice, but I would say for most of us, probably about 30 to 40% of our patients with diabetes have their sugars under control. 50 to 60% would not have their sugars under control. I think that's a fair estimate. And the consequences of inadequate glycemic control are, apart from the excessive risk of mortality and morbidity, increased emergency room visits or hospitalization because of hypoglycemia, higher cost of outpatient care. I think this is where the highest financial burden certainly is for people with diabetes. And of course, a high risk of developing diabetes-related complications, and then the therapy needed to manage those complications. One of the important factors that impacts glycemic control, apart from lifestyle modification and the proper choosing of medications, is the ability to adhere to medications. And one of the factors that improves this adherence is reduction in polypharmacy. Though we understand that improved medication adherence improves glycemic control, this was a study which actually proved it. They looked at people and they classified them based on their adherence level to medications as low, medium, and high. And what they showed was that when the adherence level to medication was low, good glycemic control was seen in less than 4%. 96% of them had poor glycemic control. Whereas when adherence level was high, only about 40% had poor glycemic control, 60% had good glycemic control. So definitely adherence plays an important role in glycemic control. And again, this is a study done in sort of a primary healthcare setting in India, where the study was done to measure adherence levels in anti-diabetes medications and what were the factors that are associated with adherence. And this was a questionnaire survey. They use an accepted questionnaire survey to look at medication adherence, and they classified people as being highly adherent, moderately adherent, or low adherence. The vast majority of people, 43.5% of people, came under the low adherence category. And poor compliance with medications, poor adherence was associated with unfavorable outcomes. They had poorly controlled diabetes and complications. So how can we improve adherence? Obviously, by making sure that the treatment regimen is simplified. And we can simplify the treatment regimen by making sure that the medication is given less often. For example, taking a medication before meals, after meals, taking it 3 times a day, taking it at a particular time with relationship to the meal. All this tends to become complicated. If it is a single molecule that can be taken any time of the day, once a day, adherence and thereby compliance and glycemic control is bound to improve. Again, studies have shown that for once daily dosing, the adherence rate varies from 80 to 94%, whereas for twice daily or thrice daily dosing, the adherence rate drops to 40 to 67%. So the compliance rate significantly improves with once daily dosing. And the reason to develop, for example, the vildagliptin once a day molecule was the thought that addressing medication adherence may offer the potential for improving care and outcome for people with diabetes. And once this vildagliptin extended release was developed, clinical study was conducted to assess the pharmacokinetic profile and compare the DPP-4 inhibition activity of Galvus 100 mg modified release tablet once a day versus Galvus immediate release 50 mg twice a day, the traditional molecule we've been using so far. And these are all studies which are conducted by the company, hence we are using the molecule, the proper name. If you look at the data, clinical data regarding Galvus OD, looking at the pharmacokinetic profile. So this was a study which was done in 30 healthy volunteers. In the first phase of the study, they were given either the vildagliptin 100 mg MR or the 50 mg BD. And then they had a 8 days washout period. And in the second, again, they were given 6 days of either, there was a crossover. So they were given the other molecule. And what it showed was that whether they were on the 100 mg OD or the 50 mg BD, the DPP-4 inhibition, the DPP-4 area under the curve was exactly the same between the OD molecule and the BD molecule, whether it was at day 1 or at day 6. So the mean plasma DPP-4 inhibition of vildagliptin was 91% with the modified release once a day formulation and 95% with a twice a day immediate release formulation at steady state. And again, studies have been done to show that the incidence of adverse effects and compliance and tolerability was exactly the same between the modified release and the immediate release groups, and they were equally comparable and well tolerated. And what about the what about the effect of the once a day formulation of vildagliptin in people with diabetes? Does the DPP-4 inhibition translate into good glycemic efficacy? I showed that more than 90% of the DPP-4 was inhibited at 24 hours with both formulations, and this inhibition starts within half an hour of administration. So it's very rapid acting, rapid onset of action with the prolonged duration of action. And this was a study looking at the actual glycemic efficacy, where they looked at the glucose area under the curve and what was the extent of glucose reduction immediately after administration. So between 0 to 5 hours, between 5 to 10 hours after administration, 10 to 24 hours after administration, and overall for that full 24-hour period after the administration of either the 100 mg OD or the 50 mg BD molecule. And you can see that both the groups are comparable. Whichever parameter we take, the glucose under the curve remains well within the acceptable limits, showing that both the molecules work similarly in controlling blood sugar levels. So similar reductions in blood sugar over 24 hours, suggesting that the DPP-4 inhibition has a good effect on controlling blood sugars. So to summarize, this Galvus 100 mg modified release once a day has actually paved a new way for diabetes management, and hopefully this will help to improve adherence and compliance. The once a day formulation definitely has been shown in other studies to improve compliance and adherence. And when patients are more adherent and compliant, it is associated with better glycemic efficacy, better outcomes in people with diabetes. The 100 mg OD formulation of vildagliptin has shown to have similar efficacy as compared to the Galvus 50 mg immediate release BID formulation with similar tolerability and safety profile. That was my last slide. Thank you very much. I'm just going to stop sharing in a minute. And happy to answer any questions after the next talk.
Have the questions later, madam. I'll ask Doctor. Okay, she has closed on. So I'll call upon Dr. Adeline Reena Srivadam to speak upon the dynamic duo, gliptins and gliflozins.
Thank you, sir. Thank you, sir. Thank you, the organizing team of Cardiometabolic Congress, and I thank IPCA for having me here today to talk to you on a very, very interesting combination, the dynamic duo of gliptin and gliflozins. We've been listening to gliflozins all the while now, switch gears and move from the angle onto a diabetic and metabolic angle to see how this duo really helps to manage our patients, not just with diabetes, but overall with a cardiometabolic risk. So we know that diabetes is deadly and deeply, not just in the global arena, but also in our country and population. What we need to understand is that we have close to 50% of our patients still being underdiagnosed or undiagnosed with type 2 diabetes, which probably contributes to the significant amount of cardiovascular risk that our patients are facing today. So how different are our patients? It is not just about the numbers or the fasting and postprandial plasma glucose that puts our patients under risk for these cardiovascular problems. But if you look at the phenotype of Asian Indians, we know that there are two critical components for type 2 diabetes, one being a poor insulin secretory function, and the second one being insulin resistance. We know that our patients are unfortunately blessed with a very, very high insulin resistance and a very poor beta cell function. Therefore, in combination, they tend to have more severe form of type 2 diabetes, and they are at a very high risk of developing diabetes-related complications. Now, whenever we talk about type 2 diabetes, we often talk about the fasting target, the postprandial target, the A1C target, but we fail to realize that type 2 diabetes doesn't come alone, just like how our famous movie says, single alone, the diabetes doesn't come alone. What we also see is that it most often comes along with dyslipidemia or hypertension or CKD or obesity or a cardiovascular disease. So we tend to look at the patient as a wholesome, right? In a holistic approach, rather than just looking at the fasting plasma glucose values, so that we are able to achieve the metabolic benefits and not just glycemic control. So what we also need to understand is that though we talk about the number of comorbidities that are associated with diabetes, we also should remember that type 2 diabetic patients can have asymptomatic cardiac issues, and they can have undiagnosed heart failure also. So it is not just about looking for a positive evidence, but also we need to look deep into the patient to see if the patient has an asymptomatic CVD or an undiagnosed heart failure in order to really understand the metabolic risk of our patients. So when you look at our patients, we tend to keep these patients or categorize these patients as good control, poor control, or improving control. But what I really want you to probably think in your minds is that most of our patients do fall under this entire spectrum. So when you see a patient right in front of your table, try to place them in this particular slide. So if the patients do start from here onto your left side, where patients have diabetes, hypertension, obesity, and they tend to progress along this particular cardiometabolic risk and end up succumbing to cardiovascular disease. And therefore, our primary aim is to not just achieve glycemic control, but also to retard the progression of these patients right at the beginning so that they don't progress and develop cardiometabolic disease and make our management and complications much more troublesome. So why do we really have to think about a combination of medications here? Unfortunately, we all are very familiar with the ominous octet that is contributing to the pathophysiology of type 2 diabetes. And we know that we will not be able to address all these 8 abnormalities with a single drug. So that kind of pushes us to the level where we need to think about multiple drugs that could really address these abnormalities so that we are able to offer a good diabetes and metabolic control right from the grass of type 2 diabetes. So what you see here on the left side is the DPP-4 inhibitor, and on the right side you see the SGLT2 inhibitors. Both these drugs have a very complementary action. So they do have a beta cell effect. On your left side, DPP-4 inhibitors have a direct beta cell effect. On the other hand, the SGLT2 inhibitor has an indirect beta cell effect. The DPP-4 inhibitor addresses the insulin secretory dysfunction, whereas the SGLT2 inhibitor addresses the insulin resistance, both of which are the core components of type 2 diabetes. Now, over and above this, you see that SGLT2 inhibitors increase the glucagon a bit, and when you have DPP-4 on board, that tends to put down the glucagon that goes up with the SGLT2 inhibitor. So overall, they work hand in hand, and therefore they are able to address glycemic control and, more importantly, a cardiometabolic control better. So this is what I was talking about, the ominous octet. When you have a combination of gliflosins and gliptins over and above the metformin, we are able to address 8 on 8 of all these pathophysiological abnormalities. So we don't have to address every single organ or every single abnormality with multiple drugs, whereas a combination of gliptin and gliflosin plus metformin will be able to do the job. So what really happens when you really put drugs together? So when you have just the metformin and sulfonylurea combination, which is very often or most commonly used combination for diabetes therapy, both these drugs are quite powerful. We can't really stand for the potency that glimepiride and glycoside have in terms of glycemic efficacy, but unfortunately, they have a very high risk of hypoglycemia and they come with weight gain. On the other hand, when you have a combination of DPP-4 inhibitor and metformin, we can achieve similar glycemic control without the risk of hypoglycemia. And what really happens when you have these 3 drugs on board, metformin, DPP-4, and the gliflosins on board, we are able to achieve all the benefits of glycemic control, low risk of hypoglycemia, a bit of weight reduction, blood pressure reduction, and more importantly, we are able to get some fringe benefits of cardiovascular and renal benefits. So how does this benefit really work in our patients? Because we know that our Asian Indian population is quite different from the Western counterparts. So does this drug or this molecule really work in our population? So what you see here is the glycemic efficacy of SGLT2 inhibitors and DPP-4 inhibitors, a comparison between the Asian and the Caucasian population. We find that SGLT2 inhibitors and DPP-4 inhibitors really work much better in terms of their glycemic efficacy in our population compared to the Caucasian population. This reiterates the fact that the incretin effect is much more pronounced in our population, and possibly the excessive SGLT2 mRNA expression that is seen in type 2 diabetes is also enhanced in our population. So that is probably the reason why our patients do respond much better compared to their Western counterparts. Now, we know that we don't have a very dedicated cardiovascular outcome trial for vildagliptin, but what we really need to understand from this unpublished data is that they have looked at a combination of dapagliflozin and vildagliptin for a period of 16 weeks. We have an FDA-approved combination of DAPA and SAXA, but we don't have the FDA approval for this combination because of the reason that vilda doesn't have a cardiovascular outcome trial. But we still know from the last few presentations that vilda does have a cardiovascular safety profile, though it doesn't have a dedicated CVOT. So this trial basically had 3 arms where DAPA and vildagliptin was compared against DAPA and SAXA. So DAPA 5 and vilda 100 and DAPA 10 and vilda 100, comparing with DAPA and saxagliptin. So what you see here is a very significant HbA1c reduction onto your left side and the fasting plasma glucose onto your right side. So a very, very comparable glycemic efficacy It's quite similar to the FDA-approved DAPA and SAXA combination. And not just about fasting plasma glucose, look at the postprandial reduction. We can achieve a postprandial reduction of close to 60 milligram per deciliter with this combination, and more number of patients were able to achieve the target A1C under 7%. So this is another interesting study where VILDA and DAPA were compared against each other in terms of their cardiometabolic risk. So what we can really see here is the fact we won't be able to compare head-on-head comparison between VILDA and DAPA because they belong to different categories and they have different effects on the cardiovascular system. But what we see here is a synchrony between both these drugs. The DAPA definitely has an upper hand in order to provide cardiovascular protection. VILDA may not be able to achieve that much, but is definitely cardiovascular neutral and is probably in the same direction as you can see here. And what we need to understand is also the fact that this particular study, a randomized study, did show a numerical reduction in the pro-BNP and troponin T with vildagliptin and DAPA. Of course, DAPA was more significant than VILDA, but still there was a numerical reduction in the NT-pro-BNP with vildagliptin. This is an animal study, but what I wanted to really emphasize is the fact that we often talk about the ischemia reperfusion injury. This is a rat study where they found that when there was an ischemic reperfusion injury, the moment they put these rats on dapagliflozin, it did show a very good cardiovascular reperfusion. On the other hand, when they added on vildagliptin over and above dapagliflozin, they showed that there was a highest cardiovascular reperfusion with reduction in the mitochondrial fission. So overall, what I'm trying to say is that DAPA is really a good drug, no doubt about it. But when you add VILDA along with dapagliflozin, the benefits just get exaggerated and is not blunted out. So we also know about the beta cell function improvement with vildagliptin. We know it's a secretory drug, but more beyond that is the beta cell preservation that is also seen with all gliptins, especially incretin-based therapy, and VILDA has no exception. It just calls or shows the same benefit that is shown in the entire class of drug. Now, what are the other benefits that one could achieve or probably offer to our patients when you consider the combination of gliptin and gliflozin? So we know that the genitourinary infections are slightly more in patients who are put on SGLT2 inhibitors. But though we talked about it in the randomized control trials, in clinical practice, we do come across genitourinary infections, but not to the tune that was actually seen in the randomized control trial. So what really happens when you give a combination of DPP-4 inhibitor and SGLT2 inhibitor is that the DPP-4 enzyme is expressed by the fungi and the bacteria, so that gets suppressed, and therefore the risk or the incidence of genitourinary infections were relatively less when this was used as a combination with DPP-4 inhibitor. I will just skip through the cardiovascular safety because it has already been discussed in detail, but this is just a meta-analysis which showed that vildagliptin, though we don't have a dedicated trial, did show cardiovascular safety and a reduction in cardiovascular events quite synchronous and quite similar to rest of the gliptins. And this is the VIVID trial, which also showed an improvement in the LV ejection fraction. What you see here, there was no worsening of heart failure, so we don't really have to worry about using even in patients with heart failure or who are more prone to heart failure. The cardiovascular outcome trials, we have very robust data with dapagliflozin. We have data to show that there is a reduction in the cardiovascular death, reduction in the MACE, reduction in heart failure with preserved and reduced ejection fraction. And what we really need to understand is that we see this benefit quite early the moment the drug is introduced to the patient. So overall, what I would want to emphasize is the fact that we are using both vildagliptin and the gliflozins, but when you put together in the right patient, that can yield more benefits than what we actually do. So, quick word on the guidelines. We know the ADA recommendation. We have moved beyond looking at the HbA1c and going in a very sliding scale and up titrating the anti-diabetic medications in order to achieve the target. Rather, we tend to look at the concerns of the patient, the risk of the patient, and then choose the drug. So what we need to understand is that though this left half is quite important, there are at least 40 to 50% of patients who fall on the right half as well, where you really need to consider a drug that doesn't cause hypoglycemia and probably offer some weight loss. So these are the patients who would also benefit from these kind of combinations, along with the patients who are at a higher risk of having cardiovascular disease or probably have an established cardiovascular disease. The ACE guidelines go a bit more step closer, and they say even monotherapy or initiating straight away with the combination of gliflozins and gliptins can also be done depending on the patient's preference. So lastly, I want to show you this expert opinion, which was published a few months ago, where they primarily looked at the optimum way of using this combination of gliptin and gliflozin in our Indian settings. So what this expert opinion did say is that we can consider a combination therapy of SGLT2 inhibitors and DPP4 inhibitors as an FTC when you have an A1C which is at least 1.5% above the target that you want to achieve in the given individual. Because when your target is much lesser than the current A1C, you may have to look at other possible medications that can help you achieve such a drastic reduction. Apart from that, when you really want a drug to be offered in a patient who has other comorbidities established or high cardiovascular risk factors, you can choose this kind of combination. And last but not the least is when you want to achieve glycemic control and not at the cost of hypoglycemia and weight gain, this combination does come handy in order to treat our patients with type 2 diabetes. So overall, I would like to summarize saying the complementary mechanism of action is quite important, especially in type 2 diabetes, where multiple factors and multiple pathophysiological abnormalities happen in a given individual. And when you are looking at a tighter glycemic control, when you really want to achieve a very intense glycemic control, you need to choose a drug that will help you to achieve that A1C, at the same time not cause hypoglycemia and weight gain. And last but not the least, we also need to provide or offer a drug that is cardiovascular safe, if not offer benefits or at least offer protection. So I will stop here and thank you very much for having me to be a part of this conference. Thank you.
Thank you for your excellent, elaborate speech on this subject. So now we'll request the questions from floor.
She's not there. I think one should, when they talk on the vildagliptin, should not forget to mention the verified trial. The verified trial is the one when they add to your drug naive patients. They had 5 years of sustainable glucose control and A1C. So that's one important study. And you also mentioned the safety of Vilda in cardiovascular patients. I think you must remember the trial called Vivid trial.
Yes, I talked about the
when they used it in HFrEF, you only saw the markers. But what happened to the end diastolic volume? It became more. So we have a doubt in our mind whether we can use this drug in patients with heart failure. I think you can answer that.
To answer your first part of the question, which is verified trial, I purposefully skipped it because the verified trial was mainly based on vildagliptin and metformin combination. My talk today was more focused on gliptin and gliflozin combination. But overall, the thing, what we really understand is, as I already mentioned, we have gone beyond the stepwise approach to titrate the anti-diabetic drug to achieve the control, rather give or intensify the therapy right from the beginning, especially in younger patients, so that the first 2 years of intense glycemic control has really shown a reduction in terms of microvascular and macrovascular complications later on. So that was what we learned from verified trial. Even with an A1C of 7.5 or 7.8 at the time of diagnosis, we straight away go ahead with combination therapy. The verified trial showed a combination of vilda and metformin can help to achieve a glycemic control, and not just achieving glycemic control, but also the durability of glycemic control. The secondary OHA failure was very, very less when the early combination therapy was given to these individuals who are newly and recently diagnosed type 2 diabetes.
Anything?
What? Nice talk, wonderful. One small question. Daxagliptin typically has been one of the restrictions using the heart failure patients.
Yes, sir.
But combination looks interesting. Daxagliptin with DAPA. What's your take on it?
The combination of DAPA-Saxa is not available. That is one thing for you. So I don't have a first-hand experience about that. But even in the heart failure data in Saxa-Gliptin, maybe you can add on from what I say. The selection of population was also a bit controversial, is what the reviews about the data Saxa-Gliptin says, because Even at the baseline, the NT-proBNP was slightly high for patients who were taken into that trial. So possibly that was the reason why there were more hospitalization of heart failure that happened with SAXA. But I think I'm not very sure. Maybe DAPA brings down the hospitalization for heart failure. Maybe it just neutralizes the increased risk of SAXA. I'm not very sure.
How many people are using Saxagen? Maybe use other than Saxagen.
I think even for glycemic control, we have moved away from using Saxagen.
I think if there are no questions, I thank the chairpersons. Both of them have done very good job, and all the speakers, Dr. Karthikeyan, Dr. Muralidharan, Dr. Jayasri, and Rina Asipadam. Thank you all. Now I hand over the mic to Dr. Chandrasekhar.
Good evening. I think we had a long day, like starting with the first presentation, like almost all the people were able to make it. Unfortunately, we could add some technical snag with Professor Rishmakar from New Delhi, but we had it in the hall C between 3:50 to 4:20. We had his lecture on mitochondrial modulator. With this, we have come to the end of this the first day scientific proceedings, and we may move on to the inauguration, which is going to happen between 6:30 to 7:30. So I invite all of you to join for the inauguration, followed by the dinner. Thank you, Ananda. Thank you.
Now can you hear me?
Yes, madam, you just go on.
Sorry, one more. City classes. The boarding joint. Yeah, with the physician involved. With Chandraman. So, on the next road,
அது கிளினிக்
பழைய வீடு அங்கதான் இருந்தேன் 78ல அங்கதான்
சாம்பிள்ஸ்
நீங்க இந்த சைடு இல்ல சார் நீங்க இந்த எண்ட் இல்ல சார் பஸ் ஸ்டாண்ட் அதான்
Live. Hey, running. பார் கோடு போட்டேன் அப்படி இருக்கு. நான் சரி இங்க எடுத்துட்டு எல்லாரும் ஒரு ஷார்ட் காட்டலான்னு பார்த்தேன். வந்துட்டேன். வீட்டுக்கு இருக்கா? எங்க ஒரு சரி 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 வைடா ஒரு ஷார்ட் காட்டலான்னு பார்த்தேன். கொஞ்சம் மேல வந்துட்டீங்கன்னா கரெக்டா வரும். உங்களுக்கு வரும், எனக்கு வரும். எஸ். கேமரா இருக்காது.
I think one time.
Wire length கம்மியா இருக்கு அதனால அது வரைக்கும் போயிடணும்.
Academic fees, not
people from international and national level.
This is a Congress of world-class knowledge sharing and in the speakers from all over the world.
I welcome you all for the Cardiometabolic Congress to be held on 30-31st of July at Hotel Savera in Chennai.
The Congress will help the young minds in the field of medicine.
It's going to be an academic feast where we are going to discuss more about drugs to devices, what is new, what is latest.
I welcome you all to attend the first ever International Cardiometabolic Congress.
Good evening to one and all present here. I would like to welcome you all to the Cardiometabolic Congress conference event organized by the International Society of Renal Research. It is my pleasure to give a warm welcome to all the dignitaries that we have with us today. On that note, I would like to invite Dr. S.M. Rajendran, Organizing Chairman of Cardiometabolic Congress, to come on stage and to honor his presence, a small bouquet to appreciate him. Next, I would like to invite Lieutenant Colonel Dr. Ravi Kumar, Pro VC, SRM Medical College and Hospital. Next, I would like to welcome Dr. Paraniyappan, Vice President, National API on stage, please. Next, I would like to invite Dr. K.V. Leela, the Organizing Secretary of Cardiometabolic Congress. Okay, sir. Next, I would like to invite Dr. S. Chandrasekhar, the Scientific Committee Chairman of Cardiometabolic Congress. Next, I would like to invite Mr. Rudravanu Satpathy, CEO of Technorite and Head of BioLeaks Worldwide. I would like to say a few words about the International Society for Renal Research, shortly known as ISRR. It is one of the non-profitable professional associations operating under Technorite Research and Development Association, TRADA. It is meant for research and development in the field of nephrology and diabetology since 2014. ISRR has facilitated the research work in the form of research paper publication, funding, and accreditation. ISRR aims to bring together doctors and medical practitioners to encourage intellectual development and providing opportunities for networking and scientific collaboration. I kindly request everyone to raise for the Tamil Tavarthu.
நீராறும் கடலுடுத்த நிலமடந்தை கெழிலொழுகும் சீராறும் மதனமென திகழ்வத கண்டனிதில் எக்கணமும் அதில் சிறந்த திராவிடனல் திருநாடும் தக்க சிறு திரை முதலும் தரித்தனரும் திலகமுமே அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிழமை திறம்பி என்று செய்ய மறந்து வாழ்த்துதுமே வாழ்த்துதுமே வாழ்த்துதுமே.
Thank you. Kindly be seated. May I request our esteemed Organizing Secretary, Dr. K.V. Leela ma'am, to address the gathering, please.
I welcome you to the August gathering on this special evening and wish you all a good evening. This is era of pandemics. So during this era, the whole world, globally, we are facing so many challenges besides the infections and also the metabolic disorders. The complications are noticed, unnoticed, explored, and unexplored. We are facing challenges each and every day, and each treating physician is also finding it difficult. Every one of us are having our own experiences, and new things are coming up along with the metabolic disorders. On that note, this event, which is a Cardiometabolic Congress, which is meant to share the knowledge and also to share the experiences, is need of the hour. On that note, on behalf of the core committee, core organizing committee, as well as the ISRR, I am privileged to deliver the welcome address. At the outset, I welcome the chief guest of our day, of this day, Lieutenant Colonel Dr. A. Ravikumar, who is a Pro Vice Chancellor of SRM IST and the SRM University. Sir is an ENT surgeon who has a passion for cochlear transplants. Also, sir is a member of NAC and also the DPNB, also the BIS. The standards are Bureau of Indian Standards. Sir is an academician as well as an administrator with 85 publications on his cadre. Thank you, sir, for being with us. I welcome you, sir, on this day. And I welcome all the doyens in the field of medicine who are all going to get the awards for the lifetime achievements and their contributions for this field. I welcome you all for this occasion. I welcome the delegates. I welcome the speakers of the day and also the participants. I welcome one and all for this program on behalf of ISR, ISRR, as well as my team. Thanks for this opportunity. Thank you.
Thank you, ma'am, for your warm and kind welcome. I invite the dignitaries to light the lamp and illuminate this conference with its radiance. Thank you, dignitaries. Now we move on to the felicitation address of the conference. I would like to invite Dr. S.N. Rajendran, the organizing chairman of Cardiometabolic Congress, to give the felicitation.
Good evening to everybody. Respected Chief Guest, Lieutenant Colonel Dr. G. Ravi Kumar, Pro Vice Chancellor of the SRM University, and distinguished core committee members of Cardiometabolic Congress, and dear colleagues and friends, good morning, good afternoon, and good evening. It's my great pleasure to welcome you to this Cardiometabolic Conference addressing one of the most difficult aspects of public health. Amid a flood of rapidly evolving and sometimes conflicting information, how we best communicate science with the public and policy makers during an outbreak or other health emergency. The dilemma of constantly changing and sometimes contradictory also findings and advice has often created more uncertainty, preciously at a time when people need clarity. Scientific process and decision making in an emergency context and mass communication do not fit together easily. High quality research takes time, but time is something we don't have the emergency. The conversation will be even more garbled with a deluge of false and misleading information on social media, and that makes its way into political rhetoric and traditional media reporting, or that can spread in the faith communities or at the dinner table. The importance of communication science in a trustworthy and understandable way is especially relevant in case of creating confidence. We support research to better understanding infodemics, develop clear risk communication messages, and train professionals as infodemic managers. Through partnership with the technology companies and social media platforms, we are reaching billions of people with reliable health information. Our aim is to give decision makers, media, and the public accurate information based on science to save the lives. And many people have come up with innovative ways to bring science into their everyday life. But we still need to better understand how we can support researchers, policy makers, media, and public to translate the science into effective, innovative, and reliable communication. With this conference, we want to learn from you. We want to hear from you the innovative ideas and the experience and how we can make best use of this emerging science during health emergencies. We want to understand how we can make science accessible and relevant to all so that we can navigate this and future crises using facts and evidence instead of falling for panic and the rumors. I wish you a productive discussion over the course of this conference and very much look forward continuing the conversation. And thank you very much for your kind cooperation.
Thank you, Doctor. I would like to invite Dr. K. Kannan, Advisory Committee Chairman of Cardiometabolic Congress, to address the gathering.
Good evening to dignitaries on the dais and off the dais, my teachers, friends, colleagues. It's indeed a pleasure to address the gathering on the Cardiometabolic Congress, the first of its kind organized very well here in Savera. The topics and the participation of the audience was excellent to the first day. It is very, very encouraging to see. So whenever a conference was perceived, because I was from the inception of this concept, I have been associated with the organization. And the first thing which when Rudraj approached me and asked me that we want to do a conference on a cardiometabolic topic, the first thing which really appealed to me were the person involved, Dr. Chandrasekhar. appealing to all sections, and also that we should have the topics presented here will be taken up for publication, which is what really took me into the conference. And I'm very happy to see the attendance of the delegates to the conference, because so many conferences are happening in the city. But if you see the participation, the speakers, they're all the exponents in their respective field. So that is what is very, very important, because knowledge, what you acquire in books, because newer books, they give you concrete knowledge, more conceptual knowledge. But the experience of the people who share, who present that is one thing which conferences only can provide. And a live interaction with the top people here, and any doubts, clarification which can be settled across a table or across a cup of tea, is what is the ultimate motive of the conference, knowledge sharing, knowledge developing, skill sharing, skill developing, and also to get acquainted with the latest in the field of medicine and cardiometabolic syndrome, which is the challenge to the population of India at large, because we are sharing with the real metabolic storm. And it's time that we wake up to the reality and then we work towards improving the cardiometabolic profile of our population. So I congratulate the team, and also I thank each and every delegate or faculty who have lent their time and who have benefited from the conference. Thank you once and all.
Thank you very much, Doctor. Next, I would like to invite Dr. S. Chandrasekhar, Scientific Committee Chairman of Cardiometabolic Congress, to share few words.
Respected dignitaries on the dais and off the dais, ladies and gentlemen, good evening to everyone. So I think most of you have seen in many forums like in APA, RSSDA, and our own diabetes club kind of thing. So many people, they inquired like, what is this ISRR and what is this cardiometabolic congress is about? So it's all came under one roof. That is because of Professor SMR. Professor SMR was my teacher when I was the assistant professor in Stanley Medical College, and most of us who were sitting on the stage are his students. So that's how it was all started. Almost a year ago, he called me. I think last year, June, July, he called me that Chandrasekhar, shall we do a conference kind of thing. So that time, we were in the midst of the pandemic, where we were almost bombarded with so many conferences, that is virtual kind of conferences. I was a little bit hesitant because it's entirely a new platform, new players, a new team kind of thing. So I was a bit hesitant to take up this thing. But of course, the man who is sitting on the left side, who has persuaded me, he's a very honest, meritful, good human being. So they have persuaded me and they convinced me, and so I started into this project, this cardiometabolic congress. So the one thing which when I entered, what I thought is we should give a good scientific content. So I believe in content. So the science is the winner. Though we are around 550 participants, of which 139 participants were from virtual, including people from abroad they are registered. And we had almost around 302 footfall here in during the day one conference. And what I thought is the content is the winner. So I spent a little bit time, and I think most of you would have gone through the scientific proceedings, which I took. It gives me pleasure and pain to get a draft of things that should be applicable to people who are going back and practice. So that is the aim of the thing. It should be simple and palatable and easy take home kind of thing. So this is how I have prepared. So it's entirely a new platform. You must have maybe this day, though they have conducted a lot of conferences, they are in the field for more than 7 years. They have conducted a lot of international conferences. The another thing is what is impressed upon me is the kind of the research work they have been doing, research, they felicitate young scholars, postgraduates, physician, diabetologists, and cardiologists into the kind of research work, and they do funding, they enhance the skill, research skill, they conduct regular workshop, and thereby so it's something kind of thing. What initially what this struck me is I can help my junior colleagues. So I'm in an institution where I have almost 92 PGs working under me. So that is one thing in a premier institution where I have been working. So which once I took up the charge as head of the department, one thing was a little bit, I was not so happy in my alma mater is the research work that was being done in my hospital. So what I thought is we do have some kind of symbiotic strengthening relationship with the other part of the things. Most of these people are engineers. So it's a young team, like maybe I work with the doctors, but this is the first time I work with non-medicals kind of thing. So that's a real challenge for me, and I fought with the people and motivated people, and in fact we had around almost 154 the oral, visual, and poster presentations. And still, even by 5:50, when you go to the B hall, there were around 50 PGs were presenting their papers. And we got a good set of judges, and virtually also, like it was happening in another hall. Also, we have got 3 halls. So this was the thing, and that prompted me to do something back to the postgraduates also. So what we have done is like we have collected the very important and very, pertinent to the clinical practice. So those kind of articles we have selected, and we have got a ISBN. So we all know that that is the International Serial Book Number. So that is a kind of thing. Once we got that, so these scientific proceedings of the Cardiometabolic Congress can be displayed in various international universities, libraries also. So that is the importance of getting those ISBN kind of thing. So like that, so that it's an opportunity for our PGs. So there are, if you see the scientific proceedings, which is going to be released in a short while, if you see that even from Gulf University, Manipal, there are so many people, young talented people, they need little bit of recognition. So that's how we started this, and we thought we do something, give back to the postgraduates as well by doing getting a ISBN, and it's going to be released. Now may I request our respected Chief Guest, Dr. Ravi sir, to unveil the conference proceedings. Thank you, sir. So I always I wish to reciprocate not only to my postgraduates and other things, my gurus also. So I owe it to my gurus, so the people who have taught me medicine. So we have eminent teachers sitting in the first row. They're all my teachers. They taught me medicine, the art of medicine, the science of medicine, and I owe it to them. So in fact, I started with K.S. Jnanagurubran sir, where I did my 3rd year, final year, and he's a very lucky man. So whatever the new venture I do, I try to get blessings from my professor K.S. Jnanagurubran. In fact, I gave my first invitation, wedding invitation to my teacher, KSG, like that, like a diabetes club, like when we inaugurated, so we have conducted almost more than 200 scientific meetings through diabetes club. So again, we got the blessings of Professor K. Jnanaguruburan and started it. So like that, we have so many teachers here, in 2002, it's all started. Soon after finishing my MD, in 2002, the EPICON. So I think most of you know that Association of Physicians of India conference, which was held in Rajamte and Rani Mahima. So that was the first time I was inducted into this APA forum. And Professor SK Rajan, he brought us into that kind of thing. But I got involved into this forum. That is because of the gentlemen who are sitting here in the front row. So they taught me all these kind of things. So how to, they are the people to emulate. So it's as a token of my gratitude, of course, the Scientific Committee Congress, we extend a deep appreciation to our teachers by felicitating them with a small award and a shawl. So may I begin with Professor K. Jnanaguruburan, sir?
Dr. K.S. Jnanaguruburan, one of the most respected physicians in the medical fraternity. He started his medical service in 1964. He was in the armed forces till 1970. Served at ESI Hospital from 1986 to 1987 as the medical superintendent. Between 1987 to 1997, he served as a professor of medicine at Government Stanley Medical College. Director of General Medicine at Madras Medical College 1998. Physician consultant in Apollo Hospitals 1998 to 2007. He is the gentle, noble, and astute physician. ISRR and Scientific Committee of Cardiometabolic Congress are pleased and privileged to honor Dr. K.S. Jnanaguruburan with Lifetime Achievement Award.
So may I now invite Professor Jnanaguruburan sir on stage, please.
Thank you, audience. Thank you, Dr. Chandrasekhar. It's a pleasure to be here today evening. After a long time, nearly 3 years, I am attending a conference like this. When Chandrasekhar called me some time back, 2-3 days back, sir, we are going to honor you along with your colleagues. I was very much impressed and happy and pleased with the way he called me. Professor Chandrasekhar, I knew him when he joined the medical college. I was a vice principal there in Stanley Medical College. His father came to me one day and said, sir, my son has joined medical college. So I was so happy. I told him that your son will become to a great height one day, and he is there behind me, taller than me. So, very Guru Minjana Shikshan, you see. So I'm so happy how he delivered his address
so much impressed with the way he delivered his address. So I am so happy today to see my old colleagues and one of my old army colleagues to be here as a chief guest. And I am very happy to welcome you, sir. The honor the Army AMC man has received today. I'm so happy. I'm so very much proud of you. I'm very much proud of my students and colleagues and my co-workers like Dr. Shanmuham, who was with me in 73 in I see you, and Dr. Narsingan, Lakshmanan, yes, and Lakshmanarayanan, Dr. Sivakumar. So I was telling him how his father scolded me in 1958. One day in the physiology lab, I was waiting for a chance to give him back, but he escaped. Director of medicine in Government General Hospital. We had 34 years of government service. I was very much happy. I am married to Dr. Aruna, who retired as Director of Pathology in Madras Medical College. My son, who did his MBBS in Stalin Medical College. Now he is a cardiologist in US. My daughter was an engineer. He refused to join medical college. And then he became an engineer. He is now a director in Warner Discovery Channel in US for the last 22 years. So I am happily there. And I am so much impressed by the meeting. And I once again thank Dr. Chandrasekhar and the organizers for giving me such an honor to see all of you. Thank you very much. God bless you.
Thank you, sir. Thank you, sir, your kind words. Next, may I now invite Dr. Lakshmanarayanan. So he is a very good physician. So I used to enjoy, he is my examiner, and I used to enjoy his all his one word, questions and comments, slapstick kind of comedy. So all these kind of things, like all in one man. Like we used to enjoy his lectures when he was the professor of medicine in Sri Ramchandra Medical College. So may we have Dr. Lakshmanarayanan.
Professor Dr. S. Lakshmanarayanan. He started his career as a top graduating student in general medicine at Governor Stanley Medical College, and he received a gold medal. Served as an emeritus professor at the Tamil Nadu Dr. MGR Medical University in Chennai. He previously held the positions of medical supervisor and professor of medicine at Savitha Medical College in Sriperumbudur. Served as a professor and the head of the Department of Medicine at the Sri Ramachandra Medical College in Porur and Axe Medical College. He is the recipient of Lifetime Achievement Award from Indian Medical Association, Kodambakkam in 2018. He served as patron in RSSDI Tamil Nadu chapter. Former chairman and founding member of the Southern chapter of the Diabetic Association of India and various national and international conferences. He presented numerous research articles on diabetes. ISRR and Scientific Committee of Cardiometabolic Congress are pleased and privileged to honor Professor Dr. S. Lakshmanarayanan with Lifetime Achievement Award.
Next, it's a pleasure and privilege to invite my mentor, Guru. See, the perfection means, like I would say, only one person. It's not a mere exaggeration, like he really meant for that. And he's a man of perfection. So he's my teacher. And we used to conduct the Sunday classes for me. It's a very famous thing, like Sunday usually the students they don't attend, but he is a teacher who used to conduct Sunday classes. But the entire auditorium will be full. Like we used to have around 70 to 75 people, and it will be spilling over. So the people will be standing on the side also. So that is the kind of thing. The moment he comes and stand in front of the students, and with his scandalizing voice, like he used to take classes for us, and that's a kind of thing. That's how Professor S.N. Narasimhan sir introduced to me during my undergraduate days. But once I get into the API fold, and we could see the real, genuine man of perfection. So the most of the things the youngsters we try to emulate. So in fact, like so I do this kind of exercise because it's a changing world. Like we do see because I've been a postgraduate teacher for more than 25 years. So I've seen different kind of batches. But definitely the batches which we were there during our undergraduates, we don't see nowadays. It's entirely changed. But we need to accept and adore the change. So that is the need of the other. But still, I thought like the younger people should emulate what they should do to their gurus. It's not Guru Dakshina, but kind of a thing like we should know how to respect our elders. So still I believe in the saying like Mata Pita Guru Deva. So may I now have Professor S.N. Narasimhan, my guru, on stage, please.
Dr. S.N. Narasimhan. He is the Vice Chairman of Lipid Association of India, the board member of World Hypertension League. He is the immediate past president of Indian Society of Hypertension. He is also the elected fellow of International Society of Hypertension. He is the managing director of SNN Diagnostic Center and SNN Specialties Clinic, Chennai. He has published 71 articles in prestigious medical journals and contributed chapters for the textbooks of medicine on lipid disorders, atherosclerosis, hypertension, diabetes, and cardiovascular disorders. He delivered 616 guest lectures at national level conferences and 60 at international meetings. He is the recipient of Lifetime Achievement Award from the Dr. MGR Medical University, Chennai. Received the Master Teacher Award from the Indian College of Physicians in API, India. He was honored with Distinguished Teacher Award from the GAD, Stanley Medical College and Hospital. His achievement in creating the highest clinical and academic standards in the field of medicine was recognized with an award from the World Hypertension League. ISRR and Scientific Committee of Cardiometabolic Congress are pleased and privileged to honor Dr. S.N. Narasimhan with Lifetime Achievement Award.
Good evening, everyone. Respected dignitaries on the dais, off the dais, my dear friends. Today is a friendship day. I don't consider Chandrasekhar as my student. I consider as my friend. Ever loving. And those students who passed from Stanley Medical College, the last so many years, I rendered 19 years of service as an honorary assistant professor there, and without getting a single pie from the government. That is honorary. Most of you probably may not be knowing what is honorary system. So I rendered only the service, selfless service there, because I like to teach and I like to treat poorest of the poor. So that gave me an opportunity to render my service there in Stanley Medical College. And I had opportunities to see many people like Chandrasekhar. So many people are there. Even when I went to United States, one of my students actually did not reveal that he was inviting. He was trying to put all other names, but he prevented other people not to reveal his name. When I entered into the hall, he touched my feet and told, "Sir, I was your student. I didn't want to tell you that I only invited." So that is an amount of appreciation for the services that I rendered in the past that probably prolongs my life, prolongs all your lives. I think what we did for our students will be the what I can say, the tonic for us to live for long period. And I'm really thankful to Dr. Chandrasekhar because he invited me and he has been there with me for a number of years from the Association of Physicians of India. And of course, they're all assets. Arundam and Dr. Chandrasekhar, Lakshman and Shanmugam, all those people have been with me. In fact, I am the secretary for nearly 3 decades. Nobody will believe. And will you ask that elections are conducted? Every year I put the election, but all of them try to tell me that I should hold the post for a number of years. So such an amount of love, affection these people have towards me. I think the whole, the Lifetime Achievement Award which you have given to me, honored me with a lot of praising words. I think I will dedicate it to my departed folks of my parents first, and to my family and all our friends, those who are seated here as well as that. Thank you very much.
Thank you, sir. It's a pleasure to invite Professor S.S. Lakshmanan, sir. So, sir is also from the API family, and one of the person we always admire and adore. So, I say he's a very successful person. So, whatever the field you want to wish to pursue, like you can get any tips from Professor S.S. L, sir. And he's a good clinician. So every time when he comes, and today I missed his panel discussion, but every time when he stand in the stage, we used to admire and emulate, try to emulate him. So that's a kind of clinical acumen. It's very difficult to update every time. So in this, despite his busy practice, so that is one of the biggest qualities which we have seen him with Professor S.S. Lakshmanan, sir. May we have video for Professor S.S.
Dr. S.S. Lakshman. He is the managing director of Priya Nursing Home at Chennai. He works as a visiting consultant at Akash Hospital in Chennai. He has written chapters in various textbooks and published 30 articles in major medical journals during his academic career, including JAPI. He has delivered 241 invited lectures at conferences on a national level and 28 at meetings internationally. For his teaching abilities at API's Postgraduate Forum, he has received the Master Teachers Award in 2003. In 2012, the Tamil Nadu Dr. MGR Medical University presented a Lifetime Achievement Award. He has delivered PJ Mehta Oration Award in 2014 by API and Indian College of Physicians. He is regarded as one of the best clinicians in interactive teaching. ISRR Scientific Committee of Cardiometabolic Congress are pleased and privileged to honor Dr. S.S. Lakshman with Lifetime Achievement Award.
Thank you, Dr. Chandrasekhar. I don't know whether I deserve this or not. When you called me and said, you are going to get a Lifetime Achievement Award, the first person I contacted was Shanmugam. Shanmugam, I thought I'm still young. Then he said, don't worry, one day or other you have to get older. I finished my MD in 78. I've never been even one day in a government service. So I don't know why he called me professor, not even one day. They posted me in Thrombolytic headquarters hospital. I went there, looked at the place and returned. I said, I'm not joining service. So my practice was very successful. 1988, I became the top of the world. One day, Narsingan called me. You are a gold medalist in MD General Medicine. You are just doing a practice like a general practitioner. You please come to the APA forum. There we started the journey. So the updating and then teaching the postgraduates and then sharing the knowledge. I'm actually popular for the case presentations. I always tickle the audience with the case presentations. I think I always admire that it is given to me by Dr. SNN. Thank you, Dr. SNN. My wife said, நிறைய சம்பாதிச்சிருக்கலாம் இந்த ஆள் உள்ள வந்து உன்னை கெடுத்து ஏபி கூட்டு போயிட்டாரு அப்படின்னு சொல்லுவாங்க. But one day we were in lifestyle in the LA. What do you call that? No. EA. Suddenly two students came and touched my feet. Sir, we heard your lectures in the railway hospital. I still remember the cases you have presented. Then my wife said, okay, you got some contact with the people and things like that. I think, thank you very much. Keep fit. That's my motto. Keep young in mind as well as in your body. I think medicine is always changing. You keep updating every time you're updating. So we have a journal club which I've been running for the past 22 years. From 2001 we started. Now every week, every month, every third Wednesday we have a journal club. That's how we update our knowledge. Thank you, dear friends, and thank you all people in the dais for the excellent thing. So one need not be in a government service to conquer knowledge. We can do it by ourselves. Thank you very much.
Thank you, sir. So it's again, it's my pleasure to invite Dr. K. Shanmugam. So sir is a senior most consultant physician, like one of the person who is most respected by everyone. So usually when we have someone who is elder, like we may have some inhibition kind of thing, but definitely not with Dr. K. Shanmugam. So most of the people who are standing on my right and left, all the young people, sir used to call them by name, and he doesn't, he just, first thing he make the younger generation to shed their inhibition, and he used to teach everyone on the nuances and the intricacies of whatever the thing they are involved. So that is one of the thing. So we used to call him as Engloda Manasachi. So in APA, like, so it's my pleasure to honor Dr. K. Shanmugam.
Dr. K. Shanmugam. He is a senior consultant physician at Sir Ivan Stedford Hospital in Chennai. He is currently Chennai's chapter chairman for API. He served as key leader of API's Tamil Nadu state chapter. As an invited speaker, panelist, and chairperson, he has taken part in various national and international conferences. In a number of professional bodies, he has written chapters for reputed medical textbooks. He is the chief coordinator for the annual All India Intensive Postgraduate Teaching Program under the Chennai chapter API. ISRR and Scientific Committee of Cardiometabolic Congress are pleased and privileged to honor Dr. K. Shanmugam with Lifetime Achievement Award.
I don't know what to see. There are so many people who are very much interested in science and publications, but I did very little in that. What I want to tell the youngsters, we already told Mata, Pita, Guru, Devam. Tamil ரொம்ப அழகா இருக்கு. ரெண்டு ஆ அம்மா அப்பா ஆசிரியர் ஆண்டவர். இதை மதிச்சு நடந்தா ஓரளவுக்கு வாழ்க்கை கொஞ்சம் நல்லா போயிட்டு இருக்கும். That is one thing. Don't forget, because you are knowledgeable, you are the greatest person in the world. What is more important, being a human being. That is most very, very important, especially at this juncture of the world, where you got chaos and everything. This is for in general. But to say, Chandru, I think first we come to know only in 2002, as is told, in this Epicon. Dr. S.K. Rajan and Dr. Chandrasekhar introduced us as a team. Then we morning yesterday we came, hall was not ready. So we reminded of those things, 9 o'clock we have to start the Epicon conference. 6:30 or 7 o'clock we went there, in the stage. We have to know the background problems of organizing an conference. That is most important. We can comment on anything, but if you work, you will know that how difficult to conduct a conference, and especially a successful conference. And he has done it many times. Therefore, congratulations to Dr. Chandru, and also for the organizers who gave this opportunity. My journey in my life is, I will briefly tell, because Mata, Pita. I was little, only from a lower middle class family came. Therefore, don't forget your parents, that is most important. But we have to work hard. When we work hard, Stanley, I think Dr. Jnanagodabani told me, was a nice you. Then after that, we did MD. After the MD, a lot of services came, just like Lakshmanan got services. At that time, we didn't join the service. But I joined that charity hospital, sir. I once said for nearly more than 35 years, I am working there. It's not a very financially sound, but still we are able to serve the poor. That is most important. And because of this association, you can see that Dr. Narasimhan, Dr. Lakshmanan, Dr. Chandru, Parandaman, Prabhu, we got a team of work going on to teach the students, youngsters, and also the general practitioner and physicians. In that way, we are very happy. But happiness comes once you enjoy the job, whatever you take. It may be teacher job or any other job, but you should get involved in that. And the family also is very, very important. It's not only one person, the family background is very, very important. Therefore, as he said, nursing and told, my family. Then the guru. I got lot of gurus, not single person, lot of gurus. So most of the things, we learn from the patient as well as the teachers also. Very fortunate in those days, very good teachers we had. Therefore, the junior should come up like we should also become a good teacher. That is most important. And I don't want to go into the other aspect. Thank you for the opportunities, and work hard, be honest, serve the poor. That is most important. Thank you.
Thank you, sir. In fact, sir has taught us the strength and the importance of teamwork. So always. So next, it's a pleasure to invite Professor S. Shivakumar, sir. So I happen to have the attendance with Professor S. Shivakumar, sir, as a postgraduate during my MD post-graduation in 1998. The sir is very simple, calm, and cool. He doesn't react much,
but he is a man of principles. He lived by his principles, and he has got its own the flavor kind of thing. So he taught us the importance of research. So in fact, like he was one of the pioneer researcher in leptospirosis, and he has got immense the interest in the field of the AKA kidney diseases, AKA and CKD kind of thing. So he is a person who has given the, so if you happen to talk to him for 10 minutes, the 11th minute he will ask like what are the research project you have planned. So you will give some kind of inputs into that. So that's a kind of very rare to see such a man with a vision. So that is more important. So it's our privilege to honor you, sir, today, Dr. Shivakumar.
Dr. S. Shiva Kumar. He served as a member of the International Advisory Panel for the Kumar and Clark Textbook of Medicine's Clinical Medicine, 6th and 7th editions. His articles have been published in national journals such as the Indian Journal of Medical Microbiology, the Journal of Postgraduate Medicine, and the Journal of Association of Physicians of India, among others. At national and international conferences, he has delivered numerous papers. The City Physicians Association honored him with the Eminent Teacher Award in 2001 for his remarkable commitment to advancing the field of medical education. During its 11th anniversary celebrations on June 28, 2009, the City Physicians Association in Chennai presented a fellowship award for the distinguished service. On July 1, 2011, the Tamil Nadu Dr. MGR Medical University in Chennai presented him with a Lifetime Achievement Award in appreciation for the distinguished commitment to the cause of medical education and healthcare services. For its Platinum Jubilee 2013 festivities, Stanley Medical College in Chennai gave Dean's Appreciation Certificate in recognition of his selfless devotion to humanity and contributions to the medical community. He teaches general medicine to medical students and works as the honorary consulting physician at the Railway Hospital in Perambur, Chennai. He has been the medical director at the Madras Institute of Magnetobiology in Anantnagar, Chennai, since March 2014. ISRR and Scientific Committee of Cardiometabolic Congress are pleased and privileged to honor Dr. S. Shiva Kumar with Lifetime Achievement Award.
I must personally thank Dr. Chandrasekhar for having invited me to this conference. I have attended many conferences, but the cardiometabolic conference which Dr. Chandrasekhar organized has been unique in many ways. But I will only emphasize on one point, that this part, the felicitation of eminent physicians from Chennai, was a very wonderful gesture. He has taken the most senior person, Mr. Gyana Gurupuran, who was the director of medicine. It was very nice of him. We have other people like Dr. Chitrambalam and the trio of API, whom I consider for so many years who have done an outstanding one. Dr. Narasingan, Dr. Lakshmanan, and Dr. Shanmugam always did a wonderful job for API conferences. So it was a wonderful thing that he organized in a very great way. Dr. Chandrasekhar I had known from my postgraduate days. I have been very impressed with the way he has progressed so far. One, the way he conducted and has become part of the national API also. So I hope that over a period of time you will reach to much greater heights And this wonderful way of organizing this conference has really made me extremely happy. I wish him good luck in all his future endeavors. And it was very nice that I had met my old friends, Dr. Kannan, Dr. Leela, Dr. S.M. Rajendran, and Dr. Palniyappan. And therefore, it is a matter of great pride for me to be part of this function. Thank you.
Thank you, sir. So I think it's next we'll invite Professor M.D. Selvam, sir. So Selvam sir is so I think all of you know him. He's a very simple and honest man. And in fact, after finishing my MBBS, I didn't have much clue what to pursue after my this thing. But I wrote the exam, and when I got a good rank, so I didn't go for any other option. I just to try to emulate my teacher, Professor M.D. Selvam sir, because the way he nourishes the postgraduates, both undergraduates and the postgraduates, was phenomenal. And we used to love to listen to his lectures and other things. So he used to take classes in a side room in the medicine ward, in the evenings. So he's such a very nice, wonderful human being, rather a good soul. So it's my privilege to honor you, sir. So Professor M.D. Selvam, sir.
Dr. M.D. Selvam. He is a well-known senior physician in Tamil Nadu. Graduated in 1978 and completed his post-graduation studies in 1981 at Stanley Medical College. In 1985, he then began working for the government in the Tamil Nadu Medical Service. Served as Professor of Medicine at Stanley Medical College and retired as head of the Department of Medicine at Kilpak Medical College, Chennai. He is serving as a professor at Muthu Kumaran Medical College and Hospital in Chennai at the moment. He has contributed to 3 chapters in the 24th edition of Hutchison's Clinical Methods on CVS, GI, and Women Health. He is the prestigious member of the 24th International Editions Advisory Board for Hutchison's Clinical Methods. ISRR and Scientific Committee of Cardiometabolic Congress are pleased and privileged to honor Dr. M.D. Selvam with Lifetime Achievement Award.
Good evening, everybody. Still very nice program. We never expected that we will be getting a lifetime achievement. Already in Stanley Medical College, I had twice same Dr. Chandrasekhar has given us Best Teachers Award and another one Lifetime Achievement Award also. Now third, I am getting it through Dr. Chandrasekhar. I thank everybody. Good night.
Thank you, sir. So next, it's my duty to invite Professor P. Chitrambalam, sir. So Professor P. Chitrambalam, sir, is known for his vocabulary and is known for his oratorial skills. So I used to inspire from his talks and its clinical discussions, particularly in cardiovascular disease. So I was thrilled to see his the clinical acumen, and particularly in ECGs, sorting out some of the difficult ECGs, which he used to discuss with the postgraduates. I was his assistant professor then. I used to amaze the wealth of knowledge he has with particularly in cardiovascular. He's a very good clinician and very good successful human being. So it's our privilege to honor you, sir.
Dr. P. Chitrambalam. From Madras University examinations, he was awarded gold medals in medicine in 1979. Recipient of Doctor's Day Award by IMA, Perambalur. Recipient of Best Professor Award by Trichy IMA. Recipient of Lifetime Achievement Award by Lions Club International. District 324A6, 2012-2013. Recipient of Lifetime Achievement Award by Tamil Nadu Dr. MGR Medical University, Gov of Tamil Nadu 2014. Recipient of Lifetime Achievement Award by Lions Club 2016. He has written books for medical professionals, including Medicine for Paramedics, for Emergency Technicians, 2004. He has written Ready Reckoner for postgraduates and house surgeons on emergency medicine. He has also contributed to Savitha Medical College's Bedside Clinical Reckoner in 2015. ISRR and Scientific Committee of Cardiometabolic Congress are pleased and privileged to honor Dr. P. Chitrambalam with Lifetime Achievement Award.
Respected chief guest, dignitaries on the dais, off the dais, my senior colleagues, friends, ladies and gentlemen. For me, it is a double award. One is what they gave, the other is award which I was enjoying because all those people who got before me are my seniors, are my teachers, my professor also, where many a times we dare to sit in front of them also. Now I am able to sit next to them. So in such a way, I am doubly happy today. See, I fully endorse the view of my previous speakers where they said, you have to recognize and reciprocate to your teachers. See, that is a very good virtue. Whatever heights we may achieve in our life, we have to remember our parents, our teachers. So in such a way, Dr. Chandrasekhar has developed a very good virtue, and I request all the postgraduates to emulate from Dr. Chandrasekhar and give him as a role model where, see, he has recognized people who have developed, who have contributed, who have been role models, who have given you all virtues. Similarly, everyone must develop like that. So the credit for whatever I have achieved in my life not only goes to my parents, but also to my family, my wife and children who are very cooperative all these years, whenever I want to spend time for academics. I thank the organizers, especially Dr. Chandrasekhar, for recognizing me for this situation. Thank you.
Thank you, sir. Next, it's my privilege to introduce and invite Professor Dr. V. Satyanarayana. So we all know that the doctor has to play multiple roles, as a teacher, as a doctor, and also he has to do something to the society. So being in a government service, many times I would think that we are doing something good for the poor people. So that's how I thinking of. But the thing is the thought process, how a doctor should help a poor and how they should have some kind of motivation. So all these things I have learned from Dr. V. Satyanarayana. So I think Dr. V. Satyanarayana is unique among us. So I think if you go through his the credentials, we all will appreciate why he is being chosen for this prestigious award. Dr. V. Satyanarayana.
Dr. versus Satyanarayana, known as the Doctor for the Poor in his town of Kanchipuram, Tamil Nadu. He charges very nominal fees and poor people and physically challenged people are exempted from paying fees. Conferred the prestigious Kalaimamani Award, the highest state honor award of the government of Tamil Nadu by the Honorable Chief Minister in 2019. achieved 7 Guinness World Record certificates for various awareness programs on health and diabetes. He is the first doctor in the world to have got 7 Guinness World Records for awareness program in health. Awarded the Abdul Kalam Siva Ratna Award in 2017 and the Best Doctor Award by the World Tamil Chamber of Commerce in 2018. Awarded certificates from the Limca Book of Records, India Book of Records, Tamil Nadu Book of Records, Asia Book of Records and the World Record Association Certificate, the Lai Nimartha Tamilan Award, Sadhanai Tamilan Award, Bharat Jyoti Award, Mother Teresa Award and Best Citizen Award for contributions in this field. ISRR and Scientific Committee of Cardiometabolic Congress are pleased and privileged to honor Dr. versus Satyanarayanan with Lifetime Achievement Award.
Good evening, everybody. Respected chief guest and dignitaries on the dais and off the dais. It's a great privilege to get this award. And today being a Friendship Day, I'm so happy to see my dear friend Dr. Chandrasekhar, who has scaled a greater height and is an example and is a role model for all the students and postgraduates. I'm so happy that he has attained such a higher level. And I dedicate this award to my parents and my inspiration, Dr. Kalam, who in fact changed my life. And when I met him for the first time, he told me, "Sir, ஏழைகளுக்கு ஏதாவது செய்யுங்க சார், ஏதாவது கேம்ப் பண்ணுங்க சார், என்ன சார்?" I was very shocked. So such a great person calling me sir, and such a small doctor, and I was so impressed. And I was involved with Dr. Kalam in the Pura project, that is known as providing urban facilities for rural areas, where we organized a lot of medical camps. And we organized, in fact, more than 500 free medical camps. And he gave me the inspiration to create awareness among school students, colleges, whom he used to tell they are the pillars of future India. So I dedicate this award to the great person. And my sincere thanks to all the organizers for considering me for this award. Thank you, everyone.
Next, I would like to invite Dr. Paraniyappan, Vice President, National API, to give us a speech. I would like to invite Mr. Rudrabana Satpathy to give a memento to our special guest.
Good evening, ladies and gentlemen. Thank you very much, my dear friend, Dr. Chandrasekhar, and conference organized by International Society for Renal Research, and Chief guest, Dr. Ravi Kumar sir, Pro Vice Chancellor of SRM Medical College Hospital, and organizing team, Dr. Leela, Dr. Chandrasekhar, Dr. Kannan, Dr. Vinod Kumar, and Dr. Esam Rajendran sir, organizing chairman, and my dear teacher and API mentors, Dr. S.N. Narsingan sir, Dr. S.S. Lakshmanan sir, and Dr. Sanmugam sir, and all the off the dais and on the dais. As a Vice President of National API, I am really admiring of this conference, Cardio-Metabolic Congress. We used to have a Cardio-Diabetic Congress. So Cardio-Metabolic Congress here, not only cardiology, Metabolic Congress includes all diabetology, lipidology, obesity, metabolic syndrome mix, and nephrology, everything. So this is the leading cause of death, morbidity, and mortality in our area. If you address properly Cardio-Metabolic Congress, our longevity will improve from 74 years to 85 years. That's our aim. Dr. Chandrasekhar is my close friend, and we are in the national API as well as Tamil Nadu API. We are taking in a good height with the blessings of our senior mentors in Tamil Nadu API. And really I have admired his scientific core. It has been included not only general medicine, diabetology, cardiology, nephrology, and lipidology, lot of topics which were in detail discussed, and lot of question and answer and case discussion by Dr. S.S. Lakshmanan sir, and many more topics which were well deliberated. Scientific content is really a topmost part of this conference, along with Dr. Kannan, my dear friend, cardiologist. Here nowadays we are lacking. This is a time to do the lot of research work. We are doing nationally as well as Tamil Nadu wise APA. We are doing lot of research work under the name of Physician Research Foundation. Now the time is experience to evidence. Lot of publication has to come out in our journals, and research up to dating the knowledge, and it's in the scientific content is very much useful for the practicing physician. Chennappan sir used to say, in a conference attend பண்ணவனே நாளைக்கு ஒரு prescription எழுதணும். அந்த மாதிரி knowledge you have to gather. So nowadays up-to-date knowledge is very, very important to practice. We are practicing in the litigation era. So we have to be up-to-date to avoid lot of litigations, because lot of patients, they are searching from the net and asking lot of questions. You have to be answered everything, each and everything. ICRR should go to the greater height. So this is a first conference. It should go in a greater height. My dear friend, Dr. Chandrasekhar Kannan, they are working very hard. It should go, my heartiest congratulations. They should take to a higher level. Complete physician. Nowadays, the complete physician knowledge is lacking. I am practicing in a rural area in my native place. Just now it has become a taluk headquarters. After completing my MD General Medicine Coimbatore Medical College with a medal, I have started my practice for 6 years. After that, I have joined with the blessing of Dr. S.N. Narsingan and Dr. S.S. Lakshmanan sir. I entered in 2008 in Tamil Nadu APA. Now I am the Vice President of National APA at 50 years. So I am doing a lot of research work like S.S. Lakshmanan sir, not only doing a practice, I am proud to say a complete doctor after completing MD General Medicine, diploma in echo, diploma in diabetology, emergency medicine, CMC Vellore, endoscopy, everything. You have to know. So as a complete physician, you should know. Actually, my professor Dr. A.R. Vijay Kumar used to say, if you are a complete physician, you should have a knowledge of 75% of knowledge of the super specialty, cardiology, neurology, nephrology, in emergency medicine, everything. Then only he can practice safely. After completing MD, if you are not up to dating all the super specialty, it is inadequate. He cannot complete. He cannot treat. You have to refer to all the other specialties. So in the periphery, it is very much useful to treat as a complete physician. Nowadays, previously in SNN, SSL eras and all, if you know syphilis, you know medicine. Now, if you know diabetes, you know medicine. So not only physicians, surgeons, orthopedicians, gynecologists, everybody should know the knowledge to treat diabetes mellitus. Because even topmost cardiologists, topmost nephrologists, they are having inadequate knowledge to treat diabetes. That is one of the important cause of cardiovascular mortality and morbidity. So everybody should know the up-to-date knowledge of the diabetes. And when I finished my MD, 1999, lipidology, it's inadequately taught. Lipidology, only atherosclerosis. Nowadays, we know lot of trials, lot of things. Nowadays, the topmost important thing in the heart attack reason is Cessation and smoking. After that, lipids, dyslipidemia. All the persons you should know. The LDL goal is less than 30. Previously 100, 70, 50, now less than 30. And lot of emerging drug, up-to-date knowledge is required to practice in the litigation era. And lot of more than 300 PG students they have gathered, and lot of encouraging medals were distributed for the postgraduate students. So the association, this ISRR should have the younger generation, middle-aged group, and elders. All three groups are there, means definitely it will grow in a greater height, and all the physicians should be up to date. They have to present lot of papers, not only studying, you have to present lot of papers, research work you have to do lot of researches for the benefit of our Indian nation and be up to date, and to prevent the morbidity and mortality, to increase the longevity of the Indian population. Thank you very much for the patiently listening. Thank you very much.
So we are all eager to listen to our chief guest, the presidential address. So before that, we would like to remember and appreciate the efforts which we have got from some of the universities, like Gulf Medical Universities, some of the academic forums, associations, all these kind of things. So we, in order to honor them, so I would like to call Professor Sundaram sir to receive the memento from our chief guest. Please, sir. Next, I invite our diabetes club team, like Professor A. Narajan sir, and Dr. U.V. Mohan, Dr. Jaykumar, and Dr. Vetrivel on stage, please. So please come to receive the honor.
I cordially invite our Honorable Chief Guest, Lieutenant Colonel Dr. Ravi Kumar Sir, Pro Vice Chancellor, SRM Medical College and Hospital, to give the presidential address. I request Dr. Chandrasekhar Sir to give the memento to the Chief Guest.
Good evening to one and all. I think we had a very interesting and very enjoyable time. Dignitaries on the dais, especially the organizing chairman, Dr. Chandrasekhar and Dr. Leela, secretary, doyens in the field of medicine, on stage and off stage. I've seen some really touching moments where the student is honoring his teachers after many years of being a student and then now being a teacher himself. He realizes the importance of teaching. I'm indeed honored to be here this evening, and thanks very much for asking me to be chief guest, especially to Dr. Rudra. When he came upon this idea and talked a few months ago, I, first of all, did not understand why I am being called. I said, what is the connection between cardiology, metabolic disorders? Then now I understood. At last we are coming to understand what this disease is all about. Cardiology was always a scary subject to me because nobody knew what caused the problem. They're firing shots in the darkness, trying to blame whether it is lipids, exercise, obesity, smoking. All of us know how many heavy smokers also get away. Non-smokers also get heart disease. So all these are the little too confusing to me. So I took up on the easy specialty of ENT and landed up in much more difficulty when I started learning the anatomy and went out to the inner ear and tried to discover some things there. So what I'm trying to hint at, nothing is easy. But once you start investigating and try to delve into the depths of knowledge, start studying more and more, discussing more and more, you come to know that, as they say in Tamil, so the more you study, you realize how little you know. But it's a journey. And in that aspect, I'm really very happy to see that this Congress is uniting many people who think similarly. I've seen here academically sound, extremely professional people. I've seen here a lot of emotion, devotion. I've seen here dedication to duty, people who have worked in the periphery, in the rural areas. I've served 5 years in Kashmir in all the God-forsaken places, including Bangalore. And I know what it is to be in such areas when you wait for your next meal, and that will be something which is very cold in a place where it's already -30. So anyway, it's an experience which is worth sharing. But what touched my heart really today is the dedication of a student to the teacher. That prompted me to put up this picture. They took off the internet. Many of you would have heard about this particular ritual which is done during Krishna Jayanti in Maharashtra. I did my master's in AFMC Pune. So I have been through all this. It's called Dahi Handi. And here you see one single fellow climbing up on the shoulders of so many people, going and breaking that pot, taking out the whatever is there inside. But then what it demonstrates is when we stand tall, we are standing on the shoulders of our teachers, of our mentors, of our seniors who have shaped our future. As recently as 10 days ago, I think about a week ago, I was in Pune, my alma mater was there. And I had lost my dear teacher. He was a teacher who used to study with us. I had to go to his home in the evening. 2-3 hours would sit and discuss the cases of the day. And when he passed away, I could not. So the first thing I did, I was on an official trip as a MAC assessor to Symbiosis Institute. I first went to his home, paid my respects to the departed soul. And I found that the garland which I had sent from Chennai was on the photograph. And his wife said, "You are a very devoted student, and I want to show everybody that the devotion you show is rare." I said, "No, it's something which happens every now and then. It depends on the teacher and the student. The relationship is very special." And this gentleman, even when he departed, he donated his body to the college for scientific purposes. And he was a student of All India Institute of Medical Sciences and wonderful person. So I saw a similar devotion there today, with Dr. Chandrasekhar honoring so many of his teachers. Very nice. And when you start showing this to your students, it sort of percolates down. Let's not forget, we are all born, may not qualify to be called equal, but when we shape our future, we need those props every now and then. And those props are first your parents, then your mentors, meaning the teachers, and you get the right teacher at the right time, your life changes. And that's what happened to me, and you heard it from many of my previous speakers. And I think every one of us is blessed to have such human beings in our lives. The only problem is we should recognize who they are and take their advice and follow their advice. That's my message. And this interdisciplinary congress which is going on, it will definitely help in the advancement of knowledge. Today, research is slowly getting focused into, number one, collaborative research. No more saying that I am MD General Medicine as the only medical research. You have to associate with somebody else in another faculty. Just because I am an ENT surgeon, I should not be thinking of only surgery. I should collaborate with an audiologist. That's what we learned in cochlear implantation. Biomedical engineering, biotechnology, everything is interdisciplinary. Second, research should be translational. We all have a finite time in this world. And then what you do today should be of some use or should translate into improvement in the quality of life within your lifetime. If that happens, it's got more regulation. In India, we finally have realized that translational research and inter-research is the way to go forward. So here we have a chance of actually doing both. So I think you have begun well, and SRM University, actually SRM Institute of Science and Technology, I've just come back from the Board of Management's meeting, where we were told that in terms of research, 10 ranks in the NARF. In terms of university, we are in 10 ranks. In terms of engineering, university 11 ranks, and engineering 10 ranks. Medicine, the call is so tough, the competition is so tough. We retained our rank, but we improved our score. What I'm trying to integrate, when you have a university setup, and you have, for the government institution, you have Anna University Institute. I collaborate with Anna University to develop a noise cancellation system and protect hearing in individuals who are exposed to loud noise. A lot of choices are there. Only you have to think, and your teachers and mentors will guide you to where you have to go. Please think and do something. We Indians do extremely well when we go abroad because they allow you to think and do something. Here you get restricted. But here you have an example of teachers who have actually mentored a good potential teacher, that is Dr. Chandrasekhar. Once again, thanks a lot for calling us. And in the SRL, to talk in 2 sentences, we are into collaborative research because we have under my faculty, that is Faculty of Medical Health Sciences, 7 colleges: medical, dental, pharmacy, occupational therapy, physiotherapy, public health, and nursing. So we encourage interdisciplinary, intra-faculty and inter-faculty research also. And the ranking is based, heavily weighted on research. India can definitely do a lot better than what we are doing now. With that note, I thank the organizers and all of you for the patient here. All the best.
Sorry for we are going to have a quick rehearsal. So may I invite Professor Sundaram sir, please. Sir, please. Dr. Shanmugam sir. Dr. Naraj sir.
To deliver the vote of thanks.
A very good evening, everyone. Well, it's a very tough time for me to express the vote of thanks to a team of diverse profession, diversified institutions, and diversified communities with a huge involvement of multiple hours, multiple days, and multiple guidance, multiple experience, and precising them and rendering a vote of thanks in only 2 minutes of time that has been allocated to me. Esteemed dignitaries, revered speakers, honorable chief guest, our most respected, the special guest of this evening, respected organizing committee members, faculties, chairpersons, judges, delegates, and participants from nook and corner of Tamil Nadu and different parts of India. I express my hearty gratitude to everyone for your participations, valuable time, and immense faith and trust and contributions of scientific articles and presentation in form of orals and posters that has created the value of this conference. When we look into the statistics, the numbers, what we see, are of great concern. India, our country, is the second largest diabetic affected country after China and globe. Last year, we came across around 70 lakhs deaths because of diabetes, hypertension, dyslipidemia, and other diseases. The major point to think about is that today in our country, out of every 11 individual, one individual is diagnosed with diabetes or related diseases. It's another dramatic number we come across. Out of every 6 diabetes affected patients from world, there is one Indian. We are the second largest populated country, the largest democracy. We are the 4th largest contributors of medical articles and citation in world. But numbers are of big concern. We belong to a unit of Techno-Elite Research and Development Association that believes in inculcation and promulgation of knowledge, thought processes, and globalization of innovation is the ultimatum and requirement of academics. Since 2014, we have been connected with different disciplines, different sectors, different professionals. And as technocrat, we are in a verge of rapidly integrating technology, of creating virtual community, virtual environment for rapid, faster, convenient, and accessible interaction of scientific knowledges. We believe knowledge do not have any barrier, and knowledge should be implemented in interdisciplinary sector. Globalization of innovation beyond the limits is the most important aspect, and this is the reason today we have collaborated with almost all leading universities all across the globe. And we search for minds, research, innovations, ideas, thought processes that could be diverted towards our development of the nation. This experience of conference was in fact a great opportunity of learning, because we have many thought-provoking keynote speakers, panel discussions, presentations that has some provision of publication in some highly cited journals, indexed in Scopus or Web of Science, PubMed and SCI. Soon after the conference, our publication team will be communicating for reception of abstracts and articles and submissions for their publication. And our editorial team is committed to do that. I express my hearty gratitude to all organizing committee members, all academic partners, industrial partners, everyone for your valuable contribution. Because scientific communities and scientific association believes in working with togetherness. So it's not about togetherness of individuals. It's not about the togetherness of institutions. We believe in building world's largest scientific community in upcoming decade that will have all professionals, all expertise of different dimensions integrated in their particular domain, in their particular interests, with better ease, access, and convenience. I believe this conference will be a fruitful event because every minute, every second of your time in this conference costs a lot for us. It's extremely valuable, in fact, you know why? Because these 2 days are because of almost 12 months of effort of so many people, relentless work, sleepless nights, and extreme dedication of unlimited. So these 2 days is directly proportional of efforts of months and weeks and days of many people behind. I express my hearty appreciation to all my colleagues, my gratitude to Chandrasekhar sir also, because of the content he brought, because of the speakers. The most important thing we all learned in this evening is Guru Brahma, Guru Vishnu, Guru Deva, Maheshwara, Guru Sakshat, Param Brahma, Tasmai Shri Gurave Namah. That says about the traditions, the customs, the thought process of Sanatana Dharma we keep, that brings and reverberates in our mind how Ekalavya attributed its thumb in terms of Guru Dakshina. I believe the message of this word of thanks will reach the core of our hearts of all listeners. And I wish everyone all the best for these 2 days of the conference. We are always there to assist you. I wish everyone a very great evening. Good night.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगल दायक जनक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे।
Thank you everyone for your patience and attention. Enjoy the rest of the evening and join us for the dinner.